get even one citation on this. So this is a focus group discussion on coffee table, focus group discussions on various aspects. We keep doing that. All of these seems to be our challenges. So if I have to kind of summarize it, it will be on three broad headings: patient caregiver challenges, provider challenges, and the government challenges. And Article 21 actually says that it's a government responsibility for health and liberty, but we are unable to maintain that to even the smallest of the extent, only limited years. If I were to do a study on this, I would do a prospective, multifaceted, mixed method, longitudinal study on the challenges in the country. And the outcome measures would be this: some surrogate and some hard endpoints in the PFSOS of the patient, quality of life of the patient, quality of life of the caregiver, and from the provider's perspective, it is a quality of life of the physician, the nurse, and the other healthcare workers, and the political mileage they can get from the government, and the budget affordability and the societal contribution. So the political mileage should have come under the government put up, but actually we must also look at the challenges of the physician and the health caregivers, which we do. So the best I could do was to do a PESEL and a SWOT on these challenges in the country. And PESEL is essentially looking at the external factors, and SWOT would be to look at the internal factors of the challenges of these three groups, what we are talking about. From the political point of view, there are no regulatory professional bodies to look at to do this. It is only no political bodies, it is only guidelines, and we are expected to do self-regulation as a professional body, and that's in most countries it is like, for a few where JC, accreditation is a must, which is not as of now in the country. So there is no quality control in the sense of what a physician does, and somebody is auditing that, was the treatment right? It's a self-regulated thing, and of course these are the meetings which will help educate is the right way we do now. From the economic perspective, we are looking at the equitable distribution. Equality is not possible, at least equitable distribution is what we need to attempt from the third point of view, third group which you are seeing. So it also provides a framework and the aims of maximizing the benefit with the available resources. So yesterday and today we discussed a lot on the financial constraints, which actually the major limiting factor than anything else. From the economic perspective, this is what the government has. Our GDP is 3 million. Total revenue generated is 30 trillion. Healthcare allocation is just 60,000 crores. Of that, about 30,000 comes under the NHM. And through that, certain things are done. So all we have in the government is only about 60,000 crores of rupees. And among these costs which we use, the union budget allocation of this 30 trillion, 1/4 actually goes to paying the interest from the loans we have taken over the past, which is about 30% to 40% of our entire GDP. Health is just 2 to 3%. Of that 3%, 50% comes from the government, 2%, 1.5% to 2% from the government, and rest is self-payment. So this is the budget allocation, or if a health expenditure is done, about 60% is from out-of-pocket expenditure. And the rest 35% comes from insurances. Of that insurances, only about 5% is private insurances. And that's where we need to probably look and see that can be improved. So that what means to say 95% of the country, if they are not government employees, they are not insured. This is the utilization of that 65,000 crores which the government gets. And rural health, National Health Mission gets about 30,000. Of that, 500 is now given for hemophilia, which is about 8% of the budget. Nothing set aside for transplant or cancer as of now, as I understand, but the budget goes through the union budget to the leading institutions, would be utilized in that aspect. If I look at the transplant costs and the inflations, if you look, a transplant cost us in 20 years ago, allogenic transplant cost us 10 lakh rupees. It is still 10 lakhs rupees, but if you look at the inflation rate of 10 lakh 20 years ago, 30 lakhs now. That's the value for money, future value of money if you look at it. So in other words, the cost of transplant has come down significantly, which is half the cost or 1/3 of the cost of what it was 20 years ago. And that is possibly because of the Indian market which is coming in for the drugs, which we do not have to actually import the drugs. And that has made a lot of difference in the way the cost of treatment has come down. So that's the backdrop of the things. I want to sustain these points there at the subsequent discussions and arguments. That's the comparison for India, China and USA of the out-of-pocket versus the government subsidies. In the US, when I pay some data here and there, I cannot say what percentage of the patients actually go to catastrophic. We are trying to capture that in our hospital. But two things happen: catastrophic funding and distress financing. These are the two major consequences when a patient undergoes a treatment. That they start borrowing. Of course, a patient who was rich or semi-rich or middle income, after the transplant he becomes poor. We assess him from what he has, not what is left behind. If we start assessing from what he has left behind, it is much more realistic than what you ask what you have now, because you may have 10 lakhs or the income generation, they say 8 lakhs and below only gets government funding in transplant in certain schemes. But what happens really is that after you utilize it, you're starting from ground zero. This is the menu card for our transplant, for myeloma treatments. For the first 4 months, this is the cost we incur. Look at DARA. We heard about DARA having an advantage. If I have to put all the data together, the DARA will give a median survival of about 1 to 2 years more than the other counterpart without DARA. But at the end of 5 years, we are talking about 10 to 15% or 20% to the extreme. One slide at 30%. So the question we are asking is it worth spending 25 lakhs or 20 lakhs more than the other drug, other regimen, for a 1 to 2 year median survival extent or a 15% advantage? So if we break it down to that patient and say that, is it worth 15% to pay 20 lakhs? That's the bottom line. So if I have to extend his life by 2 more years, each year he's going to spend 1 lakh more, each month. That's the question. We need to actually break it down at the root of it. We have now a different regimen's cost is taken, and we'll say that if you take this is the PFS, this is the OS, and if it is an out-of-pocket expenditure patient, he should choose that, depending upon his affordability. So that's the willingness to pay cut off at that particular person. From the sociological, societal point of view, the acceptance of risk in transplant is a problem, depending upon who has he been primed by prior to coming to you. And late donor deferrals in match unrelated donor transplant is depending upon who has he been primed by. From the Western literature, about 5% is the late donor deferrals in mud transplants. Here we are hitting at almost 30 to 40% on informal discussions, but it does not yet come out in the data. If I look at our own center, there will be about 10 to 15% late deferrals, which is after scheduling moving away. And it is, it is even more distressing if you start conditioning and it is moved away. And therefore, we had situations where we had changed our entire policy of freezing the product before we even start the conditioning. Technological, we are there almost. Diagnostics and storage, related issues can be outsourced now because the private players have come in. Patient care related, yes, of course, the ICU monitoring, ECMO, ECPs and CART are the limitations, I would say, if we were to ubiquitize and give everything to everybody. Legal issues, this is the advertisement in UK now. Not so far away before it reaches in the country, because there are eagles and vultures waiting for you to make a difference, a mistake. Look at the numbers of probable variables of errors you can commit during a transplant. So if you were to do a lean Six Sigma evaluation and say that, what is the defects per million opportunities during a transplant process, where these vultures can actually come and do a litigation, would be approximately 15,000. We did this exercise for medical audit for NABH. So there are about 23 parameters in medicine itself. If you give one medicine, there are 23 places in which you could go wrong. Could be more, but this is what is captured now. A transplant will have at least 10 to 20 medicines. Multiply that by 10 or 20. Then your decision-making processes, it has gone fast, it's gone slow. Because of this, the side effect happened, etc. So there are 15,000 defects per million opportunities. And if you were to do a Lean Six Sigma and say, I want to make it 3.4 per million, and you can know the accuracy which is required and the amount of work which it has to go to make it accurate. The environment of treatment is the next challenge. Whether you are in a teaching institution, the pressures are different. The administrative support will be the next issues which will come in. In a corporate setup, of course, when somebody is breathing down your neck to make the profit generated, there is a pressure involved in do or not to do certain procedures. Type of patients coming to your hospital, regions where you are practicing, whether north or the south, the belief system, the integrity quotient of that area also matters on the trust level they depute to a doctor. So some regions can be extremely litigant regions and others are not trusting. Professionalism among the allied health professionals is a huge problem. How do we tackle that problem? We may have all these conferences here, we know what is to do the best. But nurses, allied health professionals get 1/10 of such conferences in the country. Let's do a SWOT after the external. Let's do a SWOT in the country today. The strengths are that in the transplant point of view, we have ISBMT, which is an organized body. Though it is registered only 4 years ago, the gestation period was quite long, and it is more than 15 years now. There is a fantastic mission and vision in terms of establishing the best standards of care in the country. There is a data management group which is there, and there are conferences, and there are ISBMT webinars. Nurses are also being inducted into this. This is a fantastic movement where the nurses are coming into the ISBMT and in HCC. And there are other organizations like this Image and other societies and myeloma friend societies. All of these are breaking the strengths involved in what we have. What are our weaknesses? There is no regulatory influence in the transplant. It is only a guideline. Anybody can do a stem cell therapy today with an ICMR guideline. It's only a guideline. It has no regulatory or implementation authority there. You can't even, you can probably take it to court and say, then the judge will decide what is to be done. No centralized planning for the number of trained transplanters and support staff. So there is no governmental body looking at what's the need and therefore we must do this. There is no resource planning for stem cell transplant, and the current entrance policies today in the NEET which is coming up, which can be a detriment to the way medical oncology or clinical hematology is chosen by a person who is not even interested in the field. What are the threats we have before we go to the opportunities? Poor delivery of quality. There is no quality check in the way we are doing today. The high litigation risk, therefore. Lack of transplant data operators and research scientists. This is a huge problem. We talk about data. To me, the most difficult part than treating a patient is to put the data into that spreadsheet cell. To me, that's the biggest challenge. To get the right person to do that. You don't have the time. You're running 16 hours, 18 hours a day as a hematologist. Honestly, most of us do that. And we do polypractice on all the subjects. Few more slides. There is a mismatch between the transplant physician and the transplant nurses and the allied healthcare workers. For every one transplanter, you need at least 5 to 6 or 10 nurses trained in the same field to understand the language. We don't have that. These are the shortfall of Indian nurses today, and UAE and UK are offering 10 to 15 times the salary. We are standing to lose there. The attrition rates are doubling by the year today. And there's no hard data, but few hospitals I know for sure. In our hospital, attrition is doubled in the last 1 year. The Brexit has contributed significantly to that. This is the data from the US and UK. So what is going to happen is our nurses are migrate to these places and we won't have many people staying back. There is a brain of doctor migration, and there is entrance exam policies, inspection guidelines, and the process which are being done. The inspection guidelines are so stringent for the numbers, you can't even get that many professors. Where do you get those professors? And on the rule you say you may have so many professors to train, you cannot get them. Unmonitored transplant programs, and this is from the US. As the need of organ transplant goes, the transplant physicians are dwindling because the quality of life is extremely poor if you were to do HRQL on the doctors. But there are opportunities. This is from the data which was published about 13 years ago by Gratwal on the number of transplant across the world. India stands somewhere in the 1 to 49, where a developed country 300 transplants per 10 million is the now number may have gone up. What is our numbers here? We are doing 2,000 transplants per annum, and that's come to about 15 per 10 million. US is 300 plus, so we are 20 times behind there. Let's look at the number of transplants. If we were to do that level, we would do 39,000 transplants per annum, and right now we do 2,000. If Indian Union budget were to put the budget for this 39,000 transplant, it will be 3 times the entire revenue generated for the budget. So this will become 3 times the entire health budget if you allocate for transplant, then only we can reach that, to show that it is such a far away proposition. Health expenditure in India is about 3%, USA is 16%, world is 9.3%. Government expenditure is just $63 per person per annum, compared to US $10,000. The GDP of US is $70,000 per capita, where we are at 20, that is 35 times more. But look at the healthcare budget proposition is even much starking. Out-of-pocket expenditure is extremely high as compared to this. For a transplant team, you ideally need this number of groups. 2 more slides. And we can't reach anywhere there. And that's the number of transplant density of doctors, 0.08. When to achieve this for our country, we need about 1,200% increase. That is the only way we will reach there in terms of the transplant team density to be required. So that's the distribution from the different zones. That's the number of transplant centers from different zones in the country today. And that's where we stand in terms of the team density requirement and what we have. And if you were to do a comparison on what should be in each zone, so say a central zone has 20, it requires 400 transplant units if we were to do a centralized planning. And we do not have that. The opportunities are huge. We do train about 70 clinical hematologists per annum, which would take us 35 years more to reach there, to reach a transplant center. With the medical oncologists coming in about 200 more per annum, obviously that years may come down to 10 years. Opportunity for advocacy and lobbying, creating guidelines, collaboration with accreditation bodies, creating benchmarks, and consider transplant as a vocation. Nothing else we can do that. We cannot cooperate with money there. Money is not going to substitute this. Transplant is challenging, it is exciting, and it is a combination of Sherlock Holmes and James Bond, I would say, and the sun is rising in transplant. Thank you very much.
Thank you, Dr. Joseph, for a brilliant presentation on such a challenging topic.
Thank you.
I think we'll just have 2 questions or comments, because we need to have some discussion on this topic. So any quick, Dr. Dinesh.
It's an excellent talk, but I don't think the problem is the cost and this. I think the willingness is the problem. Every time the new drugs comes in, we say the transplant is required or not. And this confusion of the Western word of early transplant and delayed has harmed India more than anything else. I think we should have our own discussions of India where,
sure.
If the 100 people go from here, how many will have a delayed transplant versus how many will have early transplant, and then they have a progression-free survival or overall survival. Not comparing the people who got the transplant. So I think the message is not clear. Every time we want to know the transplant is not required, and the patient wants to hear, the patient likes a doctor who says this transplant is not required. So there are a few factors. I mean, the cost is one of the factors. I think transplant is cheaper here. If you see, you showed that data. But the problem is not that. Problem is the willingness and the clear guidelines.
So another big problem in our country is the hypocrisy, I would say. We all agree to the fact that transplant is any day cost effective. Monoclonals as of date, as was already brought up by Dr. Vincent today, and also in the the General Club that we did, is not for the Indian scenario, for the upfront setting as on date. All of us agree in public forums, in academic forums, but when we want to write it, when we want to put it up in the journal, people don't accept. We did 2 large studies and simulation models of 50,000 patients based on the real-time data of the India from the image data set and sent it for publication. 32 journals rejected it, saying that this is not okay. They bring some of the other reasons for it, but it never gets published. So I think we, as also brought up by Dr. Dinesh Burani, as a group, as an image, we need to bring out the things specific to India, our own guidelines, and where we stand as far as the cost effectiveness of the therapy for myeloma is concerned. I think that's a burning issue and it needs to be addressed ASAP by this society with the help of our international fraternity.
Yes, Dr. Rajkumar.
So one of the, in follow-up to that, from what he says, even if there is a willingness, and even if cost is okay, you simply don't have the physicians. You need 2,500 transplanters and you have 200. So only the number of transplants will increase, but it's, even if all of you agreed that's the way to go, but only by a small amount. I'm like struggling after your presentation because the situation is much different than I thought. It's not just about costs, it's also about resources in terms of physician, nursing, staffing, availability of trained personnel to do stuff.
To me, it would go parallel. The training processes, once the funding is available, willingness available, the training will come in when there is opportunities. And that is something which we need to be cognizant of. And training the nurses, I would say, is a huge important aspect if we want to keep pace up with this. Because doctors have the first world knowledge to have, and the third world facility and the expertise of the support staff. That's the issue. That's to me, that's the problem.
A last one. Just in relation to what was said by both of you, the fact is one more. The thing is, actually speaking, it's good to do calculations, math, statistics, simulations, but also simultaneously we need to answer how many of the transplant centers in the country have a huge waiting list. There are many transplant centers which are actually lying vacant. Now we understand a corporate versus a public divide in our country, wherein the public institutes like premier institutes like PGI, AIIMS, they have waiting list going up to 1 to 1.5 years, whereas we have institutes in the private setup or in a semi-private setup where they actually have transplant bloods lying vacant. What is more importantly required is advocacy. We take the example from hemophilia, from our own hematology thing. The percentage of the health budget which is allocated for hemophilia care in the country versus transplant in the country. Now see the number of patients getting benefited with that much of budget for the number of population. Per person, per budget, if we do the calculations, and the number of people who will get benefited by the government providing support for the transplant even in a corporate setting, certain amount, certain percentage, if it can be shared by the government, it will actually help in a huge way when compared to by putting it in other places. So advocacy in our country is very important, and as a group that's the second thing that is required that we need to do.
Dr. Munshi wanted to make a comment.
Yeah, a quick question. It's sort of a follow-up to Uday's comment about what proportion of population has excess ability, desire to get transplant versus what does not. And I'm guessing it will be 95% does not and 5% probably, or maybe more. So if it comes to healthcare resource allocation, the question ends up being, are you worried about in the US cost of Revlimid versus cost of insulin, where it will save thousands of lives? In the same context, where should the money go? The rural versus urban population, etc. So what would the thought?
So the way I would answer that question is, sir, is low income, middle income, high income, and upper middle class, lower middle class, that kind of classification. So upper middle class and high income would be the people who can really afford it. That would be about 15%. So that's where we need to go. So 2,500 is the ideal. We are sitting at 0.08 transplant centers. Even if there is a marginal increase, that is good enough. So we don't require that 2,500 now. I mean, see, 10 years ago when I passed out, or 15 years ago when I passed out, there were 6 people passing out from the country. 15 years down the line, there are 70 people passing out in the country. So there is a difference there happening. So it's a gradual progress. The awareness, government allocation of funding and insurances coming in, Ayushman, yesterday we heard, all those are going to boost this economy and the resource training processes happening.
What did you mean when you said the NEET exam is now turning
Yeah,
out
so
oncologists
unlike
to
in
do
the
what you-
unlike in the previous years where you could choose the subject of your choice and you take the exam of that subject specific entrance. So now it's after MD you take a general MD exam, and based on your rank you can choose whether you get cardiology or hematology or medical oncology or whatever. So I may be having a lower rank, but I'm not interested in medical oncology, but because I could not get cardiology, now I take up medical oncology. Now that's a big problem then. So he is dreaming heart, but he is seeing cancer.
So I think
Okay.
we need a 30 minutes slot for follow-up discussion for this very thought-provoking topic by Dr. Joseph John, but as of now we wind up the discussion for this topic. Over to Dr. Govind.
So let's go on to the next topic. This is going to be Indian data, modification of myeloma conditioning, TMH data by Dr. Bhav Sahab. Dr. Bhav Sahab is a professor in the Department of Medical Oncology at the Tata Memorial Hospital, Mumbai. Dr. Bhav.
Thank you, chairpersons, and thank you, Image, for this opportunity. I think it's difficult to follow Dr. Joseph's talk, and I will maybe try and do justice to 10 minutes to given to me with some of our data. So as Dr. Dinesh said, I think we need to emphasize that transplant remains an integral part of myeloma management, and especially true in Indian setup, given the cost very elaborately discussed previously. And we face some issues like stem cell mobilization, etc. And I'm going to cover two parts of our experience to share with you. So one is mobilization. So this data pertains to before Plexafir became available in generic form in our center, and we did some tweaking there. And next is PET CT for response assessment, again in the setting of MRD being not available at our center there. So in the first part, the GCSF remains the backbone for mobilization, but our center used to use chemo mobilization for getting adequate stem cells, and failure 5 to 30%, very difficult thing, but uncommon, but really a thing which we think of. And we try and do something like 2011-12, I think we went behind drug like meloxicam, etc. to see if it can mobilize. And there is a good data from CMC Velo that it could increase your yield by maybe 0.51 million cells. And we tried this. But after this, we started using bortezomib, and the rationale explained here. So I will skip the actions of GCSF and Plexafir work. But how bortezomib works is it breaks one of the axis, VCAM BLA4, and this has been very elegantly shown in this mouse model study and also the human study by the US colleague. And a paper where they used bortezomib for non-responding patient, and what they showed was the CD34 yield was very good. So based on this rationale, we started using bortezomib in mobilization for our patient, and basically we looked at our previous mobilization with cyclophosphamide and we compared this data. So this is the regimen where you use 4 doses of bortezomib. Bortezomib being generic is very cheap, and this will cost you additional 4,000, 5,000 rupees, and you have your own backbone of cyclophosphamide GCSF. And this were the, so our goal was to correct 5 million cells to aim of doing at least 2 transplant, and these were the methods. So these are the routine transplant characteristics of fairly young patient population, 46 years. I guess this is true for many of our centers, and the median lines of therapy were 2. So definitely most of our patient comes after they have received first line therapy. So these were the 2 groups. 37 patients received this bortezomib based mobilization, and remaining were cyclophosphamide mobilizations, and these were the previous treatment characteristic. So what we saw in this is the stem cell yield is roughly 1 million more if you use this 4 doses of bortezomib. But important is the number of days of apheresis session required came down from 2 to 1, the median. So it's so as to make it short, if you treat 6 patients with this mobilization, 1 patient you will be able to say 1 mobilization session, which is quite a bit of cost in our setup in most of the centers. I will not go into detail about this because my colleague Sumit is going to look at our all mobilization data. He has done quite a bit of hard work and a very elegant analysis. So we have moved on from this mobilization strategy, and he will show you this tomorrow in his oral presentation. So we looked at our PFS in this cohort, so median of 3.5 years PFS and overall survival of 8.5 years. So I think very good data going by what happens in our country. We looked at whether this bortezomib 4 doses affected the outcome of PFS and overall survival in this cohort, but it was not difference. I think very difficult to ask for 4 doses to change the OS PFS during formulation. So what we concluded as bortezomib helps in mobilization, numbers are very small. Definitely you could consider this, but it is something which we can continue. So this was our one experience which I wanted to share. Moving on, all of us are aware about the response dynamics and its prognostic implications. We don't have access to MRD, and what we started doing in early part of 2011-12 was doing PET scan of every patient before stem cell transplant and see if this has any prognostic implication. And in first few patients only we realized someone who is coming on with a PET positivity doesn't do well, so we started doing it prospectively. So what we did was we looked at the serological responses, CR, VGPR versus lesser than that, and also PET scan positivity versus negativity. We didn't have those elaborate impetus criteria and also the issue with reporting. So we simply took something which is having FDG avid lesion as active PET CT or positive PET CT, and someone with not having activity as negative PET CT, and we looked at their PFS. So this was the characteristic of this cohort. So 131 patient total in this, and roughly 40% were high risk ISS 3 cytogenetics, and what we could see is roughly around 25% of the patient were less than VGPR, so PR or progressive disease. So if you use this, 75% of the people will fall into a good subgroup which has achieved CR or VGPR before stem cell transplant. But if you look at PET scan, almost 34% of these people were positive in the PET scan. So definitely you are catching some patient who are high risk because they didn't respond serologically, and also some patient who are PET positivity. And when you combine this in terms of interdigitating, what you see is we come across 4 groups, and there you are coming with intermediate groups like group 2 and group 3, where you are high risk because you are not achieving CR, VGPR, or either you are PET positivity, and significant number. So 35% of the people were either in this group because they were not achieving the responses. So we had a group 1, the best, both were negative, 51%. We have group 4, which is 14%, where you are less than VGPR and also your PET positivity. And we have intermediate group 2 and group 3 with either positivity. And if you look at their PFS, so the group 1, both negative, PFS is not reached. And for group 4, where you have both the positive, your PFS is little more than 1 year, so very bad subgroup. And in between group 2 and group 3, you have around 2.5 years of progression-free survival. So definitely you are able to carve out a new subgroup of patients who are in between or in having intermediate prognosis, and also for people who are going to do worse or who going to do best. So this is graphically shown here. The best topmost curve is significant proportion of patient, and this is all before stem cell transplantation. So this is sensitivity to your induction chemotherapy, speaking about the initial sensitivity. After this, we have started doing at bone marrow MRD also, and we will have that data sometime in the future. So it looks that pre-transplant chemosensitivity and PET avidity serological responses can be used to having this granular response assessment, and which can help you to predict the outcomes in this setting. So this is all I had to say. I would like to thank my patient families, my colleagues in transplant unit, and all of you for hearing. Thank you.
Thank you, Bhav Sahib, for showing us that interesting data. We'll go on to the next talk.
Thank you.
Thank you for saving some time too. Next I invite Dr. Stalin Bala Chaudhary from Hyderabad. He is going to share with us Indian transplant data, NIMS, Hyderabad. Dr. Stalin is a hemato-oncologist and BMT physician, Associate Professor, Department of Medical Oncology, NIMS, Hyderabad. So over to you, Dr. Stalin.
Yeah, thank you, madam. Thank you for the introduction. Good morning to all, and thank you organizers for giving this opportunity to present the data. And this will be a continuation of the talk by Dr. Joseph John. So how can, in fact, the support from the state government can improve the transplant rates at an institute. So my focus will be on that along with the transplant outcomes. So we all know that autologous stem cell transplantation has significantly become a key component of the multiple myeloma treatment in eligible patients, and it has been incorporated as a part of initial treatment or delayed until response, and it was initially introduced in the 80s, and from 90s it has become the standard of care. Although it is not curative, it delays the progression with manageable short-term toxicities and low treatment-related mortality, and several randomized trials have performed comparing chemotherapy like this had shown that there is significant progression-free survival benefit, although the overall survival benefit was inconsistent. So there was a lot of discussion about the early versus delayed transplant, but at least in high-risk population it was shown that early transplant is the way to go. We can delay the transplant in standard risk patients. So this is the current algorithm for the management of patients with myeloma, already discussed, and the main objective of this study is to see the outcomes of the myeloma patients with autologous stem cell transplantation at our institute, and how can we improve the transplant rate if we get a support from the state health program. So this is a retrospective single center study at Nizam's Institute of Medical Sciences, Hyderabad, and all myeloma patients who underwent autologous stem cell transplantation from 2010 to 2022 were analyzed. So these are the results. So a total of 92 transplants were done during this period. So from 2010 to 2016, when the patients are to be paid from their pocket for the transplants, only 15.5% of the transplant eligible patients underwent transplant. Whereas, so we convinced the government that with their support we can do transplants, and the government has agreed, at least for the government hospitals like Nizam's Institute of Medical Sciences and another government center, they can support, and the transplant can be done at a free of cost. From 2017, we are doing it free of cost for the patients under the state health program, and the transplant rate has been significantly increased to 50%, and in the last 2 years almost 80% of the transplant eligible patients at our institute are getting transplantation done. So these are the outcomes. The 92 patients from 2010 to 2022 with a median age of 50 years, and majority were males with 63%, and majority had bone pains at presentation. These are the CRAB criteria with a median hemoglobin of 9.4 gram per deciliter and calcium of 9.1. So 25% of patients had a renal failure, that is creatinine more than 2 milligram per deciliter at presentation, and almost 70% of the patient had bone lesions at presentation. So from the last 3 years, we have moved from the conventional radiographs to the PET CT scan, and almost always in all patients we are getting now PET scan as a part of initial bone workup for this myeloma patients. So the median bone marrow plasma cells were 60, and the most common paraprotein was the IgG kappa, which was seen in almost 58% of the patients, followed by IgG lambda. So the cytogenetics were available in 42 patients, and the most common abnormality is T414, which is seen in 20% of patients, followed by deletion 13q, and 14% had a deletion 17p, and majority of the patients had a ISS stage 3. Because of the non-availability of the cytogenetics, we have not looked after the RISS staging. So the treatment received, the most common regimen is VRD 50%, and this is also because of the state government support. In the last 3 years, after the incorporation of the VRD, VCD into the Ayushman Bharat, and which has been incorporated into the state health scheme, we are giving VRD at free of cost to majority of our patients, and all the patients who are eligible to take VRD are receiving VRD at our institute. And the second most common, because of the renal failure or some other reasons, is the VCD used. And before the 2013-14, some patients have received doublets like VD, thalidomide dexa, and lenalidomide dexamethasone, and the median number of cycles before the transplantation were 4. So majority of the patient had a VGPR before transplant, followed by CR and stringent CR, and this is the transplant procedure. The majority of the patients, almost always, because the VRD is the common regimen used, and to get a good amount of yield, so we use plerixafor in majority of our patients. The 62% of patients receive plerixafor, and we had a generic plerixafor available, and which is at a reasonable cost, and which is also included in the transplant amount the government is allocating to us. So not to have to get a good yield, we are using plerixafor in majority of our patients, and majority of the patients, almost 3/4 receive the MEL 200 and only 25% because of the renal failure or some other comorbidities received the MEL 140 dose. The median stem cell dose we had given was 6.2, and the time to engraftment was almost 8 to 10 days, and the number of days in admission was 17, and of the 92 we had no in-hospital mortality, and majority of the patients are discharged by day 18 or 20, and 100-day mortality, one patient succumbed to a viral pneumonia at day 92 and succumbed to the disease. The post-transplant response evaluation, the majority had a VGPR followed by complete response and stringent CR. So this is the maintenance received, and this also has been recently included into the state health program. So majority of the patients are able to receive either lenalidomide or bortezomib maintenance as free of cost to our patients, and majority of the patients were treated with lenalidomide followed by bortezomib. And recently, after the data, we have been using the doublet maintenance, the bortezomib lenalidomide in all high-risk patients. These are the outcomes. The median follow-up was 36 months, and the median progression-free survival was almost 4 years, and the overall survival was 65.2% at a median follow-up of 36 months, and 60 patients are still alive and are in regular follow-up and receiving the maintenance therapy, which was comparable with all the remaining data from the remaining centers of median progression-free survival of around 4 to 5 years. So to conclude, the inclusion of the transplant in a state health scheme, where if you can offer it to a free of cost to the patients, we can convince many patients to undergo transplant, and it can significantly increase the transplant rates and impact outcomes in myeloma patients. And we know that in a country like India, where the DARA is costly and where all the newer modalities of therapy are not available to patients, and autologous stem cell transplantation is the best way to deepen responses and improve survivals in myeloma. And in a resource limited country where majority of newer therapies are not available or unaffordable, and challenges of doing a delayed transplant, so like there are no, we can't cryopreserve the stem cells, and majority of the patients can be lost to follow-up at relapse, and there is a lot of hiccups in doing a delayed transplant. And in a country like us, where so many challenges are there in doing a delayed transplant, early transplant is the best way to maximize in myeloma patient, irrespective of the risk stratification, is what we feel. Thank you. This is at the Indian Myeloma Congress 2020, where we have actually given to the media that we are doing the bone marrow transplantation at free of cost at our center. Thank you.
Thank you, Dr. Stalin, for sharing your data. We'll have comments and questions after the next presentation.
Thank you, madam.
So the next is going to be Indian data post-transplant maintenance by Dr. Ankur Ahuja from Delhi. So Dr. Ankur is Associate Professor, Pathology and Hematopathology at the Armed Forces Medical College, Pune. Over to you, Dr. Ankur.
Thank you, Chairpersons. Thank you, organizers, for giving me an opportunity to present the data on the behalf of our team. We start with the research data and presenting the data on Indian multi-center phase 2 randomized study, which compared the post-stem cell therapy, transplant, bortezomib, consolidation, maintenance regimens for the newly diagnosed multiple myeloma cases. So the funding was from our directorate officer, and external vetting was done by our research committee, and all approvals were taken. I disclosed no any financial disclosures, no conflict of interest. So the background of the study is there is a proven role of a consolidation maintenance post-autologous stem cell transplantation in multiple myeloma. The overall survival, though, has not been found any significance, but the progression-free survival has, in some of the studies, have been found a significant role. So why this PFS, that is progression-free survival, is important, especially in a country like ours, because of varied reasons. Patients' reservation for prolonged therapy post-autologous stem cell transplantation, the poor compliance to therapy, the affordability and availability of the second-line drugs or second transplant, and the increased usage of generic drugs. So starting with the methodology, there were 6 tertiary centers from our armed forces which participated in the study. So it was a prospective multi-center intervention study open label with a sequential assignment, and the study period was from June 2016 to December 2021. So in this study, there was a regular visit to the of a patient to OPD for first one month, and because of the COVID scenario also, some patient didn't turned up, so we did the telephonic calls, and we entered the data in the Care for Myeloma software, and all patients were being geotagged. The inclusion criteria was the diagnosis of multiple myeloma undergoing stem cell transplantation, more than 21 years of age, both genders were included. Among the exclusion criteria, the patient who were unwilling for 6 monthly PET scan data, and inability to get 6 monthly biochemical and clinical evaluation done, and patient who lost to follow up for more than 3 months. So the definitions of PFS and OS were as per the International Myeloma Working Group definitions. So the aim of the study was to compare the efficacy and safety in different post-stem cell transplantation maintenance regimes in patients with newly diagnosed multiple myeloma. And the objective was very clear to compare PFS and OS among arms, and to describe the adverse event profile of each arm. So after stem cell transplantations, we went into the 4 methodologies, and that is flow cytometry, PET scan, serum protein electrophoresis, serum immune fixation, and the clinical relapse. So we randomized the data into 4 different arms as far as the treatment modalities are concerned, and they were being followed every 6 monthly with the 4 investigations. And the terminal event is when the disease progressed, or patient died, or there was a toxicity event. So these experimental arms, which arm A comprised of bortezomib, in which patient received bortezomib subcutaneously on day 1 and day 15, and arm B comprised of bortezomib, cyclophosphamide, dexamethasone. The cyclophosphamide and dexamethasone were given perorally on days 1 and 13. Arm C comprised of bortezomib, lenalidomide, and lenalidomide was given perorally on day 1 to 21. And the arm D comprised without bortezomib, that is only single drug lenalidomide, and which was being given perorally from days 120 to 21. So in all arms, treatment was given for 28 days for 24 courses in the absence of the event, that is disease progression or any death. After completion of the study treatment, patients were followed up for every 6 months for 3 years. So the MRD techniques which were being used were PET-CT, multiflow cytometry. The comparison of these will be done by Kanparmanik sir in the afternoon session. So PET-CT scan was as per the Italian myeloma criteria of scoring, in which DLL3 score was considered to be positive. 2 readers interpreted the reports with a coefficient of variation of 1.2%, and in the flow cytometry, we used the Beckman 10 color flow cytometry. Single reader was there, and all reports were counter-checked by the company technical and scientists who confirmed the accuracy. So the statistical analysis using the JMP version 15, results were shown as mean plus minus SD, and the p-value of 0.05 was accepted as significant. The survival analysis was done by the Kaplan-Meier analysis. So these were the results. We had a total number of 163 patients, out of which only 137 patients were being included as an inclusion criteria, rest other was being excluded as we had 45 patients who were excluded because of various reasons, mainly because of the COVID factor and the withdrawal of consent. So in our data, males predominated with 2 females with a 2:1 ratio, with a median age of 54.5 years. The right side diagram shows the comparison of the various arms. So coming to the efficacy, the overall survival, 2-year overall survival was 86.31%, while the 3-year overall survival was 73.62%. However, there were no significant, there was no significance in the overall survival in any of the arms. Among the clinical PFS, the 2-year PFS was 75.64%, the 3-year PFS was 64.93%, and in this also, in the clinical PFS, we didn't find any significant association in any of the arms. In the biochemical PFS, the 2-year PFS was 71%, 3-year PFS was 69%, and in this also there was no significant activity was noted. However, in the imaging PFS, which had the two interesting findings, one that the 2-year PFS and 3-year PFS had a comparison lower value than the other PFS. The 2-year PFS was 65% and 3-year PFS was 58%. And in this, the arm D, that is which comprised of lenalidomide only, had a lower PFS in comparison to the significant lower PFS in comparison to the other arms. The MADI by MFC again had a 2-year PFS of 71%, 3-year PFS of 69%, and in this also there was no significance was noted. Coming to the adverse events, if you come to the discuss the mortality, there was no significance in any of the arms as far as mortality is concerned. However, in the serious adverse events, the arm D had a serious adverse event in comparison to the other arms. So in that, neutropenia predominated the finding. However, there were no non-serious adverse events and there was no significance in that data. So concluding, there was no significant difference in the overall survival or clinical PFS between the different maintenance regimes. Lenalidomide only therapy which was lacking the bortezomib had a significantly inferior imaging PFS, probably because of the poor tolerability and higher adverse events. Thank you. I'm grateful to all patients, to our director and to our technicians who actually, without whom support, we couldn't able to do the study. Thank you.
Thank you very much, Dr. Ankur. I think we can have a few questions in the last three presentations, if there are any. Yeah, Dr. Hemant.
I'd like to ask Dr. Bausa, which is audible? Yeah. So my question is to Dr. Bausa, with your modified pre-stem cell collection regime, did you still have to use Plexifor, or it was like a substitute for Plexifor?
So we used Plerixafor as a rescue when the previous day CD34 was less than 20. So it was as per the clinical situation, sir. And I didn't show it, but the Plerixafor use in this bortezomib cohort was numerically less as compared to chemo cohort, but numbers are too few, sir.
And if you do a cost analysis between the innovative regime and Plerixafor, like how much of the saving do you make?
Sir, I think it will still be cheaper because bortezomib would be like 1,000 rupees per dose. My feeling is we need to refine this regimen because the timings etc. are also very important. The peak is after LNR, so logistics also need to be taken care of. And now with the ease of GCSF and Plerixafor, in fact in our center we are not following this regimen. But I just showed how in that period when Plerixafor was not generic, how did we do it, sir?
One question, Dr. Bausa. So this bortezomib action is specific for myeloma related transplant, or is it generic, applicable to say lymphoma or other mobilization strategies as well?
Yeah, so based on the mechanism it should be generic, and looking at that my study paper, it is not as potent as Plerixafor, but it is, I will put it as in between Plerixafor and lesser than that.
Yeah.
So in Bausa sir, according to your study, if we have PR or PET positivity, the outcome is very poor. So now even if you achieve PR, you go on giving more induction cycle to achieve the CR and then do the transplant. Have you changed that?
So during that period and even now we don't change it, as we know that whether the changing improves outcome, we don't know as of now. But definitely this helps you in taking the decision because this person has not achieved remission. It will help you to guide your further treatment.
Morning. Good morning, sir. I am Dr. Sadashiv. Regarding this presentation by Dr. Stalin, sir, I think this 15 years ago, the first state to incorporate health care or health insurance policy in India is by Telangana or Andhra Pradesh state. Since then, they are updating their protocols and regimens. They have included almost most of the chemotherapy regimens. And with this, but as Joseph sir mentioned clearly that I think we need something education of policymaker, including politicians and bureaucrats. It's the most important step actually what you have mentioned. Yes, I think we could convince our policymakers by explaining the importance of this transplant, induction regimen and maintenance therapy. So when multiple consultations were over and they included not only the stem cell transplant, they included heart transplantation, kidney transplantation, liver transplantation, and including state insurance policy. Now they are able to get this transplant at free of cost, including this maintenance immunosuppressive therapy also. So I think with the multifocal, as sir mentioned, I think next one is again the infrastructure development. Initially we used to have only 2 rooms, now we have the 8 clean rooms with the guidance of ma'am and Chendi, I think everybody they suggested. And we have some 8 clean rooms now we have, and good faculty and infrastructure. With that, I think we are able to do more transplants and we can offer. But ultimately, what we said is a financial issue that can be taken care of by the state. I think now we are able to do more transplant. I think we can, now Ayushman Bharat also, I think yesterday we had discussion, they included same policy into most of the states. I think definitely we can, in the future we can do more transplant. Ultimately, they should get the stand of care.
Thank you, Dr. Sadashiv, for that initiative. Maybe from Image we should have a session where we can get those people and actually educate them to do this.
So just to add on to that, if you take the hemophilia process, how it happened is that we had 1.5 days of session only for the decision makers, policy makers.
Yeah.
And that has gone on for many years to actually make this NHM get happen. And then came public interest litigations.
Correct.
And therefore those 2 things actually added.
I think patient advocacy is also very important. Yeah, I think Uday has something.
One key point which sir missed in the hemophilia thing is the pharma driven thing. There's a huge pharma angle to the factors and the recombinant factors.
So obviously
so you have to include them, because when, when you do the advocacy
Absolutely.
with the patient group, you have a strong patient group support.
Yes.
You have to include the pharma.
Correct.
And you have to include the policymakers and then educate them. And that's how it's been possible, and it's almost taken 15-18 years for that to happen. Like from road shows to dharnas to, sitting in a 5-star hotel to include all these people. It has taken 15-20 years to lobby.
I remember, Cecil, all the extra efforts you put in here. Thank you.
Yeah, and I can second what Dr. Sadashiv just said. The Rajasthan government has also now covered auto and allo transplants in their state insurance cards, and this has led to a significant increase in accrual of patients, particularly in the private sector.
Yeah, sadly each state has different clones, some are more resistant, so but I think if everybody can come together, it will benefit everybody. Thank you. So if there are no more questions, comments, let's move on to the next session. This is going to be a panel discussion, and this is transplant and post-transplant maintenance in myeloma, and the moderator is going to be Dr. Gaurav Prakash from Chandigarh.
I'll make it.
Thank you, chairpersons and the Image Group, for this opportunity, and it's my pleasure to now invite the panelists, Dr. Mirza Salim, Dr. Natraj from Bengaluru. We have Dr. Sanjeev Yadav, everybody knows him, Dr. Dinesh Bhurani, Dr. Mallikarjun Kalshetty, and Dr. Ganesh Jeteshwar. Please come on the stage. How are we going to do it? Okay, all right, you can see that. All right, so I think we have a great panel to discuss about myeloma. We can discuss anything about myeloma because there are so many there is a large room for discussion on various aspects. Before we go on discussion, we all will agree, for patient with newly diagnosed multiple myeloma, the scheme is very much simple. You induce them, you use doublet, triplet, quadruplet according to the scenario we are in. There is no doubt about it. The action is, the aim of this action is to have direct anti-tumor activity and myeloma cell kill. It should be followed by a consolidation transplant, almost largely agreed upon because there is large body of data and we have been hearing about it this morning as well as yesterday probably. The idea is to cover for resistant clone because we believe that high dose therapy melphalan is going to cover for any resistant clone which is left behind. The success achieved with consolidation will be followed with maintenance therapy, which is going to be the main part of the discussion today. And the idea of maintenance is to modulate the microenvironment of the tumor. Now, for all of these three steps, we have good amount of data, large body of data, but majority of this data is Western data. And for us, it is subject to interpretation. So I would like to learn from the panelists today how to interpret the same data in Indian light. Okay, so starting with the most practical issue regarding transplant, which is age. So how to go about it, I think we can begin from either side. So let's start from the senior person. Sir, do you think that age in Indian context, you know, we see that Europe and America keep, discussing that 65, 70. Americans do not believe in that. So what do we believe?
I think the age, we need to see the comorbidities and fitness also.
Yeah, my
so most of the people below 65 should have all the patients with the below 65 should have a transplant. Above 65 to 70, we have to correlate with the comorbidities and fitness. Probably above 70, very few will be.
I would rephrase for the larger interest. Do you, in your practice, do you have a cutoff at which you stop discussing transplant, or is it a fluid state, like you are more American or more European?
70.
70. So next, Sanjeev.
Yes, of course, age is important, and we don't offer transplant if patient is more than 70 years.
More than 70, okay.
I think
Okay, so I think we are in a state of flux. So fitness is something which is important. All of us agree. But I think 70, so do you have this cutoff? Like somebody is more than 70, like I'll tell you my practice. If somebody is definitely more than 70, probably I will be skeptical in kind of considering a standard first line transplant for those patients. I may not offer also, unless, you know, I'm very much convinced of the fitness. So do you practice that cutoff in India?
Very rarely, extremely rarely.
I'm glad to know that.
Patient, I think
is more important is to strongly consider transplant below 65.
Below 65.
What is happening? We are not considering transplant even in the below 65.
Below 65.
We are discussing 65 above 65. We can discuss it, but strongly recommending for the below 65.
So can I go to Dr. Salim with the second question? Like somebody says around peri 65. What are the factors do you consider? Like it's like just PS, you have some scoring, you have some parameters, some values, kidney dysfunction. Do you have any algorithm for that?
For transplant, we have the CCI, we have the Charlson Comorbidity Index, and in, IMWG has come up with the frailty score. So where you have clearly can divide within the fit, intermediate, and frail. So in the fit patients, we can think of on a case-to-case basis. Can we go for transplant? Most of the centers we use 65 as our baseline. Even in R&R, like we use in AIMS also when we were doing transplant, 65 was our cutoff. 65.
So let me ask a more incisive question. What is the oldest patient you have transplanted?
No, frankly speaking, I have not transplanted any patient more than 65.
Okay. Other panelists? 71.
68 years.
68.
68 years. So
I think we are walking the talk, and people are transplanting patients 68. I think the oldest at PGI, sir, will correct me. I think we have transplanted somebody with 70, but it is an exception rather than the norm at PGI. 65 is something which we are comfortable with, but more than that, we are very, very pragmatic. So the next question is, does renal insufficiency plays any part in decision making of transplant? So let's put us some light on this, panelists, like starting from sir again.
We should have a renal data just prior to the transplant. So you
Right.
shouldn't have a GFR before the transplant. It will affect your dose or the melphalan,
Melphalan.
not the decision to go for the transplant.
So I agree with that, and we practice that the very much same. So, there is a recent data that melphalan can be given safely because the mechanism of elimination is autolysis. It is not kind of eliminated by kidney. So, but still we see that people reduce the dose. So is it a part of a practice and understanding that patient who are having creatinine high, they will be having a poor tolerance, so we reduce it, or you are really concerned of the toxicity with 200?
We have not changed the practice yet, so I think we need to learn,
Right.
even if you're with the renal failure, how to do a transplant.
Right, so this is some data, and this is from two large retrospective trial in which they have said that if you adjust for PS, stage of myeloma and comorbidities of other kind, the patient who were more than 65 and who underwent transplant, they had prolonged survival compared to those who did not. And the second data is also published not very recently but 2016, and is a single center data. Patient more than 70 who received transplant, the outcome were comparable to those seen in younger individuals. So that means transplant is working fabulously if it can be delivered. The question, quote unquote, is if it can be delivered safely in that context of the country where it is being practiced. Now the issues. This is the holy grail, the data which shows the TRM, and this is, let me tell you, Western data. More than 70, the TRM day 100 is around 2.5%. If you go a stage back, it drops by 50%, only 1.2%. Younger individual, we all agree, it is less than 1%. Anybody can say in Indian context, this figure is going to be more than 5%. There is a paper from Dr. Lalit, which I shall discuss. So now seeing this data, are we convinced that should we go ahead in patients who are more than 70 and fit with transplant, or still there can be a room for, in the light of drugs we have, upcoming drugs?
I think more emphasis I will put it, all the patients below 65 should get a transplant. Our message is not clear yet. We don't get a majority of the patients transplanted even below 65.
Right.
So I'm ready to do a transplant till 70. Above 70, I'll
Above
leave
70 remains an issue. Yes,
Yeah,
sir.
so I think I largely agree with sir. What the point is trying to make is, rather than debating more about 70 and older, wherein I'm sure our TRM rates would be higher, we should try and get everyone to transplant if they can, if they're fit enough. But yes, exceptional, extremely fit, and if the patient is well motivated and family understands everything, we must not deny a transplant in an elderly fit
So
person.
now,
Unfortunately, sometimes the 40 years old guy doesn't get a transplant.
yeah, that's really sad. There is no doubt about it. May I ask Uday or Dr. Pankaj, anybody from the image group, in your data set, do you have a cohort for patients who were transplanted more than 70? And if yes, then what are the challenges?
Yes, there are data, but frankly speaking,
Not
we have no
analyzed.
idea about the exact details because we generally only have the de-identified information. So the
Right.
challenges we won't be knowing.
Perfect, but we'll wait for more to listen more from your data set. Coming to now the second issue, melphalan. Again, 200, 140, 160 we all have, and as Dr. Bhurani has said, conventionally we have been trained almost across the country that patients who are more than 60, 65 or some kidney dysfunction go down on dose. So let us discuss it in the light of the latest data, that do we still practice it and is there any rationale behind it? Starting from the side this time, yes?
Yeah. See, in generally for all patients, I would prefer to give 200. We give 200 for majority of them, unless they have got renal failure or if they're frail, like we transplant more than 65, I usually don't give 200, I stop at 140.
So if somebody is having a renal failure, so and you define it by creatinine more than 2, or is there any other cutoff?
No, usually creatinine more than 2.
That kind of
I know there is no strong
make me
data.
think, regarding if somebody is on, say, maintenance dialysis, then in our setting, does that become a relative contraindication for doing auto transplant or not?
No, we have done transplants for patients who are
dialysis. So that is one
undergoing
message,
dialysis also.
that presence of kidney dysfunction, and especially if the patient is on dialysis, it is not a contraindication. The patient can be transplanted safely. We do not have any Indian data of low dose versus high dose. So whatever we have learned from is from Western countries. And now people are, my personal view is that if the patient is in remission, the dose of melphalan between 140 and 200 does not matter. The efficacy is achieved with low dose also, but the general consensus is to give 200 wherever it is possible. It is cost effective, it is one time, and there are many other aspects which were highlighted by the speakers earlier in today's presentation. Right, now this is a debate.
At least 100 doesn't work, means 100 is equivalent to the, so I'm not sure about the 140, but
Right, so I think, so 140 is the minimum dose we should intend to deliver.
no, unless there is a renal failure, we should go for 200.
Right, so we all have
Unless
heard,
we have some solid data to say it is equivalent.
so I think the take home will be that at least 140, and if you can deliver 200 or more than 140, it is welcome. But there is data that if somebody is in complete remission, the benefit is almost there.
We need to reduce dose for patients with secondary amyloidosis.
And that's a very good point for secondary amyloidosis. And what dose that would be?
140.
140, okay. Now coming to, we have to go to maintenance, the last part in the transplant thing, early versus delayed. The debate has been on for quite some time, especially after IFM 2009 data. People are still not convinced with early transplant in everyone, especially in the European countries. So let us see what the practitioner in India think about it. And I'm particularly just quoting this trial. So early versus late transplant, anybody, Salim?
Actually, sir, though all the trials have shown that there is no much difference in the overall survival, but in Indian setting, if you see, I think we should encourage early transplant because the first hit has to be good, and also the number of patients, because the willingness of transplant itself is a big question in India. So initially only we motivate them and get them to a good response, and basically later on the second line therapies are also very costly. So in India, so many people may not afford later on daratumab or anything. So it is always better that if you push, and transplant is a very, very cost-effective strategy. That's how I feel in Indian setting. Still, we should tell people that we should go for an early transplant strategy.
So what I understand from your response is that it is the willingness which is the most important one. The patients are more willing for transplant in the frontline setting than in relapse setting. Other panelists?
Sir, in generally, we would, in a very well-educated person who have achieved a very good deep response for the induction, I would give them an option of both, like store the cells and then do a transplant at a later date, continue the same induction for another 2-3 cycles and then put them on maintenance. But majority I would still go ahead with him a direct transplant, because the only bigger advantage is as the time passes, the cost of therapy comes down. For example, if you take carfilzomib or pomalidomide, about 5 years back we used to import and it used to cost 1 lakh. Now it costs only just
I
about.
think that's a very smart point, you are making.
Just about 5,000 rupees in a month. So it makes quite a lot of sense to delay the relapse as much as possible. For example, even if you take CAR-T, I think it's going to come to India in another few years at a very, very cost-effective price.
I think that's a very smart point made by the panelists that, if you have a very long PFS1, so by the time patient relapses, which eventually they will, at that time you might be having a generic biosimilar daratumumab in India, you might have CAR-T which is marketed, and India-made CAR-T is available, and you have very effective regimen at that point in time, which can further give a good, so that is a very strong point.
So I think there's more than one reason why early is better than delayed. So I think the recommendations of all high risk would try and get to an early transplant. I think the debate is in standard risk myeloma where you try to debate early versus late. But even there we know about the clonal evolution, about the loss of patients who get from one line to another line. We know that some patients who are fit upfront may not be, maybe too frail for a late transplant. So long story cut short, if possible, early transplant should always be preferred versus delayed.
Sir, I'll ask you this question differently. Is there any setting in which you will just suggest to a patient that, okay, you can get it done later?
Probably not.
Probably not. And Sanjeev will...
As I am in a government setup, I counsel patient for transplant immediately at the time of diagnosis only, because they depend upon finances by PM fund, CM fund or Rashtriya Arogya Nidhi or our in-house funding for transplant. For that they need time. So whatever, even if a patient is a standard risk or high risk, if I counsel them for transplant, it takes times to arrange finances.
Right.
And ultimately, for whom we want a early transplant, ultimately land up into a late transplant. So that usually happens. There are exceptions. We have done transplant as early as 9 weeks after diagnosis for ultra high risk myeloma, but it is an exception.
Right. Now, someone who has not got a transplant upfront, I'll strongly recommend on first relapse. So someone who has somehow has not got it a transplant,
Yes, sir.
I put my whole energy to get the transplant at first relapse. The maximum benefit will be, if you're not getting it fund, then the first relapse.
Right. So this is a recent paper from AIMS myeloma group, and one of the authors, Dr. Atul Sharma sir, is sitting over here. And where they studied is a large cohort, is a retrospective data spanning over last 15 to 20 years perhaps, and they just analyzed the whole data. And they found that patient who received early transplant versus late, the number of the number of patient who achieved complete remission after BMT was significantly higher in early transplant. The number of patient who achieved CR plus VGPR was also significantly higher, as well as overall response was higher, but this was not statistically significant. So clearly early transplant is also giving you higher response rate, and if we see whether it is translated to progression-free survival, it did. The patient who received early transplant, they had significantly higher PFS in comparison to those who received a late transplant. This is single center retrospective data, but this is a large cohort from Indian setting. This is a realistic practice over last 15 to 20 years. Overall survival, although one may argue that statistically the p-value is not significant, but you can see that the graph is consistently very, very high for those who receive early transplant, the blue color, and the red line is trailing behind.
This includes early or late, but this does not include all the 100 patients who gone there, and many of them have not received the transplant. And if you see the overall survival, people 100 have gone early transplant, started, and then you see the progression-free survival, there will be a huge difference.
Yeah, and this is a very important point, because this PFS is a post-transplant PFS. So people who could not survive till transplant or who did not opt for transplant were excluded, and these are the perils of a retrospective data analysis, which is very well accepted also. So, however, the evidence is there that early transplant did help the patient who received it. Now, what favor early transplant? All the panelists, I will just enumerate that patients are much younger and likely to be more fit when they are in the first remission. Now, second, as Dr. recently said, that longer disease-free control, PFS1 is very large, so they can live a very peaceful life without any relapses, relatively better, probably quality of life, and maybe when they relapse later, there may be much effective therapies at much cheaper rates, which is a very great point. It is a one-time treatment. The impact is proven beyond doubt, both progression and overall survival benefit. Initial cost may be high in Indian setting, but the overall cost benefit is very, very great, especially if the patient is in a Western setup where the maintenance therapy cost of 1 year can be more than the cost of the BMT. We are lucky in India. We have all the maintenance therapy, not all, but all the basic maintenance therapy available at a very, very discounted price. And the last point is, which I always felt, that the effort and momentum of the whole family and the patient is at the maximum when they present for the first time. So therefore, in most patient come to say Delhi, Bangalore or Mumbai, they relocate, they take a room on rent. So it is much better that we transplant them in the first go rather than waiting for a later relapse. Coming to the maintenance part. Now, what is an ideal maintenance? Couple of points. An ideal maintenance regimen has to be, number one, convenient for a patient. The second point, I feel it should extend remission. We may debate and argue which one is first. I feel the first one, the convenience should be the first one. The third is, it should have favorable and acceptable safety profile, which we should be discussing with a patient. And fourth point is, it has to be cost effective. Now, if we just put the drugs which are available, most of them are in India, except a couple, except Exazome, we have everything. So now I'll open it to the panel regarding which drugs from this list you use for maintenance therapy, starting.
I think largely all of us have been using lenalidomide for a long time. We did it for a very number of times. Now we sit till the progression. Now I think we try to re-stratify and then talk to people about having bortezomib or anti-CD38 molecules if they are in a very high risk group. But yes, lenalidomide for everyone, and perhaps dual maintenance for patients who have high risk disease.
Okay, so dual for high risk, and you use len, borti, and some cases daratumumab you are saying you have used in certain cases, very high risk cases, okay?
It is the same, sir.
Same. Salim, your thoughts?
Same, sir.
Same. Any difference? Okay, similar. So this is the data. This is a paper, the first paper, NEJM paper 2012, and which almost galvanized the role of lenalidomide as maintenance. Both progression-free and overall survival were seen. And this is the meta-analysis by McCarthy et al., in which you can see after pulling off 5 trials, still there was a huge difference in the benefit obtained by giving len maintenance over observation. And so this is accepted. What is, remains fluid is what dose and schedule is used in India. So Sanjeev, can you take regarding what dose, duration, and schedule you use?
Usually I start with 15 milligram or 20 milligram dose, and because 25 milligram they are not tolerating.
Okay.
And I give minimum for 2 years. Some patients who are developing cytopenia on regular maintenance, sometimes I stop early also, and some patients are on prolonged lenalidomide.
Sanjeev,
I
may I
have
ask
not
you,
stopped.
yeah, any reason that you are starting with slightly higher dose of 20? Or is it an institutional protocol at your center?
15 or 20, most of the centers are using.
Okay. Dr. Burani?
10 milligram continuous ideally, and then depends on the neutropenia. Even a 5 milligram alternate is sufficient. So depends on the tolerance. I mean, I may vary from 5 milligram alternate to 10 milligram continuous.
So let me learn that if you are using a 5 alternate or 10 continuously, you do not give 7 days break. It's like 21/8.
Ideally is a 10 milligram continuous.
Continuous without break. But if you are using higher, you would like to give a... Any variance from this? Okay.
We
So-
give 21/28 days. 7
Right.
days off.
I will also encourage if anybody from the hall would like to interact and ask the question to the panelists. It's an open hall discussion. And the duration of the...
I usually give it till they relapse. I don't stop.
You give till progression
Yes.
or relapse. Okay. And again, the same thing. There is a divide between the European thought process, who say time bound, probably because it is quite cost ineffective to give len till progression. So, Salim,
we
you
are
work in
using
a public
until
sector.
progression, sir.
Until progression.
Not really.
And your choice is 10 mg or 15 mg?
10 mg.
10 mg. So most of us use 10 mg or 15 mg. 20 mg Dr. Sanjeev is using, but you can use, it's not like it's wrong, but then commonly it is not practiced because of the risk of the complication which we shall come to. Right, so if you see the benefit given by len, this is for progression-free survival. You can see almost across the variable group, it is beneficial. So there is no doubt about len. The only thing which remains is how we use it and for how long we use it. So I think the panel agrees that we have to use it till progression. And for patient who are, which is not shown in this picture, is patient who are having high risk cytogenetics, because I think this data is data availability for cytogenetics. They have ISS3, which is PFS benefit. But when we see the overall survival benefit, the len maintenance did not work for some reason in women. Patients who were more than 60 and patient who had high risk ISS, which is ISS3. Almost it is coming over here. So overall survival benefit remains selective, patchy, but there is no doubt that we have the len is the option that we have at the forefront of maintenance therapy. Moving on quickly from len to proteasome, bortezomib, the cost of bortezomib is now 1,000 rupees per injection, less than 1,000 rupees for public sector hospitals per injection. So quite inexpensive and easy. So what is the thought of the panel on use of proteasome inhibitors? In what setting? And again the same question, what dose and schedule?
We typically do bortezomib once every 2 weeks, perhaps most adults around 2 mg subcutaneously.
So almost like capping at 2 mg because of the vial size saving the cost. Same?
Same, sir.
Any thoughts, sir, Dr. Burani? Similar. Now again the same thing which I am coming to, the HOVON data, which is the largest data with bortezomib maintenance. It worked, and it worked in the most dreaded subgroup, which is del 17p. The patient who were harboring this deletion or who had high creatinine, giving bortezomib improved both PFS and overall survival. But somehow the benefit, the similar benefit was not seen with other subtype like 1Q gain and 414 translocation. In the morning, Dr. Vincent Rajkumar has said that the benefit was there, but probably it is subject to our interpretation of data. And as of now, the practice is anybody who is having a high-risk myeloma, any of the high-risk cytogenetics parameters, they are given as a standard of care doublet maintenance with bortezomib and lenalidomide. Do you think that neuropathy plays any part in this decision, Sanjeev and Dr. Burani?
No, so maintenance, you need to have a quality of life also. So we are not just doing it for the control of the disease. I mean, high risk disease you tend to treat more intensively. You need to take care of the high risk component. So you have to balance it between two. Some people cannot tolerate because of the neuropathy. You can cut down a dose to even a 1 milligram every 15 days.
So do you do you cut down the dose, or do you offer any alternative?
We don't have any other alternative. So we have a bortezomib and lenalidomide. So we are giving these two drugs to the high risk.
These two drugs. But what about carfilzomib? We have now generic carfilzomib also.
Sorry.
So have any of you used carfilzomib in the maintenance therapy?
Yes, I have used only for patients who have sort of relapsed, and then I have done transplants. For the first relapse.
Some patients who have used carfilzomib as an induction post-relapse, and then we use it as a
and that is what the data says perfectly.
So someone you have given a 6 months or 1 year of carfilzomib at relapse, and then you go as a maintenance.
So this is the data, Nordic data from Europe, where carfilzomib maintenance was used in those patients who had a relapse myeloma, who were given carfilzomib upfront, and after that they were given KD maintenance, carfilzomib dexa, and there is a clear 10-month PFS benefit. There were more infection with carfilzomib because we know it is more immunosuppressive. So the data we have today with carfilzomib is especially in setting of the relapse myeloma who received carfilzomib based induction therapy, who responded to that. Can we use it as an alternative to bortezomib? Remains an open question. We have to answer it. It's difficult to give. It is intravenous. It is costly. So it cannot be used interchangeably. But yes, in a setting somebody who is having a high risk myeloma, and bortezomib is clearly out of question because of severe neuropathy, because of say somebody is diabetic, having underlying diabetic neuropathy, probably carfilzomib can be used as a management decision rather than any policy issue. Ixazomib we don't have, but the best data, which is tourmaline data, which is a completely randomized data, phase 3, in this there was benefit, but it is a very humbling trial where the PFS benefit over placebo was only 5 months. So therefore, in countries where ixazomib is available, it probably can be given as a very attractive option of all oral. Lenalidomide with ixazomib, you take 2 pills, and some benefit is there, but as of now, it is not available. Now coming to this daratumumab, in the morning we heard Dr. Rajkumar speaking about this Cassiopeia trial. Second part on maintenance therapy. So I think you said that you have used in a couple of patients daratumumab.
So we did.
How did you decide in which patient, apart from affordability?
Yeah. So a couple of, both of them were very high risk myeloma, and post relapse, post dara, auto, and then maintenance is what we're doing in them. Just some qualifying about Cassiopeia and daratumumab. So the benefit was largely visible in those who did not receive daratumumab in the induction in this trial, as against those who received in induction and in maintenance. Yeah.
So I agree with the decision, but I would like to learn maybe from the experts that we believe on one hand that daratumumab is more effective in patients who are having a low to intermediate risk. The maximum benefit is in that group, but we always practice to give it in patients who are having double hit or ultra high risk kind of myeloma. With what is the basis
There is a
behind?
cost effectiveness with the Cassiopeia. If you are using for 6 months, you are giving a higher doses, more doses. And if you don't give it in induction and give it as a maintenance probably for a 1 year, the cost will be lesser.
Right. Okay. Well, that's a good point. And as he said that it was beneficial across.
And both were equivalent probably if you see the data.
But I have one doubt here
regarding
this daratumumab being given as maintenance in Cassiopeia in not the treated group with dara. So if you go by the pharmacokinetics of the daratumumab, their booklet, the dosing strategy to saturate the antibodies, basically initially it's weekly, then once in 15 days, and then it is monthly. So how are we going to achieve this by not giving dara and just giving dara once in 8 weeks is my question.
Right. So maybe we can have, yes.
So one of the things is that the Cassiopeia trial just tells you that about 6 months of dara, if you give, captures the benefit you get of years of dara. But it's a very unique trial because it's done in a time when we are all using lenalidomide maintenance and they don't have any lenalidomide. So it's very hard to extrapolate Cassiopeia to current practice where all of you are giving len maintenance routinely and adding bortezomib for the high risk. So the real question is, in that context, what does DARA add? We have no idea. And when we have no idea, what we are doing is we are just grasping for straws when there is a very, very young patient who had VRD and their initial response was kind of like not as good as you would like. You somehow got them through transplant. And sometimes just out of sheer hope, not out of data, we are giving the len, the bortezomib maintenance and saying, okay, maybe you can get some DARA also. But we have to be eyes open that we are doing that not because we are sure it's going to work, but it's mostly out of hope, mostly out of wanting to give the best option to patients.
I have experience of 4-5 patients. We did a transplant, say 6 years down the track or 5 years down the track, and then put it on the DARA maintenance. They had flattened. I mean, they had a longer. I mean, it's only 4-5 patients, so I cannot extrapolate to this. But somehow this was strange.
Yes, and if you're in a situation where len is not going to be used as a maintenance, then you can, and the patient has not had DARA as an induction, then you can extrapolate and say maybe I'll give that. So
I think another thing to remember with the DARA is also, even if you look at the Maya study, the patients were supposed to get DARA until progression, but if you really look at the data, the majority of patients stopped after 2 years. With the Griffin trial, DARA stops at 2 years. Your dosing of that 8 weeks, that's a little, I don't think any of us can explain that, and that's why waiting on the DARA maintenance trials is going to be important, because using DARA indefinitely, and I think somebody asked Vincent the question, you know, early on we don't see toxicity, but the kinds of infections and the issues around stem cell collection when you're using DARA in your conditioning regimens is certainly way worse than using the 3-drug regimens. We are seeing more viral infections, we are seeing more PJP, and with COVID, we are seeing worse infections in the context of daratumumab.
All right, I mean, there's an important point, because if the point of concern to you is infections, then in developing parts of the world, they are even more. So we have to be really pragmatic in choosing this strategy. Not only it is costly, but it is also causing the concerns which are very much relevant to us.
Someone who has been more refractory and somehow you do a transplant in the later part and probably put a len and DARA maintenance, you may get a longer progression-free survival. I mean, just a thought.
Yeah, so I just, because the time, I have to watch the time, so because these are other options, and we have small phase 1 or maybe a retrospective data from various centers of these combinations of various kinds. The maximum data is with len with ixazomib, and since most of us are not practicing, so this is just for the ready reference that these are the options which can be used, and anybody can see that len is the only constant. Now coming to the last 2 slides, which is issue of second primary neoplasm, because definitely when len is everywhere, from induction to maintenance, this remains an issue. And the meta-analysis showed clearly that the hazard of getting hematological SPM is 2 times, 2.03. And for a secondary solid tumor, it is 1.7. And if you see the real incidence, in len group, hemat SPM was 5.8%. In placebo, it is only 0.8%, a major concern. So now I'm just quickly, because time is limited, do you discuss SPN with the patients and in the true sense or in a passing reference?
I don't know how much, I mean, now it stands for, I mean, previously there was a fear and then it has gone away. The people are saying give it at least for 3 years. I mean, most of our patients are dying because of the myeloma. So controlling the myeloma is more important, considering the incidence of secondary malignancy.
We
don't discuss. Okay, and any panelists?
So Gaurav, can I ask a question?
Sir, yes, sir.
So like maybe the panelists can tell us, do you stop at 3 years or do you continue till progression? For several years I am not stopping it. And I don't see too many issues, either malignancies or skin disease or anything, you know, 5 to 10 milligrams on and on till progression.
If it affects your quality of life, then we stop.
Yes.
If it's not affecting your, I think the quality of life is very important when you are away from your treatment.
In some patient in which there is a symptomatic cytopenia.
I think all the problems start in initial 2-3 months. If they tolerate in initial 2-3 months, I think they'll tolerate throughout.
Okay. Right, so I think this is an issue with the prevalent use of LEN. I think if the image can come up with some protocol where we can all pool together the SPN data, it is going to be a very important eye-opener, because SPN is is a biological thing, and one population may be very much different from the other, and we have to learn about how we behave, how the patient in Indian subcontinent behave with LEN. They may not have exactly the same incidence, we may have higher or lower. We need to learn, and I think further research is needed. So ultimately, last slide, it is about choosing the lesser evil, SPN versus myeloma, and very rightly, as Dr. Burhani has said, this analysis also showed the same, that much more patients are dying from myeloma than from any secondary neoplasm. And if you see, the blue dotted line is patients who died from myeloma without LEN maintenance. The solid blue line is patient who died with myeloma who were on LEN maintenance. And if you see, the number of deaths because of secondary neoplasm is fairly low. So with this data, I think we are very much clear that LEN maintenance has to be used. The risk of SPN is a real one. It needs to be discussed, but it should not be a deterrent or the major reason in using it. I can see one hand at the back, yes. Aditya, after that. Yes, yeah. So I think that the debate has gone to now MRD. I showed you the data from the meta-analysis where the LEN maintenance was beneficial across the group in patients who were in CR, PR also. Yes, the patient who achieved complete remission, overall survival benefit was not seen with LEN maintenance. It was not significant. It was seen, but not significantly. So now, as we heard in the morning, that the debate is about MRD positivity or negativity, because the real crux is MRD negativity. If it is sustained without maintenance therapy, the patient will do good. So as of now, since we are not doing MRD routinely, we have to use LEN maintenance because it has shown PFS benefit even in those patients who are in complete remission. Definitely for patients who are in less than complete remission. Aditya?
Sir, yesterday Dr. Munshi highlighted one important point, that after melphalan exposure, the number of mutations is significantly higher in the myeloma cell lines. So when we discuss the risk of second primary malignancies, in the discussion, how do we attribute the risk of SPMs to LEN versus melphalan in a long-term survivor?
I think we should ask the panelists for that.
No, it is.
I think it is a very important question.
Is there even in patients who are transplant ineligible if you put them on maintenance?
Actually, it is 9.7% versus 7.2 in transplant eligible versus transplant eligible. So actually, it was not of statistical significance. So it will continue as a maintenance strategy.
See, Adit, what happens? My take is on that. In most of these things are
the number of cancers have not increased in statistical significance with the high dose melphalan group. That's what the
right.
study.
But still, they remain multifactorial. Per se, myeloma is a risk factor for secondary primary neoplasm. Then LEN is, and if somebody is, has been exposed to melphalan, being an alkylate, very strong alkylator, DNA damaging agent, it will be. Some patient would have received radiation. So to single out one putative mechanism will be difficult in such subset. I think it is going to be a cumulative effect.
I want to highlight. We are blindly following International Myeloma Working Group guidelines for all patients. But in US, the multiple myeloma median age is higher. We are seeing our multiple myeloma patient in their 30s and 40s also. I don't think autologous stem cell transplant should be the only answer or conditioning strategy for these patients. There should be some alternate, there should be research for this young myeloma patient for alternate transplant options. There was a EBMT tandem auto allo study 20 years back, and you will be surprised to know there are many patients who are still surviving from that cohort. So I think for young myeloma we have to think in this line. Other than melphalan conditioning we should think.
Okay, on goes the quest, and I think although there is a bell, but Arun, definitely I'll give it to you.
Yeah, so this is regarding the maintenance with lenalidomide. So with respect to len and pomalidomide, although they are the same class, because they're but they're mechanistically different. So there is now a good proteomic paper which says LEN is more predisposing somebody to a second primary malignancy, and the POM doesn't have such a high odds ratio. So does it make it a case, like we had a talk yesterday of considering POM upfront in the induction? Can we consider POM as a part of a maintenance regimen if second primary malignancies is a real concern, is my submission.
So I have no answer for this. May I ask any of the guest faculty to answer this?
I don't think you can really make a conclusion because nobody really stays on POM for that long as what we have done with LEN. So most of the POM data is already in the relapse setting where the median duration of therapy is so much shorter.
Right. Okay, I think with this, I thank all the panelists for and as well as the audience for active engagement, and thanks the organizers for giving the opportunity. Thank you.
Thank you, Dr. Gaurav and the panelists. We now break for tea and will restart in 10 minutes for the inauguration ceremony of the 5th Annual Conference of Image.
इसी पे लगा देते हैं ना?
Someone has turned on that mic.
नहीं, this is.
We are putting left on left side.
Sir, volume.
Myeloma, and these crystals are in fact uremic frost, which is because his kidneys have failed to excrete urea from his body. To elaborate further on this, today I, Shreyasi Seth, am here to talk about kidneys in multiple myeloma. To start with, let us have a look inside one 60-year-old Mr. M&M.
Myeloma transplant, medical cadet
तुषार शर्मा, सशस्त्र सेना, चिकित्सा महाविद्यालय पूना द्वारा हेमाटोपोइटिक स्टेम सेल्स हमारे लोमा ट्रांसप्लांट मेडिकल कैडेट तुषार शर्मा, सशस्त्र सेना, चिकित्सा महाविद्यालय माइलोमा ट्रांसप्लांट
അച്ഛന് 70 വയസ്സായതുകൊണ്ടും നടുവേദന, കൈകാൽ തരിപ്പ്, അമിതമായ ക്ഷീണം എന്നിവ പ്രധാന പ്രശ്നമായതുകൊണ്ടും മൾട്ടിപ്പിൾ മൈലോമ എന്നൊരു അർബുദമാണ് നമ്മൾ സംശയിക്കുന്നത്. അർബുദം എന്ന് കേട്ടുകൊണ്ട് അച്ഛൻ പേടിക്കേണ്ടതായിട്ടില്ല. പണ്ടത്തെ പോലെയല്ല ഇപ്പോൾ. നമുക്കിത് നന്നായി ചികിത്സിക്കാനും പെട്ടെന്ന് കണ്ടുപിടിക്കാനും മറ്റു അവയവങ്ങളെ ബാധിക്കുന്നതിന് മുമ്പ് ചികിത്സിക്കാനൊക്കെ സാധിക്കും. ഈ അസുഖം എന്താണെന്ന് വെച്ചാൽ നമ്മളുടെ മജ്ജയിൽ നമ്മുടെ പ്രതിരോധത്തിനായിട്ട് വേണ്ടി ചില കോശങ്ങൾ നിർമ്മിക്കുന്നുണ്ട്. അത് ഇതാണെന്ന് സങ്കല്പിക്കുക. ഈ കോശങ്ങൾ തന്നെ ആന്റിബോഡി എന്നിവയും ഉണ്ടാക്കുന്നുണ്ട്. ഇതും നമ്മളെ പ്രതിരോധത്തിനായിട്ട് സഹായിക്കും. ഈ അസുഖത്തിൽ మధ్యలో
మూత్రపిండాలు మరియు మైలోమా. మైలోమా వల్ల మూత్రపిండాల వ్యాధి సాధారణంగా రావచ్చు.
It has come in, like I have hyperlinked it to a separate document. So it's stuck on the PowerPoint. So how do we do that?
They can extend the thing, but it will take there is a we can extend the fourth chain, but
No, I got it.
yes, you have to stop the slideshow.
So, and keep it as the last slide.
No, it will project because you have started the slideshow. You can move the slides. It will work, sir, because in the background we were slideshowing the PPT. This which version is 11.9. No, so we are used to that newer version. పాయింట్ అన్నావు సార్ எனக்கு அனைத்து பாயிண்ட் secondary screen area we have blackboard ಮಾಡಿ ಸರ್
Sir, please come. Can you please help me? बेटा वो बैग्स नहीं है इन दिस सेशन मतलब ना देयर आर नो बैग्स
Good afternoon. Welcome to all, and as the organizing chairperson for the 5th Annual Myeloma Congress, it's my personal welcome to one and all the distinguished gathering to St. John's Medical College Hospital, and to be part of this the 5th Annual Congress of Myeloma. And today, this afternoon, we are we still afternoon? Yes, we are. So, so we are privileged to have you all over here, and we kickstart the formal inauguration ceremony for the 5th Annual Congress, and it is my privilege to invite my dear friend Uday, who's a workhorse for the entire Congress, to come, and also my dear friend Pankaj Malhotra, who's the president of the Image Society, to come on the dais. And first of all, I would invite Uday to give the secretary's report to start this inauguration process. Thank you.
I've been given the duty of rattling out what we have been doing, or I would be more precise, what we have not been doing for the last 1 year. So for all of you who are new to the Indian Myeloma Academy Group, I see many of the students for the first time coming and joining this gathering. Most of the faculty have been with us. They have helped us, guided us over the last 5 years to the stage in which we are today. So just a brief introduction about the Indian Myeloma Academy Group. Trust me, I'll not take much time. We will not get delayed for the lunch. So the idea was conceived in September 2016. A theme-based meeting was organized at PGI Chandigarh, the brainchild of Dr. Subhash Verma sir and Dr. Pankaj Malhotra sir, to have a theme-based meeting. So people really were surprised that theme-based meetings at that time in our country were not very popular. Will people come? Will it be a success or not? But as part of that meeting, finally, an idea evolved of having a formal organization or a group labeled as Indian Myeloma Academy Group. The logo which you see here is what was designed by Dr. Dipesh Lad, who is a associate prof at PGI currently. So this actually looks like that SPEP, and he tried to design it out of that. There were 52 faculty members in this particular meeting, and then it was decided that we will have to formally organize a group. So the subsequent conference was held at Army Hospital Research and Referral. That was the formal launch of this particular group. It's actually a trust. We did not get it registered as a society because of the various legal and the other reasons. So it's a trust. So we had a fantastic response for a theme-based meeting. We had almost 14 parallel sessions on the prime day, going at 14 different halls simultaneously. There was nursing staff, 342 of those coming across the country, 824 registered delegates from 12 different specialities. We had separate sessions for neurology myeloma, nephrology myeloma, and each one of them were oversubscribed from people not only from Delhi but across the country. We also announced to have traveling fellowships for the students that year. Then came in the second conference. We thought, okay, we started well, but we need to continue the effort. So therein came the help from Tata Memorial Hospital, ACTREC, Dr. Naveen Khatri and Dr. Bhausab. They took it further. They organized the second annual conference. For the first time, 4 students were selected for international fellowships, and they were sent for international fellowships that year to Boston, where the IMS annual conference, we have Harshini here, who was the first recipient of this award. So the scientific session and the conference over 2 days had 86 faculty members and around 317 delegates. Other than this, around 110 students across country were supported totally for their travel, stay, everything, all covered by the Indian Myeloma Academy Group. We released for the first time a data registry platform which was created by the faculty of the Indian Myeloma Academy Group ourselves, wherein we wrote the code, we did it. So the first version which was released was almost like a prototype, and we tried to work it out in 3 selected institutes, whether we are able to do it or not. That was launched in this particular meeting. Then the third annual conference, this was held at Nizam Institute of Medical Sciences, wherein the updated or the beta version of the care for myeloma was released. This time we also released the patient and the doctor related mobile apps. It was a hybrid application wherein patients can log in, they can see what's happening to them, what the doctor has prescribed. It worked as a patient diary. It also had reminders setting for the patient, when should they get their next testing done, what is the progress, etc., etc. Similarly, the doctors also had a mobile app for all those registered institutes wherein the doctors are entering their data. The doctor on their mobile can see real time what's happening to the patient. Now, how does this real time information come in? It comes from three sources. One, the data entry operators from the hospital. Second, the patient themselves. So this is one of those applications wherein patient enters its own problems, his own investigations, because most of these patients by 2-3 months of their illness, they are well versed with the terms, etc., etc. Though whatever they enter is again vetted and validated by the hospital staff. And lastly, the third entry portal is by the doctors, the junior doctors who are seeing emergencies, wards, etc. So this was released at Nizam Institute of Medical Sciences. Again, it was a huge success wherein 54 talks, 124 faculty members and 318 registrations. Then came the COVID. It had applied brakes onto the progress that we were doing, but still the spirits were upheld, and we did our 4th annual conference during the peak of the second wave of the COVID. It was initially planned to be a hybrid meeting, but at the last moment, because of the second wave and the travel restrictions, we had to convert it into a virtual conference. But the conference was not called off, because it was a virtual conference. So rather than having it as a day-long conference, we abridged it only into the evening sessions, but rather than 3 days, we had it for 5 days. So we had a virtual conference, which was again a good success, and many people appreciated the efforts which were put in. And then we come in here for the 5th conference of 5th annual conference of the Indian Myeloma Congress, or the Indian Myeloma Academy Group, the 5th annual conference held under the aegis of St. John's Medical College and Hospital by Dr. Hari Menon, the head of the Department of Medical Oncology Division. Okay, what's our motto? So, single point agenda, furthering myeloma care in the country. But it's a huge term. If somebody asks me to write an essay on furthering a myeloma care in the country, I can write 30-35 pages on it, because there are various aspects to it. Starting from taking patients along with us, making them understand, because the biggest challenge in our country is the education of the patient. We write a prescription, but the patient need to understand the relevance, the compliance, and the side effects. Half of them miss the drugs, they go to alternative types of medications. So the first hurdle in myeloma care in our country is the patient education. So we are putting all efforts, which we will be showing you a few of those. We have had brochures released in 14 different languages, which is on our website, which were prepared by all institutes across the country. CMC Vellore prepared some 6, Tata Memorial prepared some 4, PGI prepared a bulk of them 11, Army Hospital prepared some 12-13 of those under various aspects of the myeloma and in different languages, such that we cross the language barriers in our country. The second problem was the caregiver empowerment. This is something which is actually neglected, because it's a chronic condition, people, primarily the elderly, being affected by this. So the children or the caregivers needs to be empowered. They need to understand the depth of care and the duration of care. So our second agenda is to make sure that the caregivers understand what it is. We have a caregiver here, so she had a good session with Dr. Pankaj yesterday. She could interact with them. So the third part is better training of the residents. In India, any health care is care of residents. We are there to guide. We all call our consultants, and in true spirit we are consultants. We are only there to consult, but the real hard work sitting next to the bed is by our residents. So both MD residents and the DM residents, they need to be taught the right things at the right time, because once they pass out, they carry the same information for the rest of their life. They become fixed ideas. So to make sure that the residents get better training as far as the myeloma is concerned, we have provision of both national observership program as well as international observership program. For the last 4 years, every year, one fellow, either a DM fellow or a post DM, the junior faculty, have been sent abroad to various international institutes to do 1 month fellowship purely for myeloma training. This year we had Dr. Stalin Bala Chaudhary, who just completed his fellowship or observership at Mayo Clinic, Rochester, and has come back. Opportunities for the doctors interested in dyspro or dysproteinemias, better information, international fellowships, and collaborative trials. Now the collaborative trials, we understand, we have thought about it for doing it for last 4 or 5 years. HCC, which started later than us, is much ahead of us. We are learning from them how to do the better trials, coordinated trials. We did start about 2 trials, but really because of the COVID, we couldn't take it any further. We did a VPD-VRD trial. But yes, for this year, coming year, this would be our homework, that by the next year secretary report will work on this collaborative trials as far as the Indian scenario is concerned, and to get better trials on place. National Myeloma Registry. We are proud to say that we are the first people to have a separate dedicated software for entering the data, and now we have many of those for different disease groups. We did have for lymphoma earlier than the myeloma, but the way our database is much different to the others, and we don't cover the basic minimal information. We cover extensive information from all angles. So this is something we are very proud of, and we want more and more institutes to be a part of it. There are currently 32 institutes which have registered, but we have only 4 or 5 who are dedicatedly entering the data into this. So we here require feedback, improvements, how we can help you further is something that we will talk to you, and we will take feedback from this. Indian-based recommendation is something which is our dream. A consensus guidelines came out in 2016. There was another paper which came out on transplant, but we want to come out with more and more topic-based guidelines as far as the Indian condition is concerned. So specific areas of dysproteinemias and the recommendations or the guidelines specific to Indian scenario. Dr. Pranthar actually did a huge work on writing something on relapsed refractory myeloma in 2020, but thereafter 2021 January, the NIMS conference, he presented the data, but thereafter the COVID came in, we couldn't take it further. We are going to take it further from that point wherever we stopped, and we are going to finish that paper of relapsed refractory myeloma management in our country. This is what we have achieved till date. I will not brag about it much, we'll go further. Year in review, we have done only 7 activities in the last 1 year. 1, we started the myeloma specific or the plasma cell dyscrasia specific journal clubs and journal scans. Every 4th Thursday evening at 5:30 p.m. wherein the format is, we have got one landmark article selected by our international fraternity. Therein it's given to one of the premier institute in rotation. We have made a rotation for 12 months. So one after the other, the premier institute picks it up. The junior faculty of the premier institute critically analyzes it, presents it. The director of the institute, of that particular institute, gives the Indian perspective, and the international moderator gives the international perspective about it. It has been a huge success because it goes on YouTube Live, and if you click YouTube, other than around 200 to 300 registrants every meeting, and 14 countries, which was minimum number that we could cover, around 300 views after it was posted in a gap of 1 to 2 weeks. So it's something which people are actually viewing, and it's something which is actually propagating the understanding of the landmark articles, because once a landmark article gets published, what we decipher out of it might be very different from what the authors want to convey, and what the way it should be taken in an Indian perspective. So this is something which we started. So this was 22nd September where we discussed these 2 articles, then 27th October. So we had these articles coming up. The next one is on 26th of January 2023. Despite of we know we overwhelming you with the myeloma knowledge in this conference, still we are not coming, we are going ahead with the next journal club, which is going to be a week from now. So we invite all of you to join this. It's a free link. There is no registration amount. You just have to register, and you get the link to join, and you can join this. Those who miss these activities, they are all available on the YouTube, and in a week's time they'll also be available on the Image website. So you can even view these things from that place. Activity 2, Eagle Eye competition. Thanks to Dr. Joseph Jones's idea and Dr. Pankaj's idea of having a competition for students, the DM students and the DRNB students, the Hemat and Onco, to analyze and make them write commentaries or letters to editor, to induce that idea or that habit of writing letters to editor. We started this competition wherein one recent article which was published in the last 1 month is given to the students. They have to write 175 words about it. 3 blinded reviewers will review it, and the best person gets the award. So this is primarily to encourage the students to analyze the research article critically. Second, it also allows them to keep up the pace with which the papers keep getting published nowadays. So every week we almost have 2 to 3 plasma cell dyscrasias across various top journals with impact factor of about 5. So just to keep pace with that, for that, art of writing commentary, they also get an opportunity to present in an international forum. We give them 5 minutes to send a video recording of 5 minutes wherein they are supposed to analyze everything, talk about it and finish their comments. So this is something which we started, and we really have a good response for this. But I would request all the HODs who are here, every one of us in our institutes have this habit of journal clubs and journal scans, which is a part of our routine curriculum, academic curriculum across the country, starting from MD to the DM. But if you encourage your students to do this, one, they get benefited by them getting some credit hours, which will add up, wherein it will help them in getting fellowships. And second, there are international reviewers and the national reviewers, top people who are going to guide them, okay, how they wrote, what they wrote, and how better they can write. So that's something which will help them. Activity 3. Myeloma quiz. So a 5-question quiz based on the journal club, journal scan, and about the trivia of myeloma. Every month 5 questions. Whoever gets it best, the fastest finger first, gets exciting prizes and a certificate. The questions are generally based on the journal club and scan. This is just to reiterate that they go through the articles of what are of importance selected by the International Fraternity in detail. So this is something which we started and is going on well. 5th edition completed. Activity 4 is outreach to the undergraduates. This is something which has been our dream for last 4-5 years, not only here in myeloma but hematology in specific, that we wanted things to percolate to the undergraduate level, because we need to catch bright people young. And in an effort to do that, what we have done is, there is a research forum known as Illuminati. It is the biggest undergraduate research forum across in our country, I would say maybe in the Asia Pacific, wherein around 700 to 1000 students, undergraduates, come and present their research papers. These papers are short-term projects which all the undergraduates do it across the country. They come, they are not topic specific, they can be pathology, biochemistry, anything, all MBBS subjects. As part of that, we have introduced, the image collaborated with them, and we introduced something known as STEM talks and a preliminary round for the STEM talks. For the preliminary rounds, we have given a task to all these people to create a patient education material of 5 minutes. They need to send a patient education material in language of their choice across in the country in some selected topics. So for this year, we gave the topics as diagnostics in myeloma, transplant in myeloma, drug therapy in myeloma, monoclonals, and kidney and myeloma. In this topic, they can choose any language and they send the video to us. We got 64 videos across the country. Beautiful. We had to select only 5. It was a tough task. Dr. Joseph Jones and Dr. Tapan Saikia were the reviewers for there. They came physically to see the enthusiasm and the in-depth knowledge and the current generation where they are. We all feel that the DM students or the post-PGs, they know more. The amount of myeloma knowledge that these students have, unbelievable. Most of them might have just rotoed it, by-hearted it. They would not understand the implications of it. But we made them read myeloma such that now the undergraduates know there is something known as myeloma. And our purpose was solved. So I will show you just a few clips of the students, the best of the videos that we found, just for you to get understanding.
Mr. M&M complains that whenever he sweats, it leaves white-colored crystals on his forehead and face. What if I tell you that Mr. M&M suffers from MM, multiple myeloma, and these crystals are in fact uremic frost, which is because his kidneys have failed to excrete urea from his body. To elaborate further on this, today I, Shreyasi Seth, am here to talk about kidneys in multiple myeloma. To start with, let us have a look inside one of Mr. M&M's bone. The red bone marrow is responsible for production of hematopoietic stem cells, which further give rise to plasma cells which produce antibodies. Now in this case, the plasma cells have increased to more than 10% and also they are abnormal. Abnormal plasma cells will obviously produce abnormal antibodies. Now the antibody contains a heavy chain and a light chain. Since all the fragments of the antibody are not used up in making the normal antibodies, light chains get collected and they are found in the urine by the name of Benz-Jones protein. To know how this happens further, we can see that this is a filtering unit of the kidney called nephron. Suppose this is the filtering unit. Now you can see that normally bigger structures like this normal antibody cannot pass through the filtering unit. However, these light chains can easily be filtered through the glomerulus and get clogged inside the collecting duct, causing injury to the kidney. Further, in Mr. M&M, there is also increased osteoclastic activity. So this means that the bone is prone to breakage, that is osteolytic lesions. This will release calcium from the bones, which will get deposited inside the kidneys. So there will be further damage. Moreover, abnormal antibodies are not as efficient in preventing infections. So there will be recurrent UTI, further causing damage to the kidneys, called pyelonephritis. Moreover, Mr. M&M had been taking medications for bone pain since so many months. These medications, especially naproxen and other NSAIDs, cause damage to the kidneys. This condition, AKI, is seen in more than half of the patients of multiple myeloma. 60-year-old.
So, anyway, so what I wanted to actually bring across or put across to the faculty is, you see, this girl is with us today. The understanding about the myeloma. When I was undergraduate, Dr. Deepak Mishra was my pathology professor. He taught me myeloma and I just by-hearted it and rattled it out in the exam, about half a page, short notes on it. And he gave me the best marks for that also. But the understanding aspect was missing. Now this girl, she used props, basic simple props, to make a person understand. If this education material will help a patient or not, it's a far-fetched question. But that particular student understood what and how a myeloma causes damage to the kidney. So making the students try to participate in such events, we made sure that people understand myeloma at the undergraduate levels. So I request all of you to applaud. Shrezi, stand up please. Good, sit down. Thank you. So we have some others also. I will not take you through the complete thing, but we have some in Hindi. We have some in, I think this is Malayalam.
അച്ഛന് 70 വയസ്സായതുകൊണ്ടും നടുവേദന, കൈകാൽ തരിപ്പ്, അമിതമായ ക്ഷീണം എന്നിവ പ്രധാന പ്രശ്നമായതുകൊണ്ടും മൾട്ടിപ്പിൾ മൈലോമ എന്നൊരു അർബുദമാണ് നമ്മൾ സംശയിക്കുന്നത്. അർബുദം എന്ന് കേട്ടുകൊണ്ട് അച്ഛൻ പേടിക്കേണ്ടതായിട്ടില്ല. പണ്ടത്തെ പോലെയല്ല ഇപ്പോൾ. നമുക്കിത് നന്നായി ചികിത്സിക്കാനും പെട്ടെന്ന് കണ്ടുപിടിക്കാനും മറ്റു അവയവങ്ങളെ ബാധിക്കുന്നതിന് മുമ്പ് ചികിത്സിക്കാനും ഇപ്പോൾ സാധിക്കും. ഈ അസുഖം എന്താന്ന് വെച്ചാൽ നമ്മളുടെ മജ്ജയിൽ നമ്മുടെ പ്രതിരോധത്തിനായിട്ട് വേണ്ടി ചില കോശങ്ങൾ നിർമ്മിക്കുന്നുണ്ട്. അത് ഇതാണെന്ന് സങ്കല്പിക്കുക.
So we have something in Telugu. So we have students coming up.
మూత్రపిండాలు మరియు మైలోమా.
So anyway, so I'll not take you through all these things, okay? But so this was a preliminary round. Thereafter, in line with the FAME lab, we decided to give them STEM talk. So we gave them a topic of global care in myeloma, and the STEM actually stands for science, technology, engineering and maths. We modified it into medicine, and we said, using science, technology, engineering and medicine, how will you bring about a global equity in myeloma care? And for this, there were various students who come on the stage, and mind-boggling revelations, the way they understand how the cancer care or a myeloma care should be spread across in the country. So we awarded all these students, the 10 of them, and the top 3 students, we advised them to, we offered them to come to the national conference. Only one could make up because the other 2 were having their exams. So this is how we are actually trying, putting efforts, innovative ways of taking myeloma to the undergraduate level. To taking it further, we gave them an option that they can send these patient education videos to us, and we will award them in every subsequent academic meetings. And also this, for example, now we have a pile of 72 videos, of which at least 15 or 20 we can use it for patient education material after we vet them, go through the academic science component of it and otherwise. So this also helps the society in improving the database as far as the patient education is concerned. Activity 5, supporting for the poor patients. So based in PGI, we have something known as a transplant brick. So any patient comes, he gets a list of what all he requires or needs to buy for a transplant. We call it as a transplant brick. So Image has got associated with Care India, and we have donated 15 lakh rupees to Care India, and wherein they have created a transplant brick for 10 patients. These are available for any poor patient who has a BPL, who has exhausted his resources and is getting transplanted in a government institute. The reasons for putting this by the executive committee, these embargoes or these riders, are basically to ensure that whatever we are doing goes to the right population, because we do not have the resources enough to take care of all transplant patients in the country. But yeah, this is a small thing that we wanted to do it. So the funding is provided from the Indian Myeloma Academy Group every year for this creation of transplant bricks. For this year, actually only 2 could be used. There are 13 more transplant bricks which can still be used. So any of you who want help for one of your poor patient, please write to us. We will be more than happy to support you with that. Activity 6, finance section. This actually is one of the most difficult tasks that we had, is to get a CSR. So now Image can take funds from corporate social responsibility. So all the pharma or like the industry who are around, so it will be, as you all understand, it will be tax free, it will be counted, whatever is donated or given to our Indian Myeloma Academy Group will be under CSR. Second, we also have 23C under section 10, basically tax exemption. Any personal, individuals or organizations want to donate anything to Indian Myeloma Academy Group, it gets tax exempted. For individuals it's 80G, and for the companies it is form 56 or section 23C of section 10, para 23C of section 10C. So whatever money comes to us gets tax exempted. So we request philanthropic activity, because whatever funds that we are using is part of our audit report, which will be on the website. You can go through us how we are spending it. So it is only for the students and for the patients and for furthering the education. The last activity is, as far as is concerned, is a newsletter which we are planning to launch it today. So this is going to be a quarterly publication wherein we are going to capture everything which is happening as far as the myeloma care in our country is concerned. Currently, we have put it under some 8 subheadings. We would expand it depending upon the more and more content that we get. So for the launch of this, I will explain you once I show you the newsletter, but for the launch of this newsletter, I would request Dr. Nikhil Munshi sir to come onto the stage, please. E-launch, you have to just click it. Sir. That's it.
There you go.
Good luck. Please, thank you, sir. So this is a newsletter which is come up thanks to 4 people who actually bared me for the last few months. Arun, Sumit Mirg, Dr. Gurleen and Salim. Yeah. So we could actually come out with this. So I'll quickly take you through this as far as the newsletter is concerned. So this is a interactive PDF. You can actually select to see read whatever you want to read. So this is our first version, first issue. So the general clubs which are taking place. So all the general clubs, the person who presented and the institute which presented, they write a summary of this complete landmark article in their own words, non-plagiarized. Thereafter, whatever was discussed during the general club by the various national and international experts, such that we have a record of it, and for the students, we give them a synopsis of it. So the commentary includes what was being discussed. So the first one was by Dr. Aditya Jandial from PGI Chandigarh. The second was Dr. Sachin Puntar from TMH Actrec. And the third one was by Dr. Akshay Lahoti from TMC Kolkata. So they have written these particular parts. Now, for those people who actually couldn't attend it, so there is a video link at the bottom. So if you click those video links, it will directly take you to the YouTube and you can listen to it, that 1 hour session, whichever is there. The awards and accolades, in the last 3 months or 6 months, we actually had around 5 people who were awarded in various national or international organizations for plasma cell dyscrasias, for the research / publications / presentations for the plasma cell dyscrasias. So we tried to capture it here. We understand this list might not be exhaustive. We might have missed somebody. So if at all, if you can write back to us in the next edition, we'll make sure that that gets printed. Third part, the quiz. So we have 5 questions of every month, which has come up here, and we also have put up the names of the winners of the respective months. The answers are going to be discussed in detail, why that answer and why others are not as answer in the next edition. So from the next edition, you will also have a quiz answers with you. So these are the 3 months quiz that we had. This is about the Eagle Eye competition. So the best commentaries or the critical analysis of the recent articles what was written by the students, because by the time they submit their results and we give them back, we actually, most of the top journals, they give you only 2 weeks to 4 weeks for you to write the letter to editor. So they miss that, but still for the effort that they put in, we tried to put it here in our newsletter of what they wrote as far as this article is concerned, and whoever is the winner, he gets his photograph and the name there. So these are the 3 people who got it. Here I should say Dr. Sumit Mirg is the only guy who has written commentaries for every time since the inaugural till date. Thanks Sumit for your dedication and writing the commentaries every time. It shows your interest towards the academia and also towards the plasma cell dyscrasias. Next, coming to the National Myeloma Registry. So we have 32 centers, but we have put the names of the top 10 centers which have been contributing the data. So as of now, at position number 1, we have PGI Chandigarh with 1,150 patients registered on that, wherein they are updating and following up the real-time data. So a quick round of applause for PGI Chandigarh. Because it's a hell of a task to actually, because even if it is 5 patients, but to keep a follow-up data is not a very easy task. So it's very difficult to keep the follow-up data. And I would say TMC Kolkata has been really doing a magnificent job. In fact, TMC Kolkata is going to write up the article for both ASCO and EHA on request of Dr. Reena ma'am. For this year, they will be writing on behalf of Image the complete data set as papers for the coming conferences. This is a real-time analysis which is available on this link, wherein if you put 1 patient, additional patient today, the graphs change. You put 1 patient dies, the graph changes. So this is a real-time analysis thanks to Dr. Suman Pramanik. So this is, he had created it such a way, whatever gets entered in real time, the basic information, the analysis comes up and it comes up there. So he has put in effort to do this. So we have this. So as on date, we have 3427 as on today morning, 3427 total patients registered and total number of deaths 492 as given by the institutes. So this is what is as far as the registry is concerned. On the first page of the newsletter, you will find how you can join if your institute is interested in joining us. Coming to the Indian publication, we tried to compile the Indian publication in a 3-month period of September to November of all the publications which were published by any author from our country related to plasma cell dyscrasias. So it will be a quick reckoner for anybody who wants to know or want to write some bibliography or citations, that publications from India, it will be readily available. And the top 3 articles which we felt were really good. So Sumit wrote the prelude and the summary of those particular things. But from next month, next edition onwards, we would request, we'll contact the top 3 articles, we'll request them to give us a visual abstract, because nowadays it's the generation of the visual abstract. You give us a visual abstract or a video abstract, we'll put it up here, so that it will be easy for the reader to understand what you want to convey to the public. So these are the top 3 articles that we felt, and this is a complete tabulation of all the articles published from September to November 2022 from our country. And we also captured ASH 2022, all the papers which were published related to plasma cell dyscrasias have been tabulated here from our country. Again, anything if we are missed, we apologize for that. Please write back to us, we'll add it up in the next one. Coming to the fellowships, very important for the students and the junior faculty. So we have a 1 lakh rupee annual traveling fellowship labeled as Dr. General Velu Nair Traveling Fellowship for the people who would like to do observerships. Now this is apart from the awards that we are going to declare tomorrow for the oral papers, posters and for the quiz, which is the same amount again. It's over and above that, wherein we would like to allow one person who has actually done some work for the Indian Myeloma Academic Group or for the myeloma care in our country. We have some criteria. We select that. For this year, we selected Dr. Stalin Bala Chaudhary. A round of applause for Dr. Stalin. And we also have the annual awards, as I just mentioned. And we have monthly awards for the quiz, the Eagle Eye competition. And now the last part, for the undergraduate students, we have a facility of providing 10,000 rupees for any undergraduate who is interested in doing a short-term project related to plasma cell dyscrasia, 25,000 rupees for any PG student who is taking up thesis related to plasma cell dyscrasia, and 50,000 rupees to any PhD student who is doing any study related to, as far as the basic sciences, related to plasma cell dyscrasias. So please write up to us. Every year we haven't yet thought of how many of these we should allot, but depending upon the applications that we get, we have a fellowship committee under Image. They will decide about how many to be awarded, but this facility is going to be one thing which is going to help UG, PGs and the PhD students for furthering myeloma research in our country. Now people say कि भाई तुम्हारा society तो बहुत अमीर है, बहुत पैसे बांटते हो, but let me tell you, we are not. We cut down on everything. This is the first time that we had an event manager, but for the last 4 years, we have been struggling, whoever have organized, whether it is NIMS or whether it is SGPGI, whether it is TMH, ACTREC, we struggle day in and day out to save those 10 to 15 lakhs which go to the event manager, and that money goes as part of the people to help them out for the fellowships. For the journal clubs, for the journal stands, for various newsletter, we have got various third-party sources which can charge us heavily and do it, but thanks to the various young, dynamic, enthusiastic doctors who are trying to join hands with that, and all the money which is getting saved is going to help another student. So this is all the efforts of the doctors and the people who have been trying to help Image to further. We are actually one of the poorest of the societies. There have been societies with FDs of 25 to 30 crores giving the best paper award as 1,000 rupees. Okay, but we don't believe in it. We believe that the progress as far as the myeloma care or any care in the country can only happen if we encourage our students, because they are our future. Taking care of the students is a priority, more over and above taking care of the faculty, which we all need to understand and take it further in whichever area, whichever disease group we are working. Now, we also have in the newsletter the upcoming events, and we have actually given the registration links. So in the Essence of ASH, there is a beautiful session, one-day session on myeloma. We have the 4th immune effector cell therapies in multiple myeloma workshop at Boston, and we have our own IMS annual meeting, which is going to be at Athens, Greece this time. So the registration links are provided here. We'll keep updating it. So any new meeting which is going to occur in the field of myeloma, you don't have to search where do you want to go, present your papers, etc. You'll find it at one click in this newsletter, and you can do it. Now for all those organizers who are going to organize anything related to myeloma, please send us your link. We'll get it pasted here so that it get a wide publicity free of cost. So lastly, I would say this is a team which actually tried to put it together, and sincerely the 10 executive members, the senior most people in our country, I would really thank them for bringing all this thing out, because whatever maverick ideas that we have, they tolerate us, they bear with us, they say, okay, go ahead, let's see, let's go ahead with the 1 or 2 editions of it and then think about how to modify it. But they never said no to any of the activities that any of the junior colleagues in this society have come up with. So a message to all the junior people, any one of you having any new ideas, please write to Dr. Pankaj or any of the executive members. Okay, you know most of them, write to them. We'll be more than happy to take you along and make sure that your idea prospers. So this is as far as the newsletter is concerned. With this, I would like to close the secretary report for this particular year. Hopefully for the next year, we will have something better, and we will be able to project something much better than what this is. So the next year conference is going to be at the Oxford of the East, the Pune city. We welcome you all there, and please mark your calendar. Many of you have told us that we didn't intimate you for this conference in time. So this time we are giving you 1 whole year for you to mark your calendar, and we don't want any excuses for you saying that we can't attend the complete conference, because a conference success totally depends upon the people who attend it and who are part of it. So we want all of you to be part of this. Please mark your calendars. With this, I would like to hand over the stage to the President for giving the presidential address.
So good afternoon, greetings from the Image to all the seniors, mentors, international faculty, colleagues, students. So Uday has already presented, the full report. Now the pace of medicine these days is, progressing so fast that it is, difficult to keep track of all the new developments which are taking place not in the field of medicine. Even if you take one field like myeloma, it is so difficult to keep pace with all the updates, especially, in India, where we are, not only focusing on myeloma, we are focusing on all the disorders and in your busy practice. So, one of the function of image is to at least know what are the new developments and how much we can, apply those practices in, in our Indian setting. And Uday has almost covered all the things, but I think one most important thing is thank our international faculty. And a big round of applause, because they have been associated with us, and it is all the guidance from the international faculty, for the last 4 years, and we are trying to do this kind of awareness. Dr. Nikhil Munshi is the president of International Myeloma Society, and they are very happy to support image, and they are willing to support, and officially actually they are going to support. It is, this time we could not do it, but next time definitely we are going to have a symbol of International Myeloma Society. We are also trying to do that, to becoming a member of International Myeloma Society, that the annual fee of joining, that is reduced for the low and middle income countries. So hopefully that would be done. And the International Myeloma Society, the next conference is in Greece. So one of the function of image is that whatever people who are interested in the plasma cell disorders, whatever research which they are presenting here, and the international faculty is actually going to review that kind of a research, and you can, take their views, you can submit that research to the international forum also. So thank you so much, for all, and especially Shaji, we keep on sending the messages, emails, phone calls, and calling him, and every time he's available to guide us. So with that, I think again, thank you so much for coming here, supporting us. I know it is so difficult to travel, and you are also so busy in your work. So thank you so much, and thank you all the delegates and faculty who have come here. Thank you. Dr. Hari, I should thank actually Hari, to organizing this conference in the beautiful venue of St. John's. Many of us has actually come for the first time. It's a beautiful campus and beautiful organization. So thank you, Dr. Hari, my good friend and colleague.
Thank you, Pankaj. It's my proud privilege now to formally call our director, Father Paul Partharam, and the Dean of St. John's Medical College, Dr. George D'Souza, onto the stage. As is the norm, we would just go with the formal inauguration by lighting the lamp to formally inaugurate this this Congress. And so, can we just first get on to lighting the lamp? Please, I would like to always call the international faculty to come forward. Dr. Shaji, Dr. Nikhil, Dr. Vincent, and Dr. Nupur. Yes. Thank you, Father Paul. Thank you, Dr. George D'Souza. It's my proud privilege to invite Father Paul, just give a few words as part of the, and I would like to immensely thank the St. John's Medical College and Hospital for their unstinted support for the conduct of this conference, and whatever way I wanted, everything was just a blanket statement, yes. So, Father Paul.
Organizers of the conference, faculty members, and delegates, on behalf of St. John's National Academy of Health Sciences, it gives me great pleasure to welcome all of you to this St. John's campus. I hope that you are having a pleasant time on the campus, and of course, a very fruitful conference. St. John's is a group of 8 institutions, 5 on this 140-acre campus, and 3 on the outskirts of the city. And on this campus we have the central institution, the St. John's Medical College, which has got a history going back to 60 years. In fact, next year we are celebrating 60 years. And the St. John's Medical College Hospital, which is frequented by an average of 3,000 outpatients a day. And we have internationally reputed research institute, a standalone institute, and we are actually having this conference in the St. John's Research Institute. And of course we have a College of Nursing and an Institute of Allied Health Sciences. A word about the origin of this institution. This institution and this group of institutions were born out of a social concern. As we know, right to life is a fundamental right in our Constitution, but right to quality health care, affordable care, which is in a sense integral to right to life, unfortunately is not part of the right to life. As a result, we have a huge inequity in our country in access to quality health care. Quality health care has been, affordable health care has been largely a privilege of the elite classes, the rich classes, rather than a right of the poor masses. And the Catholic Church in India 60 years ago thought of addressing this inequity in access to health care, and they thought that the best way to do that is to educate and empower healthcare personnel who are committed to serve especially the underserved. And that's why this institution was established. And already from the 1970s, before anybody else thought about it, St. John's made every graduate, every MBBS graduate, to serve 2 years in the underserved rural areas of the country. Even today, we have about 400 such healthcare centers in the different parts of the country which are associated with us and where our students go and serve 2 years. And actually inspired by this mission of St. John's, some of the graduates have devoted their entire lives to serving in the underserved areas. And this concern for the underprivileged is also reflected in our medical admission policies. 30 seats of the 150 are reserved to the scheduled castes, scheduled tribes, and the OBCs. 10 are reserved for the faculty members, children of our faculty, no, staff members, so that we have children of our sweepers and helpers and gardeners becoming doctors in this institution. And then 20 are reserved for those who have committed their lives to serving the underserved. So we have, therefore, in the NEET ranking, those who join from these classes for whom seats are reserved, they will never get admission in any other medical college. And even though we are taking in people who have got very low NEET ranking, we are proud to say that our faculty has done such a fantastic job of mentoring them, hand-holding them, and educating them. St. John's is today one of the reputed medical colleges in the country. I think the third or the fourth best private medical college in the country, as by recent estimates. So that is the mission that drives St. John's, and we are happy that you are here. And myeloma care is now, I suppose, the most important thing. And I'm very happy that Dr. Harry Menon is here, giving leadership to our care in this oncology care. We hope that over the years, St. John's will become one of the most outstanding contributors in myeloma care. Once again, a very hearty welcome to this institution. I hope you have a good stay and a fruitful conference. Thank you.
Thank you, sir, for that update, and also to what St. John's is all about. And thank you for coming, for being part of this Congress. And I thank Dr. George D'Souza also, who has graced this occasion. We have the proud privilege to actually, as part of this inaugural ceremony, to also to felicitate some of our very senior faculty. And to start with, it's my proud privilege to invite my teacher and mentor, Dr. Vinod Kochipule, who's been a teacher to several students, and I could see when she walked in today the number of people who had come to meet her, and I could see the great joy on her face to meeting her students. And to start with, we would like to felicitate Dr. Vinod Kochipule on this occasion. She is one of the pioneers in oncology care in the country. She is the former director of Institute Rotary Cancer Hospital, All India Institute of Medical Sciences. Her key research work was in bone marrow failure syndromes. She has gone pioneering work in fetal liver transplants, fetal liver cell transplant aplastic anemia. And I know for a fact how keen she has been in research, because when I was doing my thesis topic on acute myeloid leukemia, I know I had just 2 days to submit my final thesis work, and she sat up till 3 o'clock in the morning to correct my paper, and so that I could submit it on time. So welcome, madam, and I would like you to come forward and say a few words to
Thank you, Hari, for inviting me here. I did not know that I'm supposed to speak also. I just came to attend your function. But I was so happy that I was called here because I met so many of you after so many years. And it's just wonderful feeling to see all of you doing so well and taking oncology forward, which was needed. You know, when I joined All India Institute way back many years ago, there were hardly any medical oncologists in the country. So it was not easy. In fact, I still remember that I got my training in USA, and there, at that time, there was hematology oncology, which was together. You know, there was no separate oncology. So when I applied for the oncologist post in AIMS, they rejected my application. They said, well, you are hematology oncology, you are not oncologist. So I said, well, this is something which was, in India at that time, there was no oncology training at all. So I had to convince them that this is the way it is as of now. So that is how I came to be an oncologist at AIMS, New Delhi, and was able to introduce the DM program there, which has produced such wonderful people. Atul is there, Hari Miran is there, and Manju and Shaji, so many of them, and now doing so well. Thank you so much.
ಅಲ್ಲಿ ಹೆಂಗಿರುತ್ತೋ ಆ್ಯಕ್ಚುಲಿ ಹಂಗೆ ಕಾಣಿಸುತ್ತೆ ಸರ್ ಇಲ್ಲ ಅಲ್ಲಿ ಫುಲ್ ಸ್ಟಿಕ್ ಬಂದರೆ ಕರೆಕ್ಟಾಗಿ ಸ್ಪೇಸ್ ಮಾತ್ರ ಇದಾಗುತ್ತೆ ಮೇನ್ ಪ್ಯಾನಲ್ಲಿ ಇದು ಆ್ಯಕ್ಚುಲಿ ಹೆಂಗಿರೋ ಹಂಗೆ ಬರುತ್ತೆ ಇದು LED ಸರ್ ಅದು ಪ್ರೊಜೆಕ್ಟರ್
ಅದಕ್ಕೆ ಚೆಕ್ ಮಾಡೋದು ಥ್ಯಾಂಕ್ಸ್
Good afternoon to all. We will now begin with our e-poster presentation, which will be happening in simultaneous sessions in halls A and B. Our judges for the session in this hall are Dr. Nikhil Munshi, Dr. Vincent Rajkumar, and Dr. Sadashivadu. The rules for this session are, firstly,
have anything in the CBC like peripheral smear with circulating plasma cells, they usually behave like people who have plasma cell leukemia. Very aggressive disease. And yeah, so you're right. It's possible that it was disease progression.
thank you, Dr. Sushmita. Next we have Dr. Sundar.
Can I start? Yeah. So good afternoon all. I am Dr. Sundar from Tata Medical Center, Kolkata, and hereby I am presenting my poster, Experience of Daratumab Therapy in Relapsed Refractory Multiple Myeloma at Tertiary Care Center. So immunotherapy is changing the paradigm of multiple myeloma management, and we last 2 days we are seeing that different trials showed efficacy of daratumab monotherapy as well as combination in multiple myeloma in a relapsed refractory setting. Our purpose of the study is to demonstrate a disease control rate of a daratumab when given as a monotherapy or combined therapy in a relapsed refractory setting, and our primary objective was to check a disease control rate in a relapsed refractory myelomas. Our secondary objective is to assess the progression-free survival of and overall survival in a myeloma where we use daratumab in a relapsed refractory setting. We use daratumab 16 mg per kg once a week in cycle number 1 and cycle number 2, and cycle 3 to 6 as a 16 mg per kg once in 2 weeks, and then cycle 7 onward once a month we use this daratumab. So we included all myeloma patients who were actually refractory to the multiple lines, and we excluded all patients of myeloma who where we used daratumab other than a myeloma setting, or where we used this daratumab less than 1 cycle. We excluded plasma cell leukemia 3 cases, plasmablastic lymphoma, and cycles where we use less than 1 cycle from main analysis. So we had total 43 patients. Out of them 38 were multiple myeloma, 3 were plasma cell leukemia, 1 was plasmablastic lymphoma, and 1 was AL amyloidosis, where we used daratumab in all these plasma cell disorders. And in a main analysis, if you see a multiple myeloma setting where there were only 34 cases where we used daratumab, and most common line was third line. Our progression free survival and overall response rate, if you see that disease control rate was 67% at 3 months and 40% at 6 months. And our median age was 60. Cytogenic analysis, most of they were high risk, and if you compare with overall worldwide data, our PFS was 6 months. Median PFS was 6 months, and overall survival rate was 83% at 24 months. So our main conclusion is daratumab provide reasonable progression survival, disease control rate, and overall survival in relapsed refractory setting. Sir.
Do you face any problem during administration, or any adverse effects have you recorded?
Only one case had, sir, severe reaction. Other reaction, it was very well tolerated, sir. Yes, sir.
Okay. So, what was the response rate and outcomes in patients who got DARA alone versus DARA in combination? Or how many patients got alone?
We actually, sir, we had one DARA monotherapy trial. So in that there were 12 patients, but since it was in a trial, so their monitoring was better. So actually their response was better. While in combination therapy, most of they were in a later line of use, and they were refractory cases. Somehow they also have high risk cytogenetics. So their response somehow it was inferior, sir. Yes, sir.
So I think when you present this next time,
sir,
you should make sure you can split the two groups so people can understand what happened with each group.
Sir, yes. Thank you. Thank you.
Thank you, Dr. Sundar. Next we have Dr. Suraj Vasudevan.
Good afternoon. I'm Suraj Vasudevan from the Department of Hematology and Bone Marrow Transplant at Bangalore Baptist Hospital. I'm here to present to you our study on the clinical profile and outcomes to induction regimens of chemotherapy in patients with multiple myeloma at our hospital. We conducted a retrospective cross-sectional study from September 2018 to October 2022, where 57 patients were included in our study. We noticed that 56% of the patients were males and 44% of the patients were females. 31 of these 57 patients were below the age of 65 years, and 26 patients were above the age of 65 years. We noticed that patients who received induction regimen of chemotherapy, 60% of these patients showed very good partial response to induction therapy. Less than 2% of the patients showed relapse of disease, and less than 10% of the patients showed progression of disease. 44 out of the 57 patients received VCD regimen of chemotherapy, out of which 61% of the patients showed very good partial response, and nearly 10% of the patients showed partial response to chemotherapy. From this, we understood that patients who are taken up for induction therapy early on during diagnosis show good response to therapy, especially VCD regimen chemotherapy, and if followed by transplant, there is good outcome for the transplant also. Thank you.
What did the other patients get, and what is the response to transplant?
We've taken 13 out of the 57 patients for transplant, and 17 of the patients showed good response to the transplant post-inductions.
So most of these patients were treated relatively recently, right? Like just in the last 4 years?
Last 4 years, yes.
So why was VRD not used and most of your patients got CTD or BCD? Was there an institutional thing?
It was more of an institutional protocol. There were some patients in the study that did receive KRD and KDD regimens of chemotherapy, but most of VCD was preferred.
How many had renal dysfunction?
Nearly 30 to 40% of the patients did have.
And any data on how they did after the treatment? Did they recover their renal function?
This was out of the scope of our study. I'll look into it.
Yeah. Okay. Good.
Same thing I wanted to ask, because the VRD is standard of care of VTD now.
Right.
So only VCD you used. Is there any specific reason I wanted to ask? But sir is asking.
It was an institutional.
But still.
Yeah. Okay.
But have you have any something compared to data in the previous or any other?
Currently, I don't. I will look into it.
Very briefly, one question. Do you think this 25% loss to follow-up is slightly more for comfort, and any reason for this?
Sir, if you look at the 25% that's lost to follow-up, it's a very small number of patients, which is out of 4 patients, 1 is lost to follow-up. So that's in the CTD regimen that you're looking at.
And above that, you have 30% loss. So every 1 in 3 patients is getting lost to follow-up. So it's like a financial or travel issues. Can you put some light on that?
Yes, sir. So when I say lost to follow-up, some of the patients are actually lost to follow-up. Some of them have changed over to another regimen of chemotherapy, or they preferred palliative care after a few cycles of therapy.
Thank you.
Thank you.
Thank you, Dr. Suraj. Next, we have Dr. Sushmita.
Good afternoon again. I am here to present the NIMS data on response to triplet regimen in newly diagnosed multiple myeloma and institutional experience. So this is an observational study which included 19 newly diagnosed multiple myeloma from 2018 to 2022 who have received chemotherapy in NIMS hospital, and patients are evaluated for response after 4 to 6 cycles of therapy, and response is evaluated as per the IMWG response criteria, and patients are classified based on the response pattern into 3 groups like responders, partial responders and non-responders, and we identified different risk factors and correlate with them with the response. And among 40% of the patient each received a VRD and VCD treatment, and after 4 to 6 cycles of chemotherapy, approximately 61% of the patient had at least VGPR, that is very good partial response. 28% of the patient had partial response, and 11% of the patient did not respond to chemotherapy. However, there is no statistically significant difference in the response with VRD and VTD or VCD regimen. Regarding the VRD or VTD regimen, there was some associations between the immunoglobulin subtypes and impact on response. Majority of the patients who had partial response had IgG myeloma, and all of the patients, that is 5 patients who did not respond to chemotherapy, had IgG myeloma. And apart from this, less than age, that is 60, less than 60 or more than 60, bone marrow plasma cell less than 60% or more than 60%, and stage of the disease, that is either stage 1, 2 versus stage 3, had statistically significant poor impact on response. On the other hand, there is no significant association found in any of the risk factors while we give VCD regimen. So this is a small sample size, so further studies are required to confirm my conclusion.
So there are no patients here who got complete remission.
Now, that was included in the first group, at least VGPR or better response. They are included in the responders group.
So do you know how many got complete response? Because that is our small ultimate response.
Yeah, around like 45 to 50% had a, 30 to 40% had a complete response.
30 to 40% total, or of those who have VGPR?
No, in both combining the VCD and VTD, approximately 30 to 40% had a complete response. Not stringent, complete response.
Okay. And do you, I think there was a data presented, do you do MRD measurements?
No, no. As of now, we are not doing MRD assessment. Thank you. Thank you.
Thank you, Dr. Sushmita. Next, we have Dr. Rafika.
Good afternoon all. I'm Dr. Ripika. I'll be presenting my e-poster today. The topic is Study of Recurrent Genetic Abnormalities by Fish in Newly Diagnosed and Relapsed Refractory Multiple Myeloma for Risk Stratification. It is a cross-sectional observational study conducted in a tertiary care institute in North India in AIIMS Rishikesh. Objectives of the study was to estimate the frequency of recurrent genetic abnormalities in both newly diagnosed and relapsed refractory cases, and then to risk stratify the myeloma patients by ISS and RISS staging. Materials and methodology. It is a cross-sectional observational study conducted in the Department of Medical Oncology, Hematology and General Medicine at AIIMS Rishikesh. The results of our study were, we analyzed the data from 88 patients, and out of 88, approximately 55% of the patients were found to have one or the other genetic abnormalities, and 45 patients were negative. And the most common abnormality we detected were deletion 13q14 in 24% of the patients, followed by 1q gain in 12% of the patients. Other abnormalities detected were deletion 17p in 6%, translocation 1416 in 2%, translocation 414 in 4%, translocation 1114 in 4%, and trisomy 17 in 3%. The 3 patients belong to double hit myeloma category, and 3 patients belong to triple hit myeloma category. Most of the patients, approximately 77%, belongs to the standard risk category, and only 23% belongs to the high risk category. Now coming to the myeloma prognostic index, majority of the patients belongs to ISS stage 3, followed by stage 2 and stage 1. And in RISS staging, most of the patients belongs to RISS stage 2, followed by RSS stage 3, and then RSS stage 1. Conclusions. So in our study, most of the patients were in ISS stage 3, which correlates with the evidence from the previous literature from India. As per our ISS staging, more than half of the patients were in RSS stage 2, and the most common abnormality we found is on fish analysis deletion 13q. This is in concordance with the few similar studies in the literature. This might be due to the genetic and ethnic variability. Thank you.
So, most patients with myeloma have some cytogenetic abnormalities, and you did a pretty good fish panel. Why do you think that half of the patients are negative? What do you think is happening?
There might be a sample error, or the sample size is also small, only 88 patients we could enroll due to the COVID times. This study is conducted in 2019 and 20. So, and the sick patients might not be able to reach the hospital.
So most likely what happened here, just for your own information, is that the probes that they've used are all for either high-risk abnormalities or for the IGH translocations, but not to detect trisomies. So most of those who are negative are probably trisomies, but you didn't have probes for chromosome 3, 5, 7,
Yes.
like that to pick it up. The other question is, you have patients who have deletion 13. If they also had a 414 or 1114, where would they be on that chart? Would they be counted as 1114 or would they be counted as del 13?
Sorry, sir, I didn't get
So,
it.
because the same patient can have two things,
Yes,
right?
sir.
So which one would they go into if they had, say, both a 414 and a del 13?
Sir, we have calculated for, like, if a patient has deletion 13q and translocation 414, we have calculated that patient in both the
Oh, you
abnormalities.
One question, Dr. Rivika. So at Rishikesh, do you have any
providing ICU and only one was disorders. So daratumumab is pretty safe in our setup. And we have started, as was already discussed, we have started increasing the infusion rate of the drug. Thank you.
So there are two groups, one with carfilzomib and one without, and it looks like PFS is better if they are not exposed
Yes,
to
sir, that is what
carfilzomib.
our study has told us.
So is it because, what is the difference in number of previous lines of treatment? Is it that people who got carfilzomib had many more lines than the other group?
No, sir. Most of the patients had a median of 3 lines, but there were only 2 patients who had received 5 lines of therapy prior to daratumumab and carfilzomib exposure. There was also a little bias in data because a lot of our patients had received for maintenance daratumumab in other setup because they were from other countries.
So were there some patients who had previous daratumumab as well before they were taken up for this analysis?
No, sir.
The same?
No, sir.
Okay, what was the dose you have given the carfilzomib dose?
So we had initially given like the 2 days in a 8, 15, 28 days regimen for 2 cycles. And then we had given the two doses in the subsequent cycle. 70 mg per meter square, basically, the dose.
Thank you, Dr. Aishwarya. Next we have Dr. Suraj Vasudevan.
Good afternoon again. I'm Suraj Vasudevan from the Department of Hematology and Bone Marrow Transplant at Baptist Hospital. I'm here to present to you our study on the outcome of low dose versus high dose dexamethasone in patients with plasma cell disorders. We conducted a retrospective cross-sectional study from September 2018 to October 2022, where 57 patients were considered in the study. Low dose dexamethasone was dosed at 20 milligrams and high dose dexamethasone was dosed at 40 milligrams of dexamethasone. 27 of the 57 patients received 20 milligrams of dexamethasone and 30 patients received 40 milligrams of dexamethasone. In our study, we observed that 67% of the patients in both arms of our study showed very good partial response to the respective doses of dexamethasone. Also, 0% of the patients who received low dose dexamethasone showed relapse of disease. Hence, we concluded that low dose dexamethasone is non-inferior to high dose dexamethasone. However, we observed that progression of disease was seen in nearly 15% of the patients with low dose dexamethasone, in contrast to nearly 3.5% of the patients in high dose dexamethasone. So we noticed that our study had certain shortcomings. One is that we needed to conduct a multivariate analysis of various induction regimens, and two is we needed to take into account the route of administration of dexamethasone to come up with a statistically significant conclusion on the effect of these shortcomings on our study. Thank you.
So dexamethasone was obviously part of a combination.
Yes, sir.
So what were the other drugs that were, and they were same for everybody or they were different?
The other drugs were not the same, sir. In our study, we only considered dexamethasone alone, but we did have bortezomib, cyclophosphamide, lenalidomide as other drugs in various regimens of chemotherapy.
So when you want to compare one versus another dose,
Right,
you need to make sure that both the group have similar combination.
Right, sir.
So you want to look at that because
Yes.
if one group has more lenalidomide and the other has cytoxan, the lenalidomide group is going to win.
Yes, sir.
And if that could be 20 or 40 milligram, so you want
Right,
to
sir.
make sure
Yes.
that they are similar.
That was the shortcoming
or
we
described.
realized. Yes.
Is it a sequential manner? How did you do this sequencing? 20 or 40 mg? How did you decide on that?
That was based on physician discretion. So it was based on the patient's age, frailty, based on other comorbidities of the patient. It was based on the physician discretion at the time of assessment of the patient, sir.
Because the frail patient, definitely their performance state is very poor and they may not tolerate the high dose
Right,
also.
right, sir.
I think what we sir mentioned clearly, I think we should have the complete data on other drugs
sir.
accompanying this dexa should be.
Yes, sir.
So, you know, when you use the word non-inferior, you have to be very careful because there is a certain requirement for non-inferiority.
Yes,
Like, generally, it will take 1,000 patients to decide something is
Yes,
truly
sir.
non-inferior. So you can just say that we didn't see anything, but not use that term because that term statistically
Yes,
has
sir.
a certain meaning, just like statistically significant means something.
Yes, sir.
When you conclude something is non-inferior, that requires a very high standard.
Correct. Thank you.
Thank you, Dr. Suraj. Next we have Dr. Abhinav Kumar.
Good afternoon, sirs. Before designing this study, we had a clear research question in our mind. The biggest hurdle facing B cell dyscrasias in our country is the patients present very late, mostly with complications like a pathological fracture. So we tried to design a targeted screening strategy for MGUS in patients of our country, which is cost effective and can be reproduced in almost all centers across India. So what we did, we designed a prospective observational study. We made a cohort of hospitalized patients who underwent LFT screening test for various indications, and we recorded the number of patients who had albumin globulin ratio reversal on these LFTs. What we found out that out of the 4,400 samples of liver function tests that we screened in our hospital, around 4% patients of 178 patients had an albumin globulin ratio reversal. Now we used the exclusion criteria where we excluded those patients who had a very obvious reason for albumin globulin ratio reversal, like proteinuria or a patient with CLD or ongoing inflammation or an infection in these patients. And at the end, we were left with around 27 patients. All these patient samples were sent for a serum protein electrophoresis. What we found out that out of all these 27 patients, we do not had a MS spike in any of those samples. So this is an interim analysis. We target to run at least 100 samples. At this point, we found out that albumin globulin ratio reversal is not a good targeted screening strategy for MGUS, especially in a patient who are hospitalized. After this interim analysis, we plan to course correct, and we plan to go out in the community. We take samples of LFT in patients who are above 50 years of age, and we plan to see for albumin globulin ratio reversal and further send their samples for serum protein electrophoresis. Thank you.
Do you have why were you thinking of screening the population?
Sir, in our country, we do not have a standardized screening protocol for MGUS. The patients generally present very late, and we are late to intervene in these patients. We have high mortality because of that. Anyways, sir, we are not able to stop the progression of the disease or delay the progression of the disease. That's why, sir, we try to design a strategy for screening, which is cost effective maybe.
And were you able to identify what were the confounding factors?
Sir, we try to exclude, we try to be very objective in these patients. We excluded all the obvious causes of albumin globulin ratio reversal. However, still in all these 27 patients, we did not get any M spike. So,
and these were all patients from the Army Hospital?
Yes, all these patients were admitted or were receiving treatment in the OPD.
Because one of the cause could be nutrition, but I think their nutrition would be pretty good.
Yes.
The problem here is because all of them are patients. They have admitted in a hospital for different reasons. They are unwell already.
Yes.
So if you collect the sample, I think it may not represent the.
That's why, sir, we are going to course correct. We are going out in the community, going to collect the samples from the community and then see if this strategy works out.
Yeah, one is the community. Otherwise, for example, for some people, they go
sir, there are affiliated villages to our hospital where we treat these patients or people. So from there. Thank you.
Thank you, Dr. Abhinav. Next we have Dr. Anuruddha. Is Dr. Anuruddha in the audience? Moving on to the next contestant, we have Dr. Sauvik Saha. Next we have Dr. Akash.
Good afternoon. My name is Dr. Akash Chorkar. I'm highlighting this particular case for the rarity of presentation as well as the issues faced by us in a resource-constrained setting like ours. So this particular gentleman is a 45-year-old male smoker, manual laborer. He presented to a peripheral center with the main complaints of generalized body ache as well as non-cardiac chest pain. He was evaluated there. The basic investigations were normal. Then imaging was done. An HRCT chest was done, which showed a large perihilar mass, which was causing narrowing of the main bronchus as well as abutting the various mediastinal structures. There was lytic lesions in the screen vertebrae as well. There was some subsymptomatic mediastinal lymphadenopathy. This particular patient was referred to us with a case of metastatic CA lung, and that was how he was prognosticated and explained to the patient. We had investigated, a bronchoscopy was done which showed a nodular lesion with mucosal infiltration in the distal end of bronchus with a complete narrowing with the possibility of neoplastic lesion. Now this particular biopsy was taken from the bronchoscopy and is evaluated at our department of pathology, who did not have IHC at their disposal, and morphologically they said there was hyalinized tissue as well as multiple gland formation with the possibility, given the clinical scenario, they gave a diagnosis of adenocarcinoma. Now this particular biopsy we had outsourced, and an IHC was done in this particular thing which showed kappa restricted CD138 cells and negative myeloid, so diagnosis of plasmacytoma was made. Then we had done a further evaluation. Bone marrow showed 2% plasma cells, as well as we did a light chain assay which showed kappa by lambda ratio more than 12,500, hence meeting the myeloma defining event as put up by the IMWG. This particular patient was treated with VRD regimen. Post 4 cycles we were evaluated with light chain ratio which showed VGPR. CT imaging was also was done which showed resolution of the lung. We have not done a PET scan as well. The patient is being added to the transplant list. He has been continuing the VRD regimen as such, and based on the response will be taken up for autologous transplantation henceforth. Thank you.
Do you have any fish or cytogenetic data from the lung lesion?
We have not done, sir.
None.
Any PET CT has been done?
No, sir. Actually, there was financial constraints from the patient side, so we had done a CCT, and which was evaluated basically for the CA lung workup, which was initially presumed as.
So do you have the answer to the question, which one came first?
It is, given its plasma cells, we have to say it is from the bones, I would say.
So if you do sequencing, you could quite often figure out where it started. And there are, if the main clone is in the bone marrow and then the subclone is outside, you can predict or you can guess or quite often confirm which came first.
Okay.
It's quite often interesting question where it started. Okay.
Thank you.
Thank you.
Thank you, Dr. Akash. Next we have Dr. Ashwin Nair.
Good afternoon to all. I'm presenting a very short but a unique case series from our institute. So basically this is a case series of 11 patients with clival plasmacytoma, and basically as we all know, clival plasma is a very rare entity with less than 1% of plasmacytomas being clival. So this was a retrospective analysis of from our institute from 2012 to 2022. So in the past 10 years, we found 11 cases of clival plasmacytomas. So I want to clarify, first of all, it's not solitary clival plasmacytoma. These all had concomitant systemic multiple myeloma also. So out of the 11 cases, 7 of them presented with clival plasmacytoma at their presentation, whereas 4 of them had a progressive disease as, or they had a clival plasmacytoma as they had a progressive disease. The most common clinical presentation was definitely cranial nerve involvement. And among that also, it was a 6th cranial nerve which was most commonly involved. Coming to the other CRAF features, the most common CRAF features were the lytic lesions, bone lytic lesions, and in the SIFE it was a very heterogeneous group, like we had IgA kappa, IgG kappa and IgG lambda, all 3 of them quite equally represented. Of all the 11 patients, 8 of them had bone marrow showing clonal plasma cells, whereas 3 of them did not have bone marrow clonal plasma cells. And only 3 patients cytogenetic reports we have with us, and of those 3, if you can see, 2 of them had high-risk disease, and one of patient actually died, and other one was lost to follow-up. So cytogenesis definitely have a role even in this situation. Coming to the therapy that was given to these patients, so 8 of them received radiotherapy to the plasmacytoma, which was in the range of 26 to 40 gray, and they also received concomitant systemic chemotherapy. Usually it was around 1 to 2 lines of chemotherapy, but some people even required 3 to 5 lines, and in most of the situations we had to sort to alkylating agents. In 3 patients adriamycin, and in 1 patient bendamustine was given, but all of these patients usually had a bad outcome. So basically it's a unique case series, and one of this patient underwent an auto HSCT also, and that patient is doing quite well right now. The median OS was 35 months in this case series. Thank you.
So, you know, with this, some of the main questions that come up is like, what happened to the cranial nerve lesions? Did they all improve, all 8 of them?
Yes, sir. A lot of so the patients who are still alive, in all of them, the cranial nerve lesions had improved, and even in the ones who had died, initially the cranial nerve involvement improved with treatment. So the important thing over here is that only 3 of them were histologically diagnosed, because we are still, you know, as far as endoscopic biopsies are concerned, we are still not it's in a growing phase,
yeah.
And maybe that is one of the reasons why we are not diagnosing solitary plasmacytomas.
Yeah.
You know, we are requiring systemic when it is only then that case is one of the reasons. And
so my advice would be, this is the type of thing where you do have something very interesting. You know, you've just looked at clival plasmacytomas, how they present.
Yes.
But the main information that's missing is how did the patient respond to therapy and how often was it reversible? And then because you're mixing patients who are newly diagnosed with patients who are getting these plasmacytomas later and mixing patients with one versus multiple lesions, it's hard to get a natural history. So what I would encourage you to do if you're pursuing this is just work with other people, whoever can collaborate with you, collect a case series.
Yes, sir.
But when you report it, it should be all patients with clival plasmacytomas at diagnosis, in the context of myeloma or just by itself. And then what is the specific outcome with radiation alone, with radiation plus chemo, so then we can learn from it.
So when did you incorporate the radiation into this picture?
So most of the patients received at the time of diagnosis itself.
Diagnosis
Yeah. So only 1 or 2 patients did not receive because maybe the PS was too poor at that time for them to, and so all of them have systemic disease also. So a lot of patients responded with chemotherapy also. So it's difficult to say, but definitely RT was given to 8 patients and all of them have responded. So most of the patients initially had response in cranial palsies. The recurrence of plasmacytoma was not common. So we did not see that the glioblastoma was coming back again in these patients. It was mostly the progressive disease which led to their death.
So one question could be, why is clivus a more frequent area where you can see plasmacytoma? And to answer that, you might want to know how many patients did you screen to find this?
Definitely,
so is it 1% or is it 12%?
Yes.
And that would make it more meaningful. That is it a common site for involvement, or this was just by chance there were 11 patients with that?
Definitely. So like 3 of them were ones who had actually gone to neurosurgery OPDs. So they had cellular mass and then it was diagnosed. So usually, so it's important, it's basically just to know that for a cellular mass, glioblastoma should be an important DD for us. So I think more cases will come up as the neurosurgical and ENT people are doing more biopsies and all those things. That's the thing. Thank you so much, sir.
Thank you, Dr. Ashwin. With this, we come to an end to the e-poster presentation. I thank the judges and all the contestants. The results for the e-poster will be available tomorrow. We now proceed with the next session of CME talks on other plasma cell dyscrasias. Our chairperson for this session is Dr. Hemant Malhotra. We invite Sir to the dais to introduce our speakers. Dr. Malhotra is Professor and Head, Department of Medical Oncology and Director, Sri Ram's Cancer Center, Mahatma Gandhi Medical College and Hospital, Jaipur.
So thank you, organizers. Good afternoon, everybody. Pleasure and privilege to invite our dear friend Dr. Shaji Kumar once more to the dais. He's already spoken to you, I think, more than 2 times. He doesn't need to be introduced. I'll just mention his topic. He's going to talk to us about amyloidosis, the optimal management of amyloidosis, which is, I think, a little bit of gray area for quite a lot of us. Over to you, Shaji.
Thank you, Dr. Malhotra, and thank you everyone for being here this afternoon. So what I'm going to do is to talk about some of the recent improvements or recent therapies for patients with light chain amyloidosis and how it's changed the outcomes. These are my disclosures. So as you all know, light chain amyloidosis can be a difficult disease to diagnose in the clinic because of a very varied presentation given the multiple organs that can be involved in the context of light chain amyloidosis. Now, the key to making a correct diagnosis of light chain amyloidosis is to have that clinical suspicion based on the various syndromes that these patients are likely to present with. And again, this is mostly dictated by the spectrum of organs that are involved with light chain amyloid deposition. So how do you detect amyloid? We talked a little bit yesterday at the diagnosis session about making diagnosis of amyloidosis. The key to making a diagnosis of amyloid is demonstrating the presence of amyloid in the tissue, and the tissue that is easily accessible and where we can find it most commonly is the fat and the marrow. So subcutaneous fat aspirate along with bone marrow biopsy typically would give you an idea or will demonstrate the presence of amyloid in about 80 to 90% of the patients. And for the remaining patients, we have to do an organ-directed biopsy in order to get or demonstrate the amyloid deposition. And the organs obviously will depend on what you clinically suspect is involved. And the tissue diagnosis for the longest time had been based on two specific approaches. One, again with the Congo red stain, if you can see apple green birefringence under polarized microscopy, as you can see here on the left hand side most ones. And then the second has been immunofluorescence, again staining this tissue for kappa or lambda. You can again demonstrate that this is a light chain associated amyloid, and so is the cause for the other proteins. As you all know, there's probably around 40 different proteins that have been described that can cause amyloid deposits. But for today's discussion, we are focusing primarily on light chain amyloidosis. But what has really changed the field in terms of, from a diagnostic perspective, has been the introduction of mass spectrometry for identifying the protein of origin in these patients. So it's fairly simple process. You have a tissue in front of you where you can demonstrate amyloid. You do a laser capture microdissection and subject that tissue to trypsin digestion followed by tandem mass spec. And then the peptide profile that you get from the mass spec is then compared to a large database that contains the profile for a variety of different proteins, and that way you are able to say this is the protein that led to the amyloid formation. Once you make the diagnosis, the next step is to again risk stratify these patients. And there are several risk stratification systems that have been developed. Many of them have been primarily focused on the organ involvement, predominantly the cardiac involvement, which is a main driver of prognosis in the short term. Now this is the revised Mayo staging system that incorporates, in addition to the cardiac biomarkers, also uses serum-free light chain. So instead of just capturing the immediate outcome based on the organ involvement, it also gives you an idea of what the long-term outcome is based on the presence of the underlying or characteristics of the underlying clone. So as you can see here, the NT-proBNP and CTN, the cardiac troponin, being the two markers of organ involvement, and the serum-free light chain, which is more related to the underlying plasma cell clone. So once you do the risk stratification, the next step is to again start treatment for these patients. So the question is, what are the goals of therapy? So the main goal, the goal of therapy in light chain amyloidosis is to make sure we eradicate the clone to the maximum extent possible, and we want to get the light chains to normalize, or at least close to being normalized. Given that the light chains are the responsible for the amyloid deposits being formed, by basically reducing the light chain levels to normal, you can actually stop that amyloid forming process. The second thing is to make sure these responses are durable. And at the same time, unlike myeloma, these are patients who are much more susceptible to the toxicity of therapy, and also can have a variety of, already have significant organ dysfunction even coming into therapy. So I think to some extent that risk adaptation of the therapy is very, very important for these patients. And to a large extent, in addition to that plasma cell clone directed therapy, we also have to focus on the supportive care for these patients. Now we know from multiple studies that if you can get these patients into a deep hematologic response, then these patients have a better outcome. And so is true if you have a good organ response, their outcomes are better. Now the problem is, for most of the therapies, the organ response can take 6 to 12 months to become manifest. So in the short run, we are really dependent on the hematologic response as an indicator as to whether your treatment is working or not. And we know also from multiple studies now, if you can get patients into a hematologic complete response, those patients have a very high likelihood that their organs are going to improve, and the patients will have a better longer term survival. So what are the treatment strategies for patients with AL amyloidosis? Now you can broadly classify them into two. So one of them is to do plasma cell directed therapies, so which is the type of treatments we've been talking about for the myeloma, which includes immunomodulatory drugs, the proteasome inhibitors, transplant, etc. And there is an increasing portfolio of new therapies that are being developed that are targeting the amyloid fibrils itself. Some of them are monoclonal antibodies that are going through clinical trials, which can essentially increase the body turnover of those amyloid fibrils. And there are some drugs like doxycycline that have been shown in animal models to actually inhibit the fibril formation as well. So, most of the treatments that we have today in the clinic are mostly targeted towards the ones that are targeted towards the plasma cell clone. So I'm going to be focusing mostly on that. So one of the treatments that have been shown to be effective in patients with light chain amyloidosis is an autologous stem cell transplant. Now, there have been limited prospective trials looking at the role of autologous stem cell transplant, and a lot of the data have come from the retrospective experience, including a more recent one from the CABMTR. Again, showing that the treatment-related mortality for transplant in AL amyloidosis is significantly decreased over time. And also the transplant can lead to very durable outcomes, and especially when you look at this, the blue curve, you can see a fairly nice plateauing of the curve, both in terms of the overall survival in patients with light chain amyloidosis undergoing stem cell transplant. Now, the reason that autologous stem cell transplant has become safer in these patients is that we are selecting these patients in a much better fashion. So this is the eligibility criteria for going to a stem cell transplant that we utilize in the clinic. Physiological age of less than 70, a good performance score, no significant cardiac involvement as indicated by the cardiac biomarkers, and good renal function, and no more than 2 organs significantly involved. Now, obviously, the problem with restricting the eligibility is very few of your patients are going to be eligible for a stem cell transplant, and probably no more than 10 to 20% in most of the institutions, the light chain patients can go to a stem cell transplant. So, what are the other therapies that we have available? I think one of the first large randomized trials that was done in the setting of newly diagnosed amyloidosis was the Andromeda study. So before this trial was done, the combination of bortezomib, cyclophosphamide, and dexamethasone has been had been the standard of care for patients with newly diagnosed amyloidosis, primarily based on small phase 2 studies and retrospective trials. So the Andromeda study actually randomized patients to getting VCD versus daratumumab added to VCD, with the VCD just continued for 6 cycles, and then the daratumumab in that arm continues for a total of 24 cycles. With the Andromeda study, we saw that when you look at the percentage of patients who get to a complete response, you can see that it's almost threefold with the addition of daratumumab compared to just VCD alone. And when you look at the organ response rate, you can see that it's roughly double with the addition of daratumumab. With the addition of daratumumab, we did see some increased adverse event, but for most part, this was well tolerated, and these adverse effects could be easily managed with good supportive care. And when you look at the survival outcomes, and again, this is what they call a MOD-PFS, which is a major organ dysfunction, taking that into account. And you can see that the daratumumab was associated with a much better MOD-PFS. Now, in addition, they also looked at the quality of life in this study and showed that the addition of daratumumab did not really make a significant impact on the quality of life for these patients. Now, the group of patients that are the biggest challenge are the patients with advanced cardiac involvement, especially the stage 3B patients, and those patients were not included in the Andromeda study. So there was a subsequent study that was actually presented at this recent ASH meeting from the Greek group, who looked at daratumumab as a monotherapy in patients with stage 3B disease. And they were able to show that the 12-month overall survival for a very advanced disease was about 48%. Now that doesn't by itself looks great when you think about myeloma patients, but if historically these are the patients where we would have seen nearly 2/3 of the patients die within the first year after diagnosis. So clearly the ability to control the clone without having significant toxicity related to therapy did translate to better outcomes in these patients. So the other regimen that has been used for a long time, even before the monoclonal antibodies came along, in patients who cannot go to a stem cell transplant, was a combination of melphalan and dexamethasone that was again developed by the Pavia group. And they were able to show this small study that nearly 2/3 of these patients got a hematologic response, including 1/3 of the patients who were in a complete response. So certainly melphalan and dexamethasone is a good regimen to use, especially if you don't have access to care physician choice. And that trial actually did not show a significant improvement in the primary endpoint, which was again progression-free survival. The role of bortezomib or the proteasome inhibitors was, it was studied in one phase 3 trial that had 110 patients, so patients were randomized to getting melphalan dexamethasone or melphalan dexamethasone with bortezomib added to it. And this trial showed that, again, with the addition of bortezomib to melphalan and dexamethasone, did improve the time to second line therapy or death, towards improved overall survival. So certainly the proteasome inhibitors is a very active drug in this patient population. One important caveat is that one has to remember that nearly half of the patients with light chain amyloidosis have a translocation 1114, and there is data from the German group who have shown less effective in patients with a translocation 1114. Now the immunomodulatory drugs have all been studied in this setting as well. There was significant toxicity associated with thalidomide in those initial studies. Subsequently, the lenalidomide was studied in phase 2 studies, both in combination with dexamethasone as well as len-cyclodex. One of the big problems that we have seen with the immunomodulatory drugs is significant cardiac worsening, which is often transient during the first 2-3 cycles before patients start getting better. So if somebody already has some retrospective data looking at amyloid patients, again the ones with the translocation 1114, showing that this can give rise to really deep hematologic response, which can then translate to better overall better survival as well. So in our own practice, what we do for patients with newly diagnosed light chain amyloidosis is to treat them with daratumumab with Cybody. Patients who are eligible to go to a stem cell transplant, we often collect stem cells, take them to a MEL200 autologous stem cell transplant, and if they are in a good hematologic response, at least a VGPR, preferably a CR, then we basically observe them. In patients who have significant bone marrow plasmacytosis at baseline going into the transplant, we often put them on maintenance therapy, just like the way we do with myeloma. If they are refractory to the transplant, if they are not able to get at least a VGPR, then we certainly want to give them additional therapy. So, if they're transplant ineligible, then we basically continue them on daratumumab Cybody, just the way it was done in the Andromeda study. Now there is clearly a couple of questions that the Andromeda study really didn't answer. One is, do we really need to use cyclophosphamide in those patients? And two, how long do we really need to continue daratumumab for those patients? And there are clinical trials that are currently looking at that question as well. So, but one of the important thing is, I think the utility, I wouldn't say utility, the use of autologous stem cell transplant in our practice for patients with light chain amyloidosis has significantly fallen. We have gone from doing nearly 90 transplants a year to maybe doing like 10 or 15 transplants a year. Part of the reason is the more widespread use of daratumumab VCT regimen. The majority of the patients get into a deep response with that kind of regimen. And once you have a good control of the clone, there is no urgency in taking them to transplant. And there's not really a very good strong reason to even collect and keep the cells in those patients. Because again, remember, these patients who go into a complete heme response, the duration of response is often 4 to 5 years. And when these patients relapse, they are often quite far away from their initial therapy. We can always collect the cells and do a transplant as part of the second line therapy. So what about patients who are relapsed refractory? If they are refractory to the daratumumab, then we have other choices like what we talked about, Meldex, Pomdex, Cybody, venetoclax in patients who are translocation 1114. And if they have not seen daratumumab as part of their frontline therapy, certainly use that as part of the second line. Now, I just want to briefly talk about the supportive care management. It's very important for these patients because many of these patients are symptomatic because of the degree of organ involvement, and the treatment also come with some toxicity and can often make their organ function even worse before it starts getting better. So really close attention to again management of the heart failure, symptoms associated with GI amyloid involvement, they are all very, very important. So I think just to conclude, I think we have made a lot of progress in the field of light chain amyloidosis. A lot of it has come from timely diagnosis, good risk stratification, and risk adapted therapy with the treatments that we have available. I think the introduction of daratumumab has really made a difference for these patients, and I suspect once we have prospective trials, we'll be able to demonstrate that drugs like venetoclax can have a significant impact for 11-14 patients as well. But hopefully, those are trials that need to be done. While transplant is a very effective therapy, the vast majority of the patients are going to be ineligible for transplant. But I think many of those patients whom you think are ineligible for transplant in the first line setting, if you treat them with effective regimens, they get a good response and they eventually relapse later, they might actually be a candidate for transplant at that time, even if they weren't at the time of initial diagnosis. The other thing you want to keep in mind is if you don't get good heme responses, you do want to change therapy very early on. Particularly those patients with cardiac involvement. And finally, it's important to keep in mind that the organ responses can be delayed. So just if somebody has good hematologic response and no organ response yet, don't change therapy. Give them some more time unless they have active organ worsening. So I'll stop there and thank you for attention.
Thank you, Dr. Shaji. I think really good talk. One or two burning questions. Very quick, crisp question and quick, crisp answer. We have to make.
Patient of primary amyloidosis who had mainly cardiac amyloidosis and renal amyloidosis to present with the initial serum pro-BNP level of around 10,000. And with DARA VCD, he has come into partial response, and I transplanted with 140 milligram melphalan. Day 30 he presented with hemoptysis, and I evaluated for that. I did the upper GI endoscopy, and the upper GI endoscopy report shows that it is a gastric folds are showing amyloid deposit in post-transplant period. So how to handle this patient?
So the amyloid deposits are not going to go away for a very long time. Even in people who have like 5-year survivors, you can do biopsies and still demonstrate amyloid. So I think this is somebody who probably has, you have given all the therapies that you would give at that point, and you have good hematologic response. I would just wait and observe that patient. Just do whatever supportive care is needed for managing the bleed, and then wait for the organ response to happen.
Bleed has now improved. He has reached 100.
Yeah, I would just watch.
Yes.
As long as there's a good heme response.
No need to aggressive
No further therapy. No.
Okay, sir. Thank you.
Last question, please.
Sir, is serological progression at during following an indication to restart treatment once a patient achieves CR in AL amyloidosis?
Yeah, I think this is one place where I would, if somebody with light chain amyloidosis start showing increasing light chains, I would definitely go ahead and start treating them. And again, just some basic principles, right? You want to look at the trend. And if somebody presented with, let's say, 100 milligrams per deciliter of involved light chain, and now you went from, let's say, 2 to 3 or 2 to 4, I would necessarily start treatment right then. Definitely restage the patient, see what is the degree of clonal plasmacytosis in the bone marrow, and ensure that there is no worsening organ function. So that patient can be watched for some time. But if you start seeing like progressively increasing light chain, then I would definitely intervene and start therapy.
So thank you very much, Shaji. Like all your other questions and queries can be addressed to Shaji, post this session. So moving on, we'll talk about Waldenstrom's macroglobulinemia now, and pleasure and privilege to invite my very dear friend, Dr. Sadashiv Du. Sadashiv Du is Chief of Medical Oncology at the Nizam's Institute, and one of the pioneers and leading one of the top institutions in the country. And today he is going to speak to us on Waldenstrom's. So over to you, Sada.
Good afternoon. At the outset, I would like to thank organizers for giving me this opportunity. So my disclosure is I am not an expert of Waldenstrom's, first thing. So, but we have some couple of, at least around 5 to 10 cases. We have the good experience in, because at teaching hospital we have to learn and we have to treat the patient, we have to teach the students also. And at these headings, I think I would like to cover this topic. And this is, I think, one good example of a Waldenstrom's patient. During my DM residency, first year of my residency, he came to our department. So the symptoms started at the age of 57. He's a school teacher. The Hyderabad Public School, one of the famous schools in Hyderabad. So most of the students are chief ministers of Telangana and Andhra and ministers. So whenever he comes to us and always he'll talk. It's because a proud teacher always and he talks about his students. So he's my student. So with that the conversation went on. That disease part only 30%, remaining 70% will discuss his other things, because he'll feel very happy to discuss other than his disease. So with that, in 2000 he went to different hospitals with the history of anemia. There they have done some recurrent transfusions, but they could not evaluate because of local doctors. And 2003 to 2016 again he has something anemia and thrombocytopenia. Again did not evaluate properly. They are given transfusions as well as steroids also, because again, but patient used to get response because of mild disease probably at that point of time. But 2006 he came to our department with a gum bleeding and some gingivitis. At that time I think his hemoglobin was 3.9 grams I think. So suddenly our general medicine department, they thought it's very wrong. I think they started evaluating the patient. At that time he has hemolytic anemia. And because of we have one of the hematologists in our general medicine department is very good in evaluating all the benign causes like Dr. Srinivasan. So he did the bone marrow. The bone marrow I think that one is again our pathologist, very good. We have the pathology department in our institute, hematopathology. So they said it's a Waldenstrom's macroglobulinemia with these plasma cells and plasmacytoid cells, and they did the IHC, CD20 is positive, CD130 is positive. So clearly they have mentioned the lymphoplasmatic lymphoma, and we did electrophoresis, immunofixation, everything is confirming the IgM macroglobulinemia, because at that point of time we have the innovator Rituxan in our country, the MAP in 2005. So we wanted to give the MAP, so we counseled the patient, because he's a teacher, he has some reimbursement facility, we could give original rituximab at that point of time. So we initial, because as usual whenever we want to give the rituximab we have to think of flare again. So we have given initially only steroids for 5 days, then we have given the rituximab. We finished 6 cycles of chemotherapy. So the last cycle in February 2007, at the end of his evaluation, all the hemogram was normal, but thin M spike was there. So coming to that case again, how the science evolved, again I'll discuss this my patient, the last slide of my presentation. As you know, this is again there's a B cell malignancy, everybody knows, but the manifestations are 2 varieties. One is the plasma cell or B cell infiltrate the bone marrow, leads to the bone marrow compromise. It leads to anemia and thrombocytopenia. Again this plasma cell secrete the IgM macroglobulin. I think everybody knows macroglobulin leads to hyperviscosity, all the symptoms related to the hyperviscosity, maybe bleeding, maybe visual blurring, everything. And most of the times, but the disease of elderly, but this patient is 57 years at the age he came to us, and this is also known as lymphoplasmacytic lymphoma by real and WHO classifications in the past. Again, this we know that one disease of 2 problems, but the incidence is not to 1 to 2% only. And most cases are sporadic, but there is a strong family history. Some people they'll say familial history also will be there, around 5 to 10% hazard, what you can say relative risk, but there is no concluding evidence to say this could be the cause of this genetic problem. And some people again they say some autoimmune disorder, some inflammation also leads to this problem, but there is no conclusive evidence to say that this could be the reason for the Waldenstrom's. But most of the times preceded with the IgM MGUS. But if you can detect that early, definitely we can find out. So the presentation to us, again I mentioned clearly, the presentation is 2 terms. One is the bone marrow infiltration and another is the IgM related symptoms. But I think in the morning in the quiz also they have asked what are the infiltration to the CNS, something Binge-Neal syndrome. Morning they have asked one question in the quiz also. So all the residents are very good in remembering the syndromes first. Then okay. So but again I think as I mentioned that one is again because of hyperviscosity they will have the multiple symptoms. But as a clinician we should know what we have to look for. And at the same time sometimes we can see the amyloid deposit also. So cryoglobulinemia, all these things are related to something this hyperviscosity. But this is the thing I think we can say hyperviscosity, this is the IgM deposition diseases. Ultimately sometimes they may have the autoimmune hemolytic anemias also. So these are the table. I think I don't want to go in depth of each and every point. I think as you know all of us, So the hyperviscosity leads to all the symptoms. And one more most important thing is again this autoantibodies also active against myelin associated glycoprotein. They may present with the neuropathy, but we may have the confusion between neuropathy between amyloidosis or because of this Waldenstrom's. Very difficult to differentiate, but we should have the something techniques like we can do the immunofixation and everything. We can do a proper evaluation before you label them as something like Waldenstrom's. So all these are some of the things I think they may present to us. But I think history is most important. What we are looking for. Laboratory evaluation always what we have discussed yesterday since, but individual evaluation also may be necessary. For example, IgA, IgM, IgG, individual immunoglobulins also required to say that how much the other immunoglobulins are affected. So with this again the bone marrow is mandatory in this case. We can't escape from bone marrow aspiration, and biopsy is mandatory to diagnose that one, especially to know the IHC pattern. So CD20, CD19, CD79A will be positive in this because of lymphoplasmacytic lymphoma. So we have to do the IHC before we label them, and to confirm that one again we have the immunoelectrophoresis. Even though M spike is there, but M spike again should be the IgM. We have to demonstrate that one. But if we have any doubt between something like amyloidosis and this one, better do some abdominal fat. Sir mentioned clearly that one how to evaluate the amyloidosis also just now. So our key to diagnosis again I mentioned clear same thing, the lymphoplasmic lymphocytic infiltration with this hyperviscosity syndromes, and same multiple myeloma criteria applies here. More than 10% of clonal plasma cells should be there to demonstrate that one. But one more important thing is even sometimes these plasma cells may have the something immunoglobulin accumulation in the cell, so that leads to Dutch or Russell bodies. And what I have mentioned just now is again the IHC is important, but this mid-18 L265P is nowadays everybody they are asking to at least more than 90% of this Waldenstrom's it will be positive. So better to do that one. But morning I think I could connect with some of the lab people they are doing in India also. It costing around 12 to 15. So okay, HGPJ they are doing the same this one. And but some people they are also asking for this deletion of P53 also is important, and CXCR4 also there. So these three markers I think we have to do now to say that again. But for all the residents' sake, I think there are differential diagnosis almost I think 5 different diagnoses will be there, but you should correlate clinically, laboratory as well as pathologically, do all these markers. But this is very specific entity is where you can see the CD20 positive and some plasmacytoid markers also will be positive in this one. But again the differentiation I mentioned just now is again how to differentiate between other disorders, especially IgM myeloma. I think we had a discussion on that. IgM myeloma, if you have something like any bone lytic lesions is predominant, it goes in favor of IgM myeloma. But other disorders I think all of us we know that one, but always make sure that IHC and remaining tests should be done before you label as a Waldenstrom's, but clinical symptoms also most important. And these are the symptoms I think we can't treat each and every patient who is coming to us with a Waldenstrom's diagnosis, but we have to don't treat the lab values here. Always we have to treat the patient. So what are the patient have the symptoms like an hyperviscosity, is a neuropathy or any organomegaly, especially cytopenias. So frequent transfusions. So all these are taken into consideration before we start any therapy. So treatment purpose I think as you know, what I've discussed just now, so always better to don't jump into conclusion. Patient is having any of the symptoms, hyperviscosity, do the plasmapheresis, then start the rituximab. That's the most important thing. And this is how to approach this one is again the issue is the treatment naive symptomatic. If the symptoms are there, some symptoms of hyperviscosity, do the plasmapheresis, urgent plasmapheresis, go to something again, you can send the test. But in India I think whatever test we do, it takes minimum 2 to 3 weeks the turnaround time. But we can't wait for these reports, but at least if you have something M spike or this bone marrow test, start the treatment. And nowadays based on this again the 2023, can we modify the treatment based on this mid 88 L265P or CXR4? But it is again some people they'll send one BTK inhibitor is better than this algorithm. But if you need something in a rapid response, better to go for the chemoimmunotherapy, that is bendamustine based rituximab BR. Some people say bendamustine based or BR or BDR or BDC. So always, but if everything is based on the patient's symptomatology. If you want to reduce the tumor burden, go for the chemotherapy. If the patient is okay stable, if they may not need immediate tumor reduction, go for something BTK inhibitor. Now we have so many drugs are there. So again, the ibrutinib rituximab, that also is one of the combinations where you can use this one. So the algorithm now is we are proposing like this. Maybe in the future we can think of this genetic based therapies. And ultimately, again, I mentioned just now, same thing is based on the symptomatology only. Asymptomatic MGUS, there is no IgM MGUS, no need to treat the patient. IgM related neuropathy, again, you have to differentiate between amyloid neuropathy and this one. Then you can give the single agent rituximab. Problem is single agent rituximab again, flare, but keep it in mind. And at the same time, if they have the symptoms, better to go for. Now the standard of care is bendamustine rituximab is the standard of care, but still, some people they may not go for something like a chemotherapy and administration. Now you can choose a BTK inhibitor. Now all the especially ibrutinib, acalabrutinib available in India, so the cost also is very less compared to the rituximab and other chemotherapy regimens. So this is the one, I think Mayo Clinic, there's a salvage therapy, there's a initial therapy, the salvage therapy also one. So whatever you have given in the past, then you can change to that one. But if the patient achieves at least 3 years of DFS, you can use the same regimen that we can use. So because known devil is better than unknown angel in oncology, that's what always we feel that. So better to go for the regimen which had the longest progression-free survival. So but these are drugs are available at this point of time, except janubrutinib and ixazomib, everything is available in India now. So but choose the regimen based on the patient comorbid conditions and the patient symptomatology. And ultimately, this is the one I think future method we are proposing everything based on this mid-88 and CXR mutation testing, then we can choose these regimens. But patient symptom again the most important one. But this NCCN again the recommends what regimens I think bendamustine rituximab. But still the janubrutinib something is a category 1 recommendation here also. So that is not available in India. Trials are going on, but these other drugs are available in India. We can. So these are the even first line, second line drugs are available. So with this, I think this is ESMO guidelines mentioned same thing again that the choice is if you want to decrease the tumor burden early, go for chemoimmunotherapy, especially BR or BDR or BDC. So these are the ones, and relapse refractory, if you have not used any other drug, you can use it the same another drug. And ultimately these are the drugs with the single agents. I want to just mention because of completion sake, response rate and everything you can see rituximab single agent, the response rate, overall response rate of 51, around 15%. But always you have to remember the flare also, you should keep it in mind before you start therapy. These are other chemoimmunotherapy drugs like in the BR or RCHOP or DRC, VDRC, almost all of them you will get more than 90% will get some response rate because a very mild disease. So, but the sustenance of the response also very good with these regimens. So, if you want to give the fixed duration of chemotherapy, choose BR or BDR for 6 cycles. There is no role of rituximab maintenance in this condition. So very clear in this. If you want to give something, so whenever you want to use some bendamustine based regimens, there is no need to give the rituximab maintenance therapy. So these are regimens. I think more than 90% response rate we have. And coming to this again, this BTK inhibitors nowadays they are coming to the picture and easily you can manage. Administer. The problem is nowadays there are so many drug interactions, so we should be very careful by giving these drugs, especially hemorrhage and something atrial fibrillation with ibrutinib. So some of these complications may lead us to change therapy, or especially these lesser is available in form. So we are able to give the drug without any problem now. So these are again this exosomib other drugs. There is almost 96% response we will get with this other immunomod based chemotherapies or exosome based chemotherapies. But ultimately our goal is to achieve the maximum response that is possible with this one. So these are some of the guidelines I think. But again risk stratification also we have like in multiple myeloma. There is risk stratification is there. It's better to risk stratify the patient before we start therapy based on these 5 factors like hemoglobin, platelet, monoclonal IgM and beta-globin, patient age. So ultimately these are the factors. So we always risk stratification, we can use it for prognosticate the patient and to tailor your therapy. So we have to do that one before you start therapy. So ultimately coming to my patient, this patient, so he had a biochemical relapse in 2014. So initially he came 2017, around more than 7 years of progression-free survival. So at that time, because only biochemical relapse, so we started him only rituximab and chlorambucil. He tolerated very well for 3 to 4 cycles, but then he said, I don't want chemotherapy because there is no obvious symptoms. So again he relapsed in 2017 after 3 years. Then at that point of we have given bortezomib, dexamethasone and rituximab for 6 cycles. Again the 4 years he got the good response. There is no progression. We usually monitor them with the IG. We don't do regularly bone marrow, but only thing we'll do biochemical monitoring. And ultimately third relapse is in 2021. So 2 cycles he tolerated, because more than 3 years we wanted to use the same regimen, but the patient did not tolerate this one. But ultimately we had a discussion in this department. So we got a ibrutinib drug was available at that point of time. We started him on ibrutinib for the last 2 years, but he has a hematuria, something related to the prostate problem. But the consultant asked to change the drug, so we changed to acalabret now. Patient is doing very well, he's tolerating very well. So at the time of my joining in 2005, he came to our hospital. After 17 years, this age I think you can see, now 73 his age, still he's surviving without any major problem. But luckily, cost is a major thing, but he's able to manage everything because his daughter is working in USA. So as a radiologist in that, I think always and we had some good communication between the patient and the patient relatives. So maybe we hope with the science is developing day by day, we are able to tailor therapy. Maybe he will live up to, I wish he should live up to my retirement of my age. So thank you very much for giving this opportunity.
Thank you, Dr. Sadashivdu. Some of the questions which you have on plasma cell dyscrasias other than myelomas, we will cover during the panel discussion. So now my pleasure and privilege to invite the moderator of the panel, Dr. Prantar Chakrabarti. Prantar is the Director of Hematology at the very large and prestigious AMRI institution in Kolkata. And for me, he is the Royal Bengal Tiger. So over to you, Prantar.
Yeah, I think postprandial slumberness might come, so I'll just check not only from the panelists whether others were listening to Sadashivdu. I think Shaji's talk I'll come to later because I have 2 cases. But let me invite the panelists first. So this is in alphabetical order. Dr. Ganesh Kumar Vishwanathan. So he is looking younger here. Then Dr. Mahesh from Bangalore. And then is Shiddesh here? I haven't seen him. So he was supposed to come from Nasik. He's not there. And Dr. Uttam Kumar Nath from Rishikesh. So, from different parts of India, I have my panelists. So, it was a very illuminating story from Dr. Sadashivdu when, the teacher with his influential students. So, I also start off with a patient, but this is somewhat different. There you saw there was disease, they treated, it came back and all. Here it's a 51-year-old otherwise healthy man who was found to have high ESR during routine testing, right? And there are 2 ways. One is serum protein electrophoresis and densitometry, and the other is you can do the IgG, IgM, IgA levels by nephelometry. So which one do you use, and is there any advantage of one over the other? Anyone? Ganesh, you can start off.
Yeah, I think most of the centers, the choice is based on what the instruments or the installations the institute has.
In India, I believe most of the centers have both because the rheumatologists ask for the levels, right? And we ask for immunofixation and electrophoresis.
Yeah, I think for available densitometry we to start with.
And actually, there are certain recommendations which tell us that densitometry is better than nephelometry. So that's why I did not know this. I got to know when I read it morning.
Actually, when you order a myeloma panel or a panel for suspected Waldenstrom, then you get both.
Yes.
In the immunofixation, you will get IgM.
Right.
And densitometry will get the quantity of the
quantified
M spike.
IgM.
and you do quantitative immunoglobulins.
Right.
To look for immune paresis.
Right.
So there you get IgG, IgA and IgM both.
Yeah. And in follow-up, so you'll do either,
IgM
but
only.
you'll look at
IgM
it.
only.
Yeah. So as Dr. Sadashividu has told you, it's all about symptoms. But what I want to know, because my topic is challenges in India, right? So anemia, cytopenia is easy to diagnose. B symptoms is a clinical diagnosis. Now during our undergraduate days, the quiz used to have a question on hyperviscosity. So my question to Dr. Uttam is, you know, we used to be told that you send the sample and they will send viscosity levels and all. Have you ever done it in your life?
Practically speaking, we ask for history suggestive of hyperviscosity, like headaches, transient or intermittent blurring of vision, sometimes epistaxis, and we do not ask for the serum viscosity.
Yes.
But although the textbooks say that the IgM levels and the viscosity symptoms do not
go hand in
correlate,
hand. Yeah.
usually the higher the IgM levels, you get these symptoms like epistaxis. Often these symptoms are the presenting complaints with which the patients come to you, like epistaxis and all this.
And I believe our ophthalmology friends can be of use, because fundoscopy gives a very good idea about whether there is. Now neuropathy, you know, I dread, because the greatest problem is, you know, they have all these CIDPs and all, and they will invariably send a serum protein electrophoresis. They find something, they refer it to us. So how do you approach the neuropathy, you know, because you'll find maybe there is a IgM monoclonally, but whether it is linked to that, and as he mentioned, whether it's amyloidosis or it is Waldenstrom associated neuropathy, how do you approach it? Because, you know, the neurologist has told the patient that he will take care of you, and they have given some steroids and we do not know what to do. How do you tackle such situations?
Basically work on the lab side, but again the history given to us is very vague, as you said, most of the times.
Yeah.
It's very difficult to correlate with what is actually put on the paper and actually how to correlate with what we have, you know, with the lab findings.
Right.
So especially as you mentioned with hyperviscosity, so it's typically we go with the history and never mention the and never measure the viscosity levels per se.
And I don't think we are measuring all those anti-gliadin antibodies and all. Those are there, we are not doing it, and I don't think if we get it also, we'll be able to do something.
So I would like to add that by the time you get such a patient, the neurologists have almost done all the workup.
Yeah.
So your job is basically to do a bone marrow. No, seriously. And
I agree,
to
yeah.
see whether it's just MGUS or myeloma or paraproteinemia associated peripheral neuropathy
Yeah.
or amyloidosis, like systemic light chain amyloidosis,
So
or
they'll be doing
very
enough
rarely-
biopsy also.
or Waldenstrom. Yeah.
Yeah.
Your
And it
job
becomes
is
very
limited to
difficult.
doing the marrow early.
Yeah.
And along with the immunophenotyping of the marrow at the same sitting.
So I just have one more point, just as
Yeah.
Dr. Uttanath said. So when they refer to it, basically they just have one particular question: is it hematology related? So
Yeah.
just want us to do bone marrow and say, no, is it associated with the lymphoma or not?
Yeah.
So basically their reference refers to one specific question,
Yeah,
and we
yeah.
answer that yes or
And
no.
so there is clonal disease or not, but sometimes they are very naughty. They tell us that we will cure it, which we can't, and they can't. Anyway, so symptoms of cryoglobulinemia. So that is another thing, you know, they can go to the internist, they can go to the rheumatologist, but how many of us have access that you tell the lab and they will do a cryoglobulin? Do you have access to it?
Yeah, we provide this service. We offer cryoglobulins. So we do get positive cases, I would say 2 to 3 per year. That's
Right.
not very common.
Yeah.
But the request we get is about two to three cases per month, but positive pickup rate is about 2-3 per year.
2,
So
3 per year. Yeah. And I think it's easy to do. So if your lab is not doing it, you just centrifuge the sample, keep it in a refrigerator, and you can do it. The other is cold agglutinin. You know, these can also present. So fortunately, our transfusion medicine colleagues also help here. And I think in India, it is now not a great challenge because they can do it. You
yeah, so
agree or
our
disagree?
blood
Yeah.
bank offer these services, and they give the titer also.
They give
so
the
it's
titer
yes.
also. Okay. So I think these are looking for the clinical clues. So for this patient who had no symptoms, how will you work up? You know, so Sadashividu has shown you that entire NCCN thing, but in your opinion, what is the most important? I think as we were discussing neurology, we already said that we will do a bone marrow, right? Any other things you'll do, and is immunohistochemistry a must, and should you send, cytogenetic studies? That is my question.
So, actually this, another aspect of this is, do they have, mostly they have this IgM level, but many times they don't. So
Yeah.
it's part of a workup of a lymphoproliferative disorder as a lymphoma.
Right.
So as part of that, sample for flow, and IHC is done basically after looking at the HNE, and as molecular and cytogenetic studies are sent beforehand,
Right.
keeping the lymphoproliferative thing in the mind.
Right.
So even before the particular diagnosis is reached, the ancillary tests are sent beforehand.
They have been sent because it was done.
Flow cytometry must be done because you are anyway doing a marrow aspirate and biopsy.
Right.
So it will give you a very early diagnosis if there is a significant number of those cells. And you can complement it with IHC later on the bone marrow if there is any suspicion or any differential diagnosis like SMZL like thing.
Yeah. So how many times have you seen that there is a diagnostic dilemma on the morphology on bone marrow, say, per year?
So basically this is, this comes under a group of lymphomas
Yeah.
which have some plasmacytoid differentiation.
Right.
So, the differential diagnosis in such a setting would be one a splenic marginal zone lymphoma.
Right.
And then obviously this LPL Waldenstrom's.
Rarely we CLL. Recently we got a patient.
Right.
There was flow, IC, everything was done, but still we are not sure whether it was actually CLL or CLL with Waldenstrom's. And we sent this NGS panel, and it was positive for MYD88.
Yeah. So that is my next question. This is also for the audience. How many of us are sending MYD88LT65P? Can you just raise your hands?
We are doing in-house.
You're doing in-house. Great. So which technique are you using and what is your source? Because in the literature I've seen you can do from whole bone marrow sample, you can do it on CD19 selected cells, you can do it from paraffin embedded tissue, and you can also do from peripheral blood cell-free DNA. Which one do you use?
We are doing by RT-PCR.
Okay. RT-PCR and
Bone
which
marrow
sample?
aspirate sample. Bone marrow aspirate sample.
Bone marrow aspirate sample.
So I think bone marrow aspirate, if it's involved, that would be the best sample to
That
begin
would
with.
be the best.
And other options are as and when depending.
Right. If it
there's-
was not thought of earlier or it was not sent or anything, maybe, yeah, please, Hari.
So no, just to say it's feasible to do it from paraffin embedded because
Yeah.
when we did a retrospective analysis when MID came for the
Right,
first
right.
time, on our 21 samples we were successful in doing it in all from the paraffin
In
embedded
paraffin.
tissue.
Yeah, that is what
it can
the
be
literature also
you can
says.
take a scraping, extract the DNA, and then you can do it.
So, may I comment on
Yeah,
this?
yeah, please.
In this scenario, we have had bit of an experience because we were using Sanger sequencing. We were very careful that we are picking specifically this mutation, and Sanger
Right.
sequencing will be the gold standard.
Right.
But then we realized that when the involved, if you use the unsorted bone marrow or the peripheral blood, if the tumor load is less than 20%, you won't pick it up.
Right.
So the best thing in this is to understand as a pathologist or as a hematologist oncologist that what is the tumor load percentage in the sample that you've got in your lab.
Right.
So that's why we say that a pathologist is important, because then they can see the slide from the same sample, how much is the tumor load. Depending on them, you decide whether you're going to sort the cells, you're going to get, and what is the percentage of T cells in that sample. Depending on that, whether you would do a 19 positive sorting or you do just a lymphocyte sorting, or you would, what kind of sorting, and then you run the assay. And the best is at diagnosis, I think it's like Sanger sequencing is the gold standard, but can also do the PCR, qPCR based specific for the mutations.
Okay, thank you. And I think another important thing is, as it was shown earlier, that whether it is more than 10% or less than 10%, Waldenstrom wise it doesn't matter except for the Mayo, because you can call it IgM MGUS. But obviously if the cells are more, you're getting this mutation, chance of getting it is more. Thank you. I come back to our patient. Patient's hemoglobin is 14.2, no B symptoms, no splenomegaly or lymphadenopathy, but bone marrow biopsy showed 50% infiltration by lymphoplasmacytes. And molecular testing was done. It revealed that this mutation is there. Will you treat him?
So it depends on hemoglobin is normal, so there is no sign of bone marrow failure. Blood counts are normal. If there are no hyperviscosity symptoms or any clinical like bulky lymphadenopathy on proper imaging, then we can wait and watch. Recently we had one patient of Waldenstrom who had very big lymph node mass in the abdomen which was causing symptoms. PET CT uptake was not very high, but the size of the mass was 16 centimeters, the longest dimension.
Okay.
And so you can get any indication of treatment. You have to do a detailed workup. If there is no indication, then you have to wait and watch, follow up the patient clinically and with CBC and IgM levels.
Ganesh, you want to add?
Yeah, I agree. In fact, most of the patients we see are symptomatic with
Yeah,
cytopenias.
because they come late to us, so yeah, you rarely get this type of patients. Do you use this, either ISSWM or this revised IPSSWM?
WPSS we use, but
okay, because this one looked to be, easier to me. Just the age, the beta 2 microglobulin, LDH and albumin. So, that mindset of us, but frankly speaking, I was also not using it. That's why I wanted to know. Okay, so you are using it. So back to the patient. Patient was on follow-up, was not treated. About 18 months after the initial diagnosis, the patient complained of worsening fatigue, low-grade fever, IgM is 4.4, but now hemoglobin is 11.8. As per IPSSWM, the patient is low risk, and also our IPSSWM wise also is low risk. So now will you treat him? And how do you decide what to give? He has shown you a cafeteria choice, right? So now what do you use? Yes, Uttam, Ganesh, anyone? Yeah.
We have to actually confirm whether these are B symptoms due to the disease. Because there are no other indications of treatment in this patient. If the B symptoms are persisting, there is significant weight loss, patient is having fever or fatigue, ongoing fatigue, then we may take a call on starting treatment. The IgM is also quite high, but this is not an indication for treatment. According to NCCN, you can treat asymptomatic patients who have more than 6 gram per DL, but again that is dicey. So either we can start treatment or maybe increase the frequency of follow-up, and at the earliest sign of progression we treat.
So how will you monitor progression now?
Blood counts, the symptoms, if the symptoms persist, they are hampering with the quality of life or daily activities.
See, now fatigue, low-grade fever, you ask me, I'll say it might be tuberculosis, right?
So that is why we have to rule out other causes.
Yeah. Okay, and if you decide to treat, how do you decide? Ganesh?
So in our department, I don't think we have a specific or fixed regimen.
Yeah.
It depends on the patient affordability and the stage at which he's seen.
No, this patient, now you are diagnosed 18 months later, you see that hemoglobin has gone down, there are possibly B symptoms. So
bendamustine rituximab.
Bendamustine rituximab.
Before starting rituximab, we should be cautious, and as per guidelines, if IgM is more than 4 gram per DL, you should do plasmapheresis before starting rituximab. Earlier we used to start bortezomib based regimens, which rapidly decreases, and in that regimen BDR, rituximab comes later. It was like day 11 or maybe later, and sometimes we used to skip rituximab in the first cycle. But if in this patient we can start any treatment, either bendamustine rituximab or only bendamustine or BDR, and keep an eye on the hyperviscosity, worsening of the hyperviscosity symptoms or the IgM flare.
Okay, so I'll tell you what was done. He was started with BDR. He achieved a rapid response within 4 cycles. He completed 6 cycles and he was not given maintenance rituximab. Okay, so on follow-up, his IgM has started rising after 14 months, and they were following him up for every 3 months. He still has no symptoms, but IgM is going up. So what will you do now? So after 14 months, it has come, no symptoms till now.
So I think wait and watch would be one option.
Yes. So I think whatever I read, I understood that even if you consider it as a relapse, the same things apply. So let him earn his treatment. This is one thing which in Waldenstrom does. So treatment has not been started till now, and I think I can now go to the second patient and see, if you remember what Shaji told you. So here there is more of clinical data. 62-year-old male presented with a 15-day history of dyspnea on exertion, bilateral pitting edema. Before this admission, he also had suffered from abdominal bloating, taste sensation altered for a year, significant weight loss of 20 kg. Over the past 6 months, he has developed a multiple system disorder which included painless paresthesias in his lower limbs, erectile dysfunction, and chronic diarrhea. So, when this type of things come and when they are referred to us, we obviously think of what Shaji was describing. I'll tell you the findings clinically. The blood pressure was low, the heart rate was low, significant jugular venous distension, moderate hepatomegaly, edema as I already told you, weakness and muscular atrophy, especially on neurological exam, bilateral tibialis anterior and gastrocnemius. Okay, hyporeflexia in both knees and ankles, so diminished tactile and pain sensation in a stocking and glove pattern, so peripheral neuropathy. Vibratory sensation was distally reduced in the lower limbs. The motor and sensory functions of upper extremities were relatively spared. So, because this was a multi-system disorder, this patient was admitted under medicine. Neurologist had a close look, and then initial workup was done. So CBC, LFT, creatinine, electrolytes, even cardiac troponin and thyroid function were normal. NT-proBNP was 3996. Nerve conduction studies confirmed bilateral sensory motor neuropathy. EMG showed active denervation and chronic re-innervation. These are all in the reports. So changes in the tibialis anterior and gastrocnemius. ECG revealed sinus rhythm, low voltages in limb leads, QS waves in precordial and inferior leaves, first degree AV block, prolonged QTC. 2D echocardiography revealed marked concentrically thickened and speckled appearance of ventricular walls, biatrial dilatation, LVF maintained 70%. Doppler revealed a severe restrictive mitral filling pattern, EA ratio of 2.1. Coronary angiography was done. There was also some history of chest pain, so they wanted to look at 62-year-old. Coronary angiography was normal. Now the hematologist, the hemato-oncologist has been called to the scene. Now what do you do? Yeah, Ganesh can start.
As usual, you'd like to look for the M component and then to look for the bone marrow plasma cell load.
Okay.
Just to, so we expect the plasma cell numbers to be less, so just wanted to establish the clonality of the plasma cells,
right,
either by flow cytometry or an IHC.
Or by immunohistochemistry, right. And it came out as lambda.
We need to rule out myeloma associated amyloidosis also, because sometimes in a myeloma patient you can get incidentally on the echocardiography you can get asymmetric hypertrophy of the septum or some unexplained neuropathy or higher proteinuria.
Yeah.
So an imaging, I would like to add, a PET CT should be done so that you are not missing any myeloma associated amyloidosis.
Okay, and let me tell you that here what happened was that if you look at Shaji's, when he was showing you, the cardiologist was concerned that troponin is normal, right? But, and this NT-proBNP is also causing a lot of headache nowadays to us, and the values, but obviously his value was high. Now, sometimes what happens is, this was more UC speckled pattern. Sometimes what happens is, there is some degree of restrictive cardiomyopathy, and the cardiologists tell, we should ideally do an MRI, and we should ideally do a myocardial biopsy and all. But frankly speaking, have you ever seen this being done in our patients? Ganesh?
So I've seen one in the past 3 years.
One in the past 3 years. I think that itself is a logistic challenge, and in certain cases maybe you do not need it. So as far as challenges is concerned, what do you think is the challenge in the diagnosis of amyloidosis right now in India? What are the major challenges you face?
So it's first establishing the tissue diagnosis itself, so getting the correct tissue,
Right.
and then doing the correct
Which
test.
would you prefer? You have done a marrow, right? Marrow does not show you any amyloid deposits. So then which tissue would you prefer?
So abdominal fat pad is easier to obtain,
Right.
and just a needle, and we don't need much of expertise to do it.
Right.
So begin with the simpler ones.
Right.
No, but often we get such patients referred from the nephrologists.
Right.
Already they have done a kidney biopsy. So
Yes.
involved organ.
Right.
Which is what is easiest to access.
Right.
If kidneys are involved, significant proteinuria, you will have the kidney
I
biopsy.
think there was a history of chronic diarrhea also there. I do not know whether it is involved due to this or that. Anyway, yeah, I think it is easier, and as Shaji had already shown you, majority would have a marrow and tissue positive. Now prognostication, obviously there are these findings about, and you have the scores and others. Most of them do not have a good prognosis. Are you able to, using MS, get to the tissue of origin? Because that is what he showed. Have you been able to do it in your clinical practice in India?
No.
No. Has anyone been able to get it done? Because I think in the Congress in Hyderabad,
Mass
there was,
spectrum.
yeah, they said that it can be done. Anyway, I'll end. I think treatment-wise, what we can use and we do use is doxycycline, obviously. And if there is a suggestion of light chain, we target it, and as was mentioned, that here is one point when we see the light chain increasing, we again try to do something, but with a low blood pressure and with 30% of patients with bortezomib, we have our problems. But those challenges are there all over the world. In India, I think one major challenge is these patients come to us very late. And this can be overcome by image working together. So thank you, my panelists. Hope you enjoyed it. And I think every challenge is an opportunity. So keep on enjoying managing these patients. Thank you.
Thank you, Dr. Chakrabarti and the panelists. Now we will have Dr. Sushant Vinarkar presenting Indian data on MRD by flow cytometry, TMC Kolkata data. We cordially invite Sir to the dais.
So good evening everyone. At the outset I would like to thank you, the organizing committee, for accommodating my request of preponing my presentation, as well as giving me the opportunity to present the myeloma MRD flow cytometry data of Tata Medical Center, Calcutta. So we all are aware that MRD in myeloma is very important. MRD negative patients have a better overall survival and progression-free survival as compared to the MRD positive patients. With increased rates of CR and modern multiple myeloma therapies, there is increasing need for more sensitive evaluation of disease responsiveness and disease burden. Three methods for detecting MRD are known: immunophenotyping by flow cytometry, molecular methods ASPCR, qPCR, and NGS. As per the IMWG MRD negativity criteria, sustained MRD negativity is defined as MRD negative in marrow by next generation flow or next generation sequencing. Flow cytometry has its own advantages and disadvantages. The advantages are it is very widely applicable, a single cell or a single event analysis can be done. It is a sensitive technique. It can go as low as 10⁻⁻⁵ and nowadays as low as 10⁻⁻⁶. It is fast, and it is a simple technique for assessment also. It has its own disadvantages. It can be performed only on bone marrow, blood compartment. The quality of bone marrow becomes very important while doing the flow cytometry assessment. Limited number of markers can be studied, and the most important thing is the sample needs to be a fresh sample. The analysis needs to be done within 48 hours. In 2016, IMWG had given a consensus guidelines for MRD by flow cytometry in myeloma, and we at Tata Medical Center are trying to follow the guideline. We have an 8-color, 2-tube, 12 monoclonal antibody panel. The backbone markers 19, 138, 45, CD38 are present in both the tubes. The first tube is the cytoplasmic tube, wherein we place the lambda and kappa light chain. We acquire 2 million events per tube to reach a sensitivity of 10 raised to -5. As per the consensus guideline and Euroflow network, bulk lysis is the method to be used for processing of multiple myeloma MRD. We follow the bulk lysis protocol using ammonium chloride as the lysis agent. After bulk lysis, we resuspend the pellet, and then the staining is done, and then the washing is done. We try to acquire 2 million events. Cell loss at each step is noted. However, in our experience, we have gained 100% of tubes at 2 million or more than that events. This is the gating strategy that is there. Basically, we start with so basically we start with our 38 positive cells, which are then plotted against 19 and 45. Each of the quadrant in the 1945 plot is then again plotted on the kappa and lambda light chain to look for any clonal population of light chain present within the plasma cell. All the events of 38, 138 and then analyzed for markers with expression of CD56, CD117, CD28 and loss of 81 and 27. More than 0.001% abnormal plasma cells are said to be positive MRD. We look for 20 or more abnormal events. We also look for CD117 mast cells. CD138 positive, 38 negative events are also analyzed separately. This is the data that I would like to present. In a duration of 5 years, we have analyzed the total samples of 118 MRD by flow cytometry of 72 patients at different time points. Our flow cytometry MRD positivity percentage comes out to be 36%. Our major bulk of MRD samples comes from PRIME study, wherein VPD is the therapy that is instituted, and MRD analysis by flow cytometry is done after cycle 4, cycle 9 and cycle 12. We had 2 patients who have relapsed from the PRIME study, and one of the patient had MRD positive, the other patient was MRD negative. Coming to the marker expression on the abnormalities of the plasma cell clones that are present, the most informative markers are CD19, which is negative, and CD45, which is negative, CD56, which is positive, and CD27, which is negative. CD20, the informativity is low, and this is being given in the published literature as well. We have tried to analyze our data for the pre-transplant multiple myeloma flow cytometry. In 3 years, we had about 28 patients who had a pre-transplant MRD, and 14 were positive for MRD and 14 were negative. We tried to evaluate and compare flow cytometry with their biochemistry parameters. We found that even when the MRD by flow cytometry was negative, either IFE or FLC was positive. So subset of patients can be positive by immunofixation but negative by flow cytometry MRD. Through IFE positivity is when there is residual disease but which is not detected by MRD on bone marrow samples, whereas false IFE positivity is because of the delayed clearance of the M protein. We have a very limited experience with post-daratumumab at our center. We just had 4 patients who had sent for who had relapsed refractory and were given daratumab, and post one cycle they were referred for MRD. 2 of them were positive still, and 2 of them had become negative. For daratumab we use a special panel wherein we have added 319 initially and then 229, and these 2 markers are to be used when CD38 is negative in the plasma cells. Just to show you the data of one of our cases which was positive, we gated the 138 positive, 38 negative events which were also positive for 319, and they were subsequently plotted for other marker expression, and they showed lambda light chain restriction. We have been participating in UK and EQUA since 2020 biannually, and we have had a fair bit of satisfactory data that has come up. We had one event where in 2020 we were critical because the Z score was outside 2 standard deviations that was present. Future plans for MRD myeloma at TMC Calcutta are, we would be liking to go to single tube 12 color monoclonal antibody panel to increase the acquisition to 5 million events, so that the sensitivity increases to 10⁻⁻⁶. We would be preparing ourselves for myeloma MRD with newer targeted therapy. We would collate our data for clinical outcomes, and we are looking forward towards NGS based myeloma MRD. I would like to thank you again, the organizing committee, the Department of Clinical Hematology, Lab Hematology at Tata Medical Center, and the Department of Flow Cytometry. This is Tata Medical Center through its length. This is the phase 1, this is the phase 2. This is the Lab Hematology team, the Flow Cytometry team. Thank you very much.
Thank you, Dr. Sushant.
Yes, maybe we can use the time while we're getting organized. Do you have data about people who are MRD negative, whether they were in CR or VGPR, or what was the clinical response?
Sir, we have not analyzed the clinical outcome totally. Those patients who were in prime study, we are at present analyzing their data, and as I said, 2 of them had relapsed. One had shown MRD positivity at cycle 4 itself, and later on that patient relapsed, and one patient had relapsed before cycle 2 MRD. So the correlation is not there much. It's a small data that is there. That is what is there.
Thank you.
So Dr. Shashank, what are the, here, second row.
Yes, sir.
What are the advantages and disadvantages of MRD assessment by flow versus NGS?
Okay, fine, sir. So both the methods are recommended methods. NGS MRD as well as flow cytometry MRD both have been recommended by Euroflow as well as the consensus guideline. NGS flow cytometry MRD has advantages that it is bit faster. Sensitivity of NGS MRD is said to be much more better as compared to the flow cytometry MRD. However, the limitations that are there is that the flow cytometry MRD needs fresh sample to be done. In NGS MRD you can extract the DNA and then also you can perform the analysis later on. Flow cytometry MRD, there is a minimal panel that needs to be run, and bone marrow dilution is what is to be taken into consideration in flow cytometric MRD, which is not a case where we are looking at the NGS MRD, because NGS MRD we are looking at the clone through the kappa and lambda IGH rearrangement. So that is the reason NGS MRD has some advantages over flow cytometry MRD.
At least in India, most centers are doing MRD by flow, right?
Flow cytometry.
What about in the US, Dr. Munshi? Again, is it the same situation or is it reversed?
No, it's reversed. In US, most of the majority of the centers do NGS based method, but they are commercially available, so from technical point of view collect bone marrow and send, and it gets done. So they are not done in the institution itself. There are few institutions which do it, and there are a few companies which do it, NGF as well. So in unlikely cases, around 5 to 7%, where we cannot get the idiotype sequence, then NGF can and needs to be done.
And the turnaround time is how much?
For
the NGS?
So NGS turnaround time is around 10 days, 7 to 10 days. If the ID is already available, which quite often is done before we do the MRD bone marrow.
Thank you. Thank you.
We invite the chairperson for this session, Dr. Cecil Ross. Dr. Cecil is professor and head of the Department of Hematology at St. John's Medical Hospital. We cordially invite you, sir, to the dais to introduce the speakers.
Sorry. I now called up Dr. Ritu Gupta from Delhi, and he's speaking on MRD flow cytometry, the AIMS data. Suman. Comparison of. Okay. Okay. Oh, I called. Sorry, because there's a lot of confusion between the switchovers. So comparison of MRD by imaging and flow cytometry, Suman Puranik, Delhi. Yeah. Sorry.
First of all, I would like to thank the organizers for giving me this opportunity to discuss about the study which we had done. So it was a multicentric study which was done in the armed forces, and one of the part of that study was this analysis of MRD through whole body PET CT scan and flow cytometry. So I'll be presenting that part. So as we all know that MRD analysis in myeloma, although it is a incurable disease still, but as we are progressing more and more towards better and targeted therapies, more effective therapies, so we are looking into more and more depth, deep into the ocean. And one thing is this MRD, this minimal residual disease. So nowadays it is of paramount importance that we go in that progress so that further development can occur and we can get the further differences between various therapies. So there are, broadly speaking, there are two types of MRD techniques, as we all know. One is the bone marrow based techniques and second is the imaging. So the bone marrow based testings, they are basically the phenotype of the cells which is seen by the multicolor flow cytometries. Then you have got genotypes when we are having this PCR and next gen sequencing. And the imaging, when we are using imaging for this MRD, basically for two ways we do it. Firstly, the functional status, and secondly, the anatomical. Functional status, we do the PET CT, and anatomical, again PET CT and MRI and whole body CT scan. So the study was a prospective multicentric study. It was an interventional study, and the study was named as IMPOSE Boticon. It was a study which involved all the hematology centers, which were 6 in number, and it was headed by Army Hospital Research and Referral. And it was an interventional study. It was an open label study, and there was sequential assignment with an intention to treat analysis. The study was for over 4.5 years, from 2016 to 2020, and basically we did various ways by developing a software also for assessing the survivals, and we were regularly calling the patients to OPDs and telephonic calls. So the inclusion criteria were the patients who were diagnosed to be case of multiple myeloma, who had undergone autologous stem cell transplantation. Basically we were seeing the autologous stem cell transplantation consolidation post that,
age more than 21 years, and both the genders were there. For the exclusion criteria, we had the patients who were unwilling for 6 monthly PET CT scan or multicolored flow cytometry, or inability to get the, either of these interventions within 3 months of due date, or inability to get 6 monthly biochemical or clinical evaluations, or patients having contraindications for these tests. The response assessment was the progression-free survival and the overall survival as per the IMWG definitions. So the primary objective was to compare the PET CT and the multicolored flow cytometry for prognostication on the patients of multiple myeloma post-transplant for the overall survival. And the secondary objective was when we exchanged this overall survival with progression-free survival. And then we also tried to assess, though informally, about the universal availability and applicability of both the tests, patient satisfaction scoring, and some financial implications. So this is the original study of protocol of the imposed Boticon, where patients were taken after post autologous stem cell transplantation, and patients were randomized at day 100 after undergoing this PET CT or flow cytometry and the myeloma profiles and clinical relapse, and they were given one of the 3 arms with subcutaneous bortezomib and Cybody or bortezomib and lenalidomide, and were followed up for 2 years, 6 monthly, and then we assessed for their outcomes. And at every follow-up we are doing this flow cytometry and PET CT and biochemical and clinical features for any relapse. For this study, for this analysis part, we combined all the 3 subgroups, and we just checked, we just took 2 things, that was the 10 colored, that's multi-colored, that's flow cytometer, and the FDG PET CT, and we tried to see when they came positive, and then we tried to correlate them with the outcomes. So the MRD techniques that we were using were 2. One was the PET CT, when we're using the standard this FDG PET CT and controlled blood sugar and impetus scoring was used. DVLA 3 was considered to be positive, and we had 2 readers who interpreted the reports. For the multicolored flow cytometry, we were using 10 color one with made of Beckman and Coulter 2 tube, and we were using EMN guided this technique, and a single reader was doing the test, but it was counter checked by the company scientists. So total 434 simultaneous procedures were done. That means 434 events were there, where both the PET CT and the MFC was done along with the biochemical parameters and MDE evaluation. Average gap between PET CT and MFC was around, say, 7 days, because of the time which was taken, expertise coming, and there was a gap of around 7 days, and there was this breakup of this evaluation. So these are the data analysis which did. So now 163 multiple myeloma patients were transplanted, and 57 patients were excluded from this particular analysis. 16 because of we had this COVID infection in between, and 18 they withdrew for this. There was a withdrawal from the of the consent, and of 12 patients they had non-availability of physician for testing for this flow cytometer, and 9 patients had inadequate samples. So total 106 patients were analyzed. So 61.3% patients were male with a median age of 52 years with a range of 35 to 66 years, and 2 years overall survival total 2 years survival, overall survival was 80%, and 3-year overall survival was around 60.4%. So we found that among all the tests which we did, 37.2% of PET CT had positivity, and 29.8% flow cytometry came positive for this MRD. So we had higher MRD positivity with PET CT than the MFC. Then when we stratified this overall survival with PET CT positivity negativity and with MFC positivity negativity, we found out that with PET CT positive and negativity, the curve they separated well. So that means that PET CT had a better positivity negativity, had a better discriminatory ability to describe overall survival, and than the multi-parameter flow cytometer. Not only that, the PET CT which we found that on an average, or the median, the PET-CT was able to detect these MRDs about 6 months prior to the our MFC, although it was not statistically significant, but it came that it was around 6 months prior was there. We also found out that the universal availability of multicolored flow cytometry was more difficult. There was issues with standardization, and it needed lots of expertise to report the test, and which can be shown by this figure of 12, which patients were excluded because of the non-availability of physicians for testing. We also found out that 18 patients they withdrew from the consent because of 6-monthly bone marrow tests. Costs were comparable. Both all the indirect and direct and societal costs were comparable, although we didn't do any formal testing for the same. We also tested for that whether cytogenetics made any difference, whether the time to transplant from the disease onset made any difference, whether the pre-transplant regimen made any difference, and whether the pre-transplant remission status made any difference, or whether the post-transplant consolidation regimen which we used made any difference, but there was no difference in among all these points. We did only univariate studies to one by one we kept on checking. So to conclude, whatever little we had, we can, it gives us an indication that the PET-CT is a better marker for prognostication, prognosticating the relapse and survival of patients in post-transplant scenarios, and they are more easily interpretable, they are more acceptable to the patients, and they are more widely available. Thank you.
Yeah, any questions?
Yeah, please.
Yes.
How frequently were you doing the PET scan post-transplant?
Post-transplant for this study we were doing 6 monthly.
Every 6
Yeah,
months.
but ideally we should not do it, but for the study we were doing 6 monthly.
So if, would you recommend if
No.
Would you not? Thank you.
Yearly, at least I think yearly would be okay, not more than that.
But with a third of population being excluded, the conclusion may not be.
Yes, that is what I told, that within a limited whatever thing we have, but it is not well generalized, always well generalizable. It cannot be.
And the flow cytometry was done at different places depending where the patient.
No,
was.
it
So
was
non-availability of the flow cytometry was because of.
Because of the like the expertise, we had postings issues also. The
Okay.
expert person goes on posting, not on posting, on leave and other things. Those were the issues.
Okay, okay.
So we were getting samples from other places to Army Hospital RNR only. That was the only place where we were doing this MRD. So those were the issues that we were facing.
And you did pre-BMT MRD also?
No, pre-BMT MRD was not included in this study.
So any explanation why PET negativity was greater than MRD, which it's possible, but is it technical, is it real, and how many patients were both negative? And
both PET-CT positive or negative, sir? It was
both
you can say,
negative and positive.
both negative and positive. Sir, the data was a bit complicated, sir, because there were lots of time points when we were getting the data, and when we compared it in whole. So it is not exactly that good a analysis so that we can exactly tell that way. But what we found out was that the PET-CT was positive in 38% cases, sir, and that was positive in 28% cases. What I feel that maybe because of, I think it was because of expertise, the better way in which we were able to identify the PET-CT abnormalities, the better discrimination which were there, than the MRD, which was leading to, which had led to this type of picture that came. Because MRD, it didn't have that much of ability for overall survival, the differentiation. Maybe it was because what I feel that MRD was catching only very initial part of the disease, and PET-CT, the disease is already there in the macroscopically it was visible to our eyes. So I feel that PET-CT, when it came out to be positive, the disease must have had little bit more. It had become little bit more than the MRD positivity. So what I feel that this is because this PET-CT had this discriminatory ability for overall survival, but MRD didn't.
So
So what was the overall survival post-transplant in your cohort?
80%, madam. 80%.
Median time?
But just it was around 2 years.
So you mean to say that, since bone marrow is, most patients are not willing to get a bone marrow done, so you do a PET CT. If that is positive, that means MRD
Yes,
is positive.
yes,
So
yes,
it is
sir.
better to, continue the treatment
Yes,
or
that
whatever
must be the-
rather than doing the bone
absolutely,
marrow.
sir. Absolutely, sir.
Okay.
Thank you, sir.
Thank you. I call upon Dr. Ritu Gupta for delivering next talk. She's going to speak on flow cytometry, the AIMS experience.
Good afternoon, everyone, and I thank the organizing committee for giving me this opportunity to to attend this meeting, and the chairperson for connecting me to the audience. So, in the next 10 minutes, I will share with you the data on MRD from AIMS, but before I share the current data, I would like to take you to this initial study of ours, which was compiled in 2016. And in this study, we had analyzed 71 patients of multiple myeloma post-autologous stem cell transplantation. And what the sensitivity of this assay at that time was 10 to the power minus 4. And what we found was that the MRD had high positive predictive value, but relatively low negative predictive value. And this was in comparison to SFLCR in 65 of the patients. So the reason for this kind of result was because MRD could have been false negative due to the low sensitivity of the assay that we employed at that point of time, and because of the hemodilution, which are two issues that plague this technology for detecting the measurable residual disease. So after having done this study, we, before venturing on to our current study, we went back to our initial work in 2009, where we used a similar sensitivity assay for MRD, but at that point of time we were comparing it with the conventional method, that is the SPEP and immunofixation, for differentiating the complete responders from the partial responders. Now here we found that when we were trying to differentiate the complete from the partial responders based on the aberrant plasma cell percentage as a numerator of the total bone marrow cells, we could not find a cutoff value. But when we changed the statistic, the denominator, instead of the total bone marrow cells to the total plasma cells, we could find a clear distinction or a cutoff mark which could differentiate the complete responders from the partial responders. So taking both of these studies into consideration, we ventured on to this current study where we evaluated 170 patients of multiple myeloma at day 100 post-transplant using a 2-tube 8-color or a single-tube 10-color assay. The sensitivity of this assay was 10 to the power minus 6, and the cutoff for MRD that was used was less than 0.001. So here, because of our knowledge from the previous studies, we used two statistics, the MRD total, which is used across all the centers, and we also use the NPCI or the Neoplastic Plasma Cell Index as another statistic to evaluate our results. So the median time from diagnosis to ASCT in this cohort was 12 months, the median PFS after ASCT 36, OS 41.5 months, and 65 patients progressed and 38 had died till the analysis stage. So these are the baseline characteristics of the patient cohort, and here you would appreciate that none of the baseline parameters correlated with PFS and OS after transplant. The only parameters which made difference were the lines of therapies before transplant for the PFS and the pre-transplant ASCT response. Pre-ASCT response by conventional parameters. So there was a question in the morning that whether the MRD pre-transplant, does that influence the outcome? So here we have shown that the deeper the responses prior to transplant, the longer would be the PFS and the OS subsequent to the transplant. So then we, since none of the baseline parameters made a difference, we looked at the impact of responses on the PFS after ASCT. So we found that the pre-ASCT responses, the post-ASCT responses and the upstaging of response from the pre to the post state ASCT contributed to the PFS as well as the OS. And you would appreciate that the FCMA MRD had the maximum hazard ratio for both the PFS and the OS. That is, it was the strongest predictor of survival outcomes. Now, in the analysis, we already have a cutoff value for the MRD total, that is 0.001. But for the neoplastic plasma cell index, for this statistic, we do not have a cutoff value. So what we did was we used a K-adaptive partitioning modeling on the PFS to find the cutoff which could segregate the patients based on survival. So this is the cutoff that we found. We divided them into, just like to assess the graded level of the response, we divided the levels into 3 there. NPCI 1, 2 and 3 levels, and you can see that with these cutoffs we could find a clear separation of the survival curves both for the PFS as well as the OS. So this is the result where we've looked at the simple yes or no MRD at the level of 0.001, and then with each log reduction in the MRD we can find the differential survival outcomes, and similarly for the NPCI we can find different survival outcomes with increasing depth of response. So then we wanted to know whether NPCI is a better statistic than MRD total. So we used two statistics, the C index and the AIC, the archaic information criteria. The first one, if it is higher, the model is better, and AIC is generally used to compare two different models on the same data set, and lower is the value, the better is your model. So in this, the NPCI scored over the MRD total. And in this study, we had paired samples for 113 patients in whom the PET CT was also done at day 100 post ASCT. So what we found was that although independently the PET CT was not able to differentiate between the PET positive and PET negative patients, did not have different survival outcomes, which was statistically significant, but when combined with MRD, we could get a stratification. So it contributed to improved prediction of survival outcomes when combined with MRD. So the next question that we asked was, in this era of MRD, does assessing conventional response has any role? So we segregated up MRD positive and negative patients, and then we looked at the survival times between the between the conventional response positive and negative patients, separately between the MRD positive and negative groups. And what we found was that the patients achieving maximal conventional response have survival benefits in both the MRD positive as well as the MRD negative groups. So to summarize, that 4 take-home messages from this study. First, the increasing depth of response with gradual fall in MRD, either using MRD total or NPCI, is predictive of superior survival outcomes. And NPCI is a better predictor of disease progression and mortality, because essentially it somehow takes into account the amount of hemodilution, because in a hemodiluted marrow, both the normal as well as the aberrant plasma cells are likely to be equally diluted. Then PET CT positivity contributes to improved prediction of survival outcomes when combined with MRD, and patients who are achieving maximal conventional response have survival benefits in both the MRD positive and negative groups. And it highlights the essence and the rationale of using the conventional response in this era of MRD evaluation. And I will end here by acknowledging my colleagues from AIIMS, New Delhi, and my collaborators from IIIT Delhi and the funding agencies, the Department of Biotechnology and DST, for generously supporting our work over the years.
Thank you, Ritu Gupta. Any questions?
So, Dr. Ritu, very good work. So, the neoplastic plasma cell index. So can you just elaborate it, whether it was done on flow or it was IHC or?
Sir, it is the same thing, that you detect the aberrant plasma cells using flow cytometry. Whereas when we are reporting MRD by flow cytometry, the calculation is that we calculate it as a percentage of the total bone marrow cells. So the denominator here is total bone marrow cell and numerator is the aberrant plasma cells. In NPCI, the numerator is the same, the aberrant plasma cells, but the denominator is total plasma cells, and it is multiplied. It's just a percentage of that. So it is based on the premise that in a hemodiluted marrow, both the normal as well as the aberrant plasma cells would be equally diluted.
But so the marrow that you do, the standard was the first pull marrow in all the patients, or?
Yes, sir. That was a standard for this study at first pull
First
marrow
pull
was
marrow.
used.
Okay. So, if there are no questions, thank you. Thank you very much. So
we can continue.
continue. Okay, so we have got a lot of information on MRD and MRD right from morning. So I now call upon Dr. Nikhil Munshi to speak on measurable residual disease monitoring in myeloma. As we've heard various types, techniques, duration, timing. So just to put it all together and tie up the loose ends, we have Dr. Nikhil Munshi to speak to us.
Thank you very much. So I think we have over last day and a half now discussed MRD in bits and pieces. So now this is the more focused discussion on MRD. I'll be a little bit quick because we have discussed some of this quite intensely as a question answer thing. So these are my disclosures. So there are two methods, as we all know, flow-based and sequencing-based, and both are very standardized. And as we discussed a little bit yesterday, the method does not matter. Both methods are very well standardized. They can be reproducibly done by many labs. What is important is which lab is used to or good at doing which method. And so there are institutions that they do good flow, and that's absolutely fine. On the US side, because commercially available NGS method, we send it for convenience for various other reasons. But as far as technical aspects are concerned, the only critically important component is that the method should be able to have a good sensitivity, 10 to minus 5 minimum, 6 preferred. The rest other doesn't matter. In myeloma, most of the time when we do MRD, time doesn't matter. We don't need result next day. If it takes a week, our decisions are not so dependent. Ability to know the marrow dilution is an important component, which NGS does not do. NGF would do it, as Dr. Gupta showed in her presentation. So basic principles of before we use it for clinical purpose, the depth matters. And there are many studies. One which has been shown many times is in this particular study, the top curve is patients with 10 to minus 6 MRD negativity, and then 5, 4, and positive. And so you can clearly see patients who have minus 6 have better outcome. The next question is that it shows benefits at every stage. And by now there are many studies done. I'll just give example of each of those scenarios. One of the better known and one which we were involved in is this IFMD-FCI study, transplant versus no transplant. And you can see that patients who are MRD negative, the red curve is significantly better than the one positive. And if you look at these patients where there were not too many overall survival events, even then the curves separate significantly for MRD negative. So both PFS and OS is importantly driven by MRD negativity. The same thing is true for older patient population. So Dr. Rajesh showed this data earlier about Maya study, and you can see that patients who get DRD get higher frequency of MRD negativity versus RD alone, and both the curves are on this side. The important point is that whether you got 3-drug or 2-drug regimen, if you're MRD negative, your outcome ends up being similar. And that in some ways drives the selection, especially if the resource constraint setting, you can decide what you want to use as far as the endpoint remains the same. Now MRD is important for maintenance, and you could see in this this was the IFMD-FCI study, where you could see that while patients are getting maintenance, they are deepening of their MRD. And so one of the purpose of getting maintenance is to also make patients who are MRD positive to become negative. So in this particular case, response at the beginning of maintenance, there were 25% patients were MRD negative. At the end of 12 months of maintenance, which was the prescribed maintenance in this study, that number had gone up to 38.5%. So there is deepening of response, and that's another reason why we should do MRD measurements periodically in this setting. And then what is also becoming now very clear, that even in relapse patient, MRD negativity can be achieved and they are meaningful. So Castro and Pollux are two very well described studies. Everybody talks about it for MRD angle. In both of those studies, you could see that at the different depth, patients do get MRD negativity. So if you look at 10 to minus 6 being the gold standard, you can see 3-drug regimen gives around 12% MRD negativity versus 2.5 for 2-drug and 4.4 versus 0.8. 10 to minus 5, after saying all this, is more frequently attained, and that's a good enough standard to be utilized as well. I do believe 10 to minus 6 is better, and if you're going to take clinical decision, 6 would provide better significant impact than minus 5. And if you look at Castro and Pollux again, both 2 and 3 drug MRD negativity with the top two curves on both the sides are very overlapping. So if you're MRD negative, of course there is better PFS, but again, it doesn't matter how you get it with RD or DRD or VD or DVD, their outcome is very similar. And I think this is very recurrent theme across all different studies. So putting all those studies together, there have been multiple meta-analysis done. This particular meta-analysis was more than 100 publications were distilled into some thematically similar patient population. Overall, 8,000 patients are in this meta-analysis. And the message is very straightforward and simple. In many cases with long follow-up, that in newly diagnosed transplant eligible patients, that's the top curve, newly diagnosed transplant ineligible patient, the left curve, and on the right side, relapse refractory or relapse patients. In all three, the yellow curve, which is MRD negativity, is significantly better than the blue, which is MRD positivity. So there is clearly no question that MRD negativity provides a better outcome. What is interesting from the same study is that if you look at MRD negativity in the three patient population, the transplant eligible, ineligible, and relapse, those are the top three curves. And you see here is that the green curve is relapse refractory patients, and their outcome, even though they are relapse, is very similar to newly diagnosed patient population. So if you get MRD negativity, you can make them similar to newly diagnosed setting. And the frequency of getting MRD negativity is lower. But if you get it, their outcome becomes much superior. So this is a clear enough indication that even in relapse, we should try and obtain MRD negativity by all various means. And then in the same study, all various subclasses were evaluated for impact of MRD. And in every setting, whether it is cytogenetic risk group, whether it is depth of the response, the type of the method used, each one provides better PFS when they are MRD negative. And the second curve is overall survival, similarly improvement. And so whichever way we look, MRD negativity provides better outcome. Now, we talked earlier, I think it was today or yesterday, I forget now, but we talked about risk and treatment. And in the risk group, you could see that if you get MRD negativity, and I showed the same slide, I think it was yesterday, the outcomes are very similar. ISS 1, 2, and 3 on the left side, they all have overlapping curves. So on the right side, for MRD positive, ISS 1, 2, and 3 groups are separating. And so that's an important point. And the second one is that if you're high risk, if you get MRD negative, your outcome is similar to standard risk. So to convert a high risk into a standard risk, we need to get MRD negativity as a first step. Again, treatment doesn't matter how you attain it. And then finally, important concept, which is not very innovative or surprising, but if you get a sustained MRD negativity or maintain MRD negativity, those patients do better. So the top two curves are patients who either remained MRD negative or they became MRD negative later. They have the best outcome. Versus if you don't sustain it or don't get it, those are the bottom two curves on both sides. their outcome is not good. And this has been highlighted in multiple other recent studies. For example, if you look at in this particular study from Maya, the top curve is patients who had MRD negativity more than 12 months. So this is where you want to repeat it 12 months apart and get MRD negativity. The middle one is less than 12 months or not more than 12 months, and the bottom is MRD positive. And so maintaining MRD negativity is another component, and that's where maintenance treatment comes into picture. And this is a final word that even with the newer treatments like CAR T cell, getting MRD negativity is important, and also sustaining MRD negativity is important. So if you look at all various curves, the top two curves here are patients with MRD negativity at 12 months or at 6 months or more than 6 months. They have the best outcome, versus the middle curve is MRD negativity less than 6 months, and then the lowest curve is MRD positive. So even with good immunological treatment, getting sustained MRD negativity is our endpoint. Two other points to be made. One is how can we make decisions based on MRD positivity, and what are the ongoing studies, and there are many of them. So we have to have adaptive therapy based on MRD, and one of the good trial that you have seen before, so I'll skip it quickly, is the master trial where patients get DARA-KRD, and based on when they get MRD negativity, they go on maintenance and or no treatment, otherwise they continue the consolidation. And this study clearly shows that even at 10 to minus 5 and 6, the top and the red and the blue curve, as patients go through the treatment, you see increased in MRD negativity. The red curve is going up. But in the same context, if you look at patients with high risk features 1, 0, 1 or 2 or more, at least in high risk 0 and 1, you get good MRD negativity. More than 2, there is slightly reduced MRD negativity, especially when you look at 10 to minus 6. And that's better illustrated in this curve, where you could see that the relapses or resurgence of MRD is very good, very low in patients with 0 and 1 high risk, versus it is slightly higher. And keeping in mind that these are the patients whose treatment was truncated based on whether they became MRD negative or not. So we can drive our treatment based on when they become MRD negative. And there's an ongoing study, which is the actually French study, which from Dana-Farber we are participating closely on the correlative side. Is an interesting study which will answer a very important question for us. Patients get 6 cycles of ESA-KRD, then MRD is measured, and patients who are MRD negative, that's a top box, they're called standard risk, but here standard risk is MRD, not cytogenetics, so it's a little bit of misnomer there. But when those who are MRD negative are being randomized to transplant versus no transplant, question being that if you're MRD negative already, do you need transplant, and would you provide benefit? On the MRD positive side, the effort is to get MRD negativity and see if that benefits or not. So this MIDAS study is almost 2/3 accrued out of 700 patients. End of this year, end of 23, the study would be completed, and then we'll wait for the results. And the good part is the endpoints are MRD driven, so we don't have to wait for PFS for 6 years. We'll have results within around 18 months or so. The second or the last question here is that if we're making decision choices, can we decide if the patient becomes MRD positive from being negative, when do we intervene? If it's MRD negative, tomorrow is positive, nothing else, do you change the treatment? And there is really no answer, and today the answer would be I would not change treatment, except there are scenarios where we want to keep in mind, like very significantly ultra high risk disease. So there are data suggesting that if you get MRD negativity into positivity, there is an impending relapse. And these are 3 different scenarios with 3 different drugs, which shows that patients who became MRD positive, their outcome, their survival is truncated or less. And you can see in the curve, especially in the middle and the last curve, you could see that the light blue bar are patients who have lost their MRD negativity, their survival is lower, indicative of need for intervention at some point in time. The better answer will be provided by this study called Remnant study, where patients who are MRD negative, they go on this study and then wait for MRD positivity. When patients become MRD positive, they're going to be randomized to getting immediate intervention, and immediate intervention here is DARA-KD, or the physician would wait, have a clinical relapse, and then start DARA KD, and then primary endpoint is PFS and OS to see whether immediate early intervention provides better outcome, because at that time the disease volume would be much smaller. So that's the combination of it. Now there are many methodological problems in MRD for clinical application. We know solitary plasmacytoma won't be seen, and I think those limitations and how to overcome is going to be the next talk by Dr. Rajevich, how imaging is going to be helped. And also there are all different studies undergoing with circulating free DNA and others that we talked a little bit yesterday to overcome this. Now, the final word is this, that we have there's a big effort ongoing in the United States and internationally, not just the US, called I-Square team, where data from every MRD study is being collected to be submitted to FDA so they can use MRD as a surrogate endpoint. And there are 12 randomized studies. You can see there are multiple two-arms comparison in there. Almost 32 such comparisons with MRD data from close to 14,000 patients. And every study at every level of depth shows single thing, that MRD negativity is better. So for our discussion, it still doesn't meet the FDA's level yet, and we'll get there. But for our discussion, I think it's clear that MRD negativity needs to be utilized for our practical purpose. And there are people who you will hear saying, well, I had a patient who was MRD positive and I've been following for the last 20 years. There are always going to be exceptions. That's not the rule, and so that's not what we want to apply. And we need to know how can we do better. So we will make it better, 10 to minus 5 to 6, and include HCT and other things. But we can use what we have today. So if we can do 10 to minus 5 or 6 MRD with the methods we use, I think that is good enough. And the negativity need is that we don't want to keep a residual disease. If somebody is a breast cancer, we're not going to leave residual disease. The principles of oncology should not change between one versus another. And I would not go into prognostic versus predictive, etc. It does have clear evidence of benefit, and there is large amount of data. So the summary would be, when should we do MRD testing? A preferred general time would be when patients get complete remission. That's a straightforward. On our side, on the research side, we do more often. We do pre-transplant, we do pre-maintenance, and then every year after maintenance. If affordable otherwise, that may be a best way to do it, because MRD measurement doesn't mean I'm going to just look for negativity. I can also look for what proportion of plasma cells are there. So today a patient is 0.084% plasma cell, and tomorrow it's 0.015. Maybe the burden is going down. So I think doing periodically is going to provide important information. So one is we should do it to have a real depth of disease, whatever level, below 1%. We need to get MRD negativity, and at the minimum, definitely in patients who are high-risk myeloma. And then we can decide on need for consolidation. If negative, I wouldn't worry about consolidation. Also in high-risk patient population. Also, as we talked yesterday, how long the maintenance treatment to be given. We give on average 3 years. But can we decrease it in a very high, good risk MRD negative patient sooner? If the toxicity is there, we can use MRD to decide on our ultimate outcome. So maintenance decisions are important. And in relapse patients, one, we get MRD negativity. Two, we can decide based on MRD positivity with clinical response. So I think MRD is going to be sort of an end to achieving a cure. If you don't have MRD negativity, we won't be calling it a cure. So I think that's the first step to curing myeloma. And I think I would stop there. Thank you very much.
Thank you. Thank you, Dr. Nishu, for that cogent and clear message. Any questions?
I'd like to ask you, is there some data to suggest that the sooner you are decreasing the residual disease level, say do it every cycle during the induction, and if you see a nice steep falling curve, then you're going to do better, or is that an indication of change in the induction drugs?
No, I think during the induction time, proteins are a good measure for decline, and that tells us the tempo of response, etc. So I would not do MRD at that point. I think when the protein becomes less useful, whether they're too low, is when bone marrow MRD would become important component, and I wouldn't do too often, because what is likely to happen, and it has happened occasionally for some of our patients too, that you measure 2 times, the second time it's higher, and that's going to put you in quandary whether it's relapsing, what is going on. So if you do too often, you will see, one thing, the variability you see in the measurement. Number 2, it's a patchy disease, so you might hit a different spot. So I would not do very often MRD measurement, and not too early on either.
So get to a CR as per current definitions and then only.
And then do it. The only reason, the slight caveat is that some of the VGPR patients are MRD negative. And the classic example are the CAR T patients who have such a very quick response. The bone marrow is negative in 3 months, sometimes they are negative in 1 month. However, the protein is going to stay on for 6 months because half-life is longer. There's a lot of protein which is extravascular, so it comes in. Your immunofixation is still positive, can't call CR. So those are the situations. Very quick, good response is where MRD negative we might be obtained. And most of the VGPR patients who are MRD negative, eventually, if they're truly negative, become CR. So that's a small set of patients where VGPR and MRD might be measured.
Yes, doctor.
Just to this from that you said about CAR T cells, many a time when we are assessing on the biochemical profile, the electrophoresis free light chain, after some time it just tends to linger, and the free light chain ratio still is just about the number as per the definition. So would you recommend that we should defer doing the MRD at that point, or
in CAR T setting?
No, in a regular induction therapy.
The free light chain ratio is a finicky thing, because the ratio depends on the other light chain, which the theory would be that the other light chain will be normalized and the other one would be normalized. And so the ratio is not the best. So do I need a stringent CR? Probably not. I would do in a regular CR as well. And just because light chain dynamics are a little bit different.
Sir, one question. Sustenance of this MRD is most important. Sustenance of this MRD is most important. For example, analogy of chronic myeloid leukemia. If the MR 4.5 more than something 3 years, we are saying the functional cure, and we are planning for TFR. Are we going to see such hope in the cure, functional cure in the multiple myeloma after 3 years or 5 years?
Absolutely, probably less. The current thought was be 2 to 3 years. So the sustained MRD negative 2 to 3 years would sound good. This is a guess. We'll have data in maybe a couple more years and might be able to say it more confidently.
Your last question.
Dr. Munshi, if the patient is MRD, would you recommend doing the protein FLC ratio also?
I would. So that's a good question. If somebody is MRD negativity, and the fact that MRD negativity could be driven by other, I wouldn't call it false negative, but it could be because of dilute marrow or technical issues. I would still do FLC and SPEP and immunofixation just to be sure there's a CR. Because there's also a component, and what is probably FDA going to accept in US is not just MRD negativity, but also CR. So acceptable endpoint for clinical study is likely to be CR with MRD negativity, for which we would need protein studies to be done.
Thank you.
Thank you, Dr. Munshi.
Thank you.
I will call upon Dr. Nupur Raje to deliver our next talk, role of imaging in monitoring response. So I think that will complete the circle on monitoring.
Thank you so much, and I see people still around. I've been hearing, at least at this poster session, I think you guys are doing more imaging. I think the data that I'm going to show you is less so. It sounds like your imaging is cheaper in India, and PET scans and MRIs seem to be done more. So you guys have more data, and at least at the poster session, I heard a really nice presentation on comparing diffusion-weighted MRIs with PET scans. I'll show you data, but it's the one you have here is way better. So what I wanted to do right now is just kind of talk to you a little bit about imaging, and all of you know that for imaging for bone disease, the skeletal survey has always been the gold standard for years now, and we've been using it, and some centers even in the United States use skeletal surveys. What we are going to try and cover is benefits and limitations of the different imaging techniques. We're going to look at bone versus bone marrow sort of imaging. We're going to look at early disease, advanced disease, and then look at monitoring, initial diagnosis, and then finally monitoring with all of these different tools that we have. So just thinking about the skeletal survey, you have on a skeletal survey, you will have abnormalities in the axial skeleton in about 65% of patients, so vertebral bodies, ribs, skull, shoulders 40%, long bones it's about 25% or so. The advantages of skeletal survey, obviously it's an easy enough test. You can find CRAB criteria there. There's low radiation dose. Disadvantages, obviously all of you are familiar, low sensitivity, there's low specificity, several regions are not really clearly seen, specifically the vertebral bodies, sternum, ribs, not well seen, even the pelvis is not well seen on x-rays, and it's really not a comfortable test for patients. So a skeletal survey actually takes about an hour and a half, and patients who are with bony pains actually do not like a skeletal survey, so it's quite uncomfortable for them. And I think one of the biggest limitations of conventional radiographs is lytic lesions seen on plain films. You have to have about 30 or 50% of the bone to have been destroyed before you can start seeing things on an x-ray. So now that we are talking about MRD, as you just heard so nicely from Dr. Munshi, we need to step up our game. We need to do better in terms of what we use. This is just an example of an x-ray on your left out here, which doesn't really show anything, and a CAT scan, and you see this huge lytic lesion with almost extramedullary extension of that bony lesion, which really does not even show up on an x-ray, despite the fact that this is such a massive lesion. And this is largely because of bowels in that space, etc. So not a good area for x-rays, clearly. We have moved over completely to low-dose CT scan in myeloma. It's certainly way better than using a skeletal survey. This is one place where you can actually see the whole body. You're looking at long bones. The only part which is not really seen on a whole body low-dose CAT scan may be really the extremes like your feet, etc. But in general, most of it is seen. You can actually evaluate stability of bone disease as well. And it's a very quick procedure. It takes about 2 minutes for a patient. So patients really appreciate it. I think the people who hate a whole body low-dose CAT scan is the radiologist. And the reason for that is, and now at least at MGH, what at least our radiologists have said is this test is only being done for multiple myeloma, because they do not spend time looking at lung and other organs, because it can become a medical legal thing when they start reporting on this. So they specifically will say that we are only looking at the bones in this case, and if you find a small lung nodule which has been missed, they don't want to be litigated for that. Obviously, it's a little bit higher in terms of radiation doses compared to x-rays, but it's not that much higher. It just doubles the amount of radiation exposure, and certainly way more convenient. It's certainly less sensitive than an MRI, or even not a functional imaging like a PET CT scan. So whole body low-dose CAT scans are being done. That is the standard of care for us right now. We've moved completely away from skeletal surveys, and I'll tell you the places where we use PETs and MRIs. We don't use it in all patients, but in specific patient populations, we would use it. So what about the role of an MRI? And this is an X-ray of a patient with multiple myeloma. On the X-ray, you really don't see any bony abnormality at all, and this is the MRI of that same patient. And what you can see at that vertebral body is actually a small compression fracture, a focal lesion, which would have been completely missed on an X-ray. So if you are doing skeletal surveys on patients with MGUS and smoldering myeloma, I think you cannot stop at an X-ray because you will be misdiagnosing. And in fact, based on our new diagnostic criteria now, you have to have either a PET scan or an MRI to make sure that they do not have active symptomatic multiple myeloma. What are the advantages of MRIs? The advantages are obviously it can show infiltration before the bone is completely destroyed. You can see also differences between benign and malignant lesions, and depending on the nature of infiltration in the marrow, it does have prognostic relevance as well. Disadvantage in terms of MRIs are not like PET scans. PET scans are more functional, and when you come to following patients, a PET scan may be easier to follow patients with, although we do have newer MRIs now, which is the diffusion weighted MRIs, and they can in fact be used as functional modalities as well. So this is still work in progress, but certainly in a patient where you're thinking of specifically the spine, it's really important to get an MRI as opposed to any of these other tests. This is just showing you different appearances on an MRI. You can have focal lesions like this. You can have diffuse infiltration of the marrow space. And when you have that, these patients actually do much worse when you look at this patient from a prognostic standpoint. Sometimes, and more often than not, this is what we see in a patient where you see a variegated appearance. This is one place where I think it's really important to differentiate when you have, say, a 75-year-old lady who presents with an MGUS, has bad osteoporosis, has a vertebral compression fracture, and you do an MRI of the spine. If you have a variegated or a focal appearance or an infiltrative pattern on that bone marrow in an MRI, that is almost always a myeloma versus a compression fracture from osteoporosis in an old lady with osteopenia, osteoporosis, and an associated MGUS. So this is very helpful. The other place where an MRI is exceedingly helpful is when you're looking for cord compression. This is just showing you an MRI and the prognostic significance. If it's normal, obviously those patients do well. If you have focal, they do way better than patients who have a variegated appearance on an MRI. Again, we started now going from a whole spine MRI to whole body MRIs, and the whole body MRI obviously will pick up more disease because there is a lot of disease which is exclusively axial, and that can be or extraaxial, and that can be completely missed if you do just an MRI of the spine. So whole body MRIs are actually being done, not necessarily routinely at our site because we do preferentially whole body low dose CAT scans, but again, whole body MRIs as of right now we are doing as a research tool at our site. What about PET scans? PET scans obviously is a functional imaging. It has prognostic significance. You showed very nice data with your MRD data associating it with PET scan, and it really does correlate very nicely with MRD status as well. The problems with a PET scan is you might overinterpret disease, you might get false positive results. Out here I've just been hearing it seems to be cheap in the US. A PET scan is really, really hard to do because of the cost of it. We can get one baseline, but to necessarily follow patients with a PET MRI, we don't necessarily get full coverage, and plus the radiation dose for PET scans is quite significant. But this just gives you an example of how important a PET scan is. This is a patient who has macrofocal disease. This is one place where I do use a PET scan. What you can see out here is this patient did not produce a lot of protein, but you have focal disease in the scapula, in the humerus, in the rib, in the pelvis, got RVD, and just within 3 cycles, besides this little lesion here, everything has cleared. Now, if you look at the CT correlate, this is the PET correlate, complete clearance of that scapular lesion. Obviously, on a CAT scan, if you did a whole body low dose CAT scan, you're not going to see that improvement. So looking at CAT scans to look for resolution or to monitor these patients, you're not going to be able to see that, because you're going to continue to see that lytic bone disease, and in fact that might even get more aggravated once you get rid of the tumor within that space. So the role of an FDG PET CT scan, at least in our practice generally, is if you have a solitary plasmacytoma, you either do a whole body MRI or do a PET scan. Generally would do a PET scan if we are doing only spine MRI. Since our site has whole body, I pick one or the other. It does help detect extramedullary disease and is very helpful in non-secretory sort of macrofocal disease in patients. And PET scans has been shown, and I'll show you some data looking at PET scans as a prognostic tool and to follow patients with in terms of response as well. And because of all of these imaging criteria with MRIs, PET scans, and whole body CAT scans now, we have new diagnostic criteria, so you cannot rely on your old X-rays, specifically in patients with smoldering and MGUS patients. You, of course, if somebody has lesions on X-rays, it's a no-brainer, they have disease, but otherwise you have to do one of these imaging modalities to make the diagnosis of symptomatic multiple myeloma based on these new criteria. So the recommendations right now for imaging studies in patients with a diagnosis of smoldering myeloma, either do a whole body low dose CAT scan or a PET scan or an MRI, at least of the whole spine, if not whole body MRI. In a patient with MGUS, also do all of these, and on all patients, especially the MGUS and the smoldering myeloma patients, doing DEXA scans sometimes is helpful. For follow-up testing, routinely in patients with one focal lesion on an MRI, we do not consider those symptomatic. Those don't necessarily need to go on to treatment right away. Again, a repeat MRI is required and should be considered within 6 months. And if you see progression, that would be symptomatic myeloma requiring treatment. In patients who have smoldering multiple myeloma, again, doing a whole body low dose CAT scan could be considered. We generally will do this at least once a year to see that they are not bony progressing, because sometimes you won't see a monoclonal protein go up, but you will start seeing evidence of bone disease in these patients. In advanced stages, I've already talked about cord compression. This is the one place where MRIs are quite helpful. X-rays will not pick up the extent of disease, and you can pick up extramedullary disease, and this can be really important in terms of surgical interventions in this patient population. This is an extramedullary plasmacytoma causing acute cord compression in this patient. Also, you can look at bone stability with some of these imaging modalities. For monitoring therapy, what about the role of CAT scan? I've already shown you CAT scans are not good. You still have that lytic disease. I showed you that with the FDG PET scan. And this is where I think a PET CT or a functional MRI is quite important. PET CT has been shown and has been shown to have prognostic significance. So if you're PET negative, your outcomes are much better than patients who are PET positive. add on the MRD testing to the PET negativity, that increases the possibility of staying in a deep and durable remission. We also see that with MRIs. MRIs, it's a little bit harder when you follow patients with MRI, specifically the routine MRIs that we are doing, whole body MRIs. When you see focal lesions, those focal lesions do not necessarily disappear like the PET scans do. They take a little longer, and that was shown from the IFM study, which Philippe Moreau has already published on. What about the prognostic significance of residual disease in PET with PET CT scans? 189 PET CT scans were done after therapy. This was done by Elena Zamagni. And what she showed out here very nicely was that your PET, if you are PET negative, your median progression-free survival is nearly doubled compared to patients who are PET positive, again confirming the prognostic value of this. Again, prognostic value of MRIs also, if you start seeing lack of progression or no new focal lesions, from a progression-free survival, MRIs seem to be a good test. And again, we've talked about residual lesions on PET CT before maintenance. Also, again, all of these, like MRD testing, just add to your MRD testing in terms of better disease control with the addition of imaging in this patient. I think the whole body diffusion weighted MRIs are going to be the next test. They are a functional way of looking at this. You see a diagnosis, you see a patient in CR, all of those lesions have gotten better. It's almost like a PET CT scan, and the difference between here and a diffuse weighted imaging study, MRI, you're not giving a patient contrast, and you're able to pick up more disease compared to a PET scan. You're not going to be able to see inflammatory disease. So I saw a really nice poster looking at exactly this about an hour back. This is PET CT versus the functional MRI. This is just 20 patients. The person who presented the data today had 30 patients. I don't think we have any that higher number in any study to date, so I'm encouraging you to present and publish your data. But what this shows is that this diffuse weighted MRI is actually going to be a better, more sensitive way of picking up disease and also following disease in these patients. For us, these are harder tests to do because of the cost of all of these. This is again just showing you an MRI of the pelvis. This is an MRD positive lesion, and this is an MRD negative. This is an Arkansas kind of a study where they go into these focal lesions and actually do directed biopsies and look for MRIs on this. So the MRD negative disease, you see functionally, you're seeing less disease there. Again, when you look at MRD negative disease and PET negative disease, very similar to your data again, if you are MRD negative by bone marrow, whether it's next-gen sequencing or by flow cytometry, and your PET negative, have a much, much, much better prognosis. So I think the key points for imaging is that whole body low dose CAT scans is superior to general radiology. MRI is the best imaging method for marrow infiltrative disease, looking at focal disease, infiltrative disease, and in places where you're looking for cord compression. Functional diffuse weighted imaging is going to be the way to go forward to follow patients with an MRI. And as of right now, because that diffuse weighted functional MRIs are not available routinely, we are still using PET CT scans to follow patients and to monitor responses in these patients. So the IMWG has come up with sort of reporting criteria for these imaging, and now we are in the process of working on some of the discrepancies that you've seen, which Nikhil just mentioned, specifically in the immunotherapy world, where bone marrows you see MRD negative very quickly. I think correlating that with PET and imaging is going to be critical to make sure that you're going to see negativity in both the PET as well as on marrow MRD to call it MRD negative disease. So for the future, I think we still need to come up with better imaging. I do think the diffuse weighted MRI is going to be good. What we still don't have, though, is no markers, functional markers of looking at bone formation. We're using anti-catabolics, but there are drugs out there where we would be using bone anabolics, and as of right now, we do not have good imaging to look for bone healing and bone formation. I think we are getting better at clear guidance now on monitoring with some of these IMWG criteria. The problem is all of our imaging studies are very small, and that's why to come up with real good recommendations is becoming a problem. And in the clinical trial space, we are still using skeletal surveys, unfortunately. And because of that, we've not been able to change how we monitor this just as yet, because we've not been able to fund studies with 100 PET scans or 100 MRIs. So with that, I'll stop and happy to answer questions. Thank you.
I think there'll not be any questions. In the interest of time, I think we can go to the next
I'll
section.
ask one question here.
Yeah. Okay.
So, Pankaj here. Sorry. So, imaging is one, but has anybody looked at, the bone markers either in the serum or in the urine? We have good markers now, osteoclastic markers, and has somebody seen a correlation? Yes, instead of doing imaging, which is obviously difficult, radiation exposure except the MRI. Look at the bone markers, and if they have become normal, then does that suggest something?
Yeah, so we did that. We've studied bone biomarkers. The problem with bone biomarkers is all of our patients are on bone catabolic drugs, and when they're on them, all your bone biomarkers are suppressed, and really significantly suppressed. And the problem is the timing of doing the bone biomarkers. So certainly bone disease with CTX and NTX, entelopeptide and cetelopeptide, can be predictive of bony disease, but not necessarily of response. That's where the discrepancy is.
So in the CRAB criteria, if it's a diffuse or focal variegated involvement, it can be taken as CRAB now?
Based on the new diagnostic criteria that would be considered symptomatic. If it's just one focal lesion, you just repeat an MRI in 6 months, but otherwise a variegated appearance is bone disease from myeloma.
What about diffuse involvement?
Diffuse involvement would be bone disease from myeloma.
So for a frail old lady who has extensive osteoporosis, who has suspected myeloma also, which would be the best imaging modality?
So that's exactly where I would do an MRI. So if you have just an MGUS with osteoporosis and osteoporotic fracture, you're not going to see that bony infiltration. If you have that variegated appearance or focal lesions on that MRI, I'd call it myeloma with a fracture from the myeloma, and the myeloma has accentuated the osteoporosis, is the way I would define it.
And sometimes the bone is so friable that it's difficult to get an aspirate, impossible to get a biopsy.
Yes,
Right?
so absolutely.
Thank you, Doctor. Thank you. I now hand it over to the organizers.
Thank you to our chairperson and the speakers. We now proceed with a debate on the endpoint in myeloma therapy. We start with Dr. Neeraj Siddharthan speaking on why MRD negativity should be the endpoint of therapy. Dr. Neeraj Siddharthan is clinical professor in the Department of Blood and Marrow Transplantation, Amrita Cardio Oncology Clinic, Kochi.
Hi, good evening. So that today's debate is on MRD negativity should be the endpoint of therapy. And I have a very strong opponent, Dr. Sanjeevan here. So this, I think, endpoint is often mentioned only in clinical trials. So I think the organizers meant clinical trials. So I'm going to take it in the context of the clinical trials only. And then 4 things. So one is overall survival, 2 progression-free survival, standard response assessment, and the MRD. So let's go one by one. So these are different endpoints that the clinical trials have, and most important, as we all know, is the overall survival, and it has been the gold standard, and it doesn't require, and it is not dependent on the methods of monitoring, surveillance schedules, interpretation of test results or patient symptoms. But there are also problems with it. It doesn't address the subsequent lines of therapy, supportive care measure differences, the competing causes of death, and other interpretations. All this can interpret the OS results. And also, if you want to keep OS at the, it will typically require a large number of patients and very long follow-up. So in myeloma, we have seen a transition from looking from overall survival to progression-free survival as the endpoint. So, because it is increasingly difficult to design clinical trials with OS as the primary endpoint, and most of the recent trials have looked at PFS as even as a primary or a surrogate endpoints. So let's look at some of this. Now the one example is the CalGB trial. Now it is a benchmark of the OS post autologous transplant. It demonstrated an OS of 9.5 years for those who are receiving lenalidomide maintenance. Now that's 9.5 years, and based on the PFS of 3 trials, the US FDA got approved the lenalidomide maintenance, and the OS benefit was further confirmed in a meta-analysis. So now there is an ongoing trial by SWOG which is comparing lenalidomide to lenalidomide plus daratumumab maintenance, and it has been powered to compare a median OS of 10 years in the lenalidomide arm versus 15.7 years in the combination arm. So the estimated end of study here is 2040. Like by the time a trial is completed with this, the question addressed would become irrelevant. So that's the problem with OS. Now we are going to the PFS. PFS is now increasingly being used as a more meaningful endpoint in clinical trials. We listened to Professor Vincent Rajkumar in the morning alluding to this IFM 2009 trial where the OS was not significant, but what was really important was the difference in PFS, which was even very evident in the last update in 2020. So, so much so about the good things about PFS, but PFS has its fallacies also. We have seen the venetoclax trial, the Bellini trial, which had an improvement in the PFS, but there was toxicities, and then OS was significantly worse in the people who had an improvement in the although the venetoclax sham had a better PFS, it had a worse OS. The PFS is also has its problems. Another problem we identified was during the keynote trials, during the relapse refractory as well as the newly diagnosed patients. The phase 2 trials have shown good overall responses, and based on which the went ahead with this, but there were significant toxicities of in the experimental arm of pembrolizumab, and which resulted in worse PFS and OS. So now the problem is with OS, the problem with PFS. Now let us try and look at response rate as endpoints. The Cassiopeia trial looked at the depth of response, and it found that it looked at the day 100 post-autologous transplant with the DARA VTD versus VTD, and the stringent CR and CR rates were much better in the experimental arm, and that ultimately led to the approval of the quadruplet regimen. Another trial which looked at the response was as the primary endpoint was the Griffin trial, which again looked at DARA combination of DARA VRD, and it looked at the stringent CR after the end of consolidation. Now you can see that the stringent CR was much better in the experimental arm, and it further resulted in a better PFS. Now the conventional response rate also has fallacies. Let us see how. In the 40 trial, which actually looked at KCD versus KRD, and KRD in two arms, one with transplant and one without transplant, and the primary endpoint was a post-induction VGPR, and then it also looked at the post-consolidation VGPR. If you look at the post-consolidation VGPR here, between both the transplant KRD and the without transplant KRD, they looked similar. But what happened? In the PFS, there was a clear superiority of the transplant arm. So again, problem with the stringent CR or the response, conventional response arm. So now what to do? Now we have to look at a more meaningful validated surrogate endpoint. Now there comes the MRD. Now we have already listened to a lot of MRD talk today. So, and there are international multiple myeloma working group suggestions and criteria to define the MRD negativity both by NGS as well as by flow cytometry, and there is a sustained negativity which is more than 12 months, and then imaging MRD negativity is also described. And now there are many trials looking at MRD driven therapeutic strategies. You can see here one which I have highlighted is that upon MRD negativity after 12 months and at MRD relapse, then you reintroduction of daratumumab, that's one strategy. Another is image directed MRD, MRD directed therapy is also there. So there likewise there are different trials now looking at MRD driven strategies. Now there are analyses have tried to look at whether there is a correlation between the PFS and MRD. And initial analysis had shown that yes, there is a correlation, and Professor Munshi's meta-analysis had very clearly shown in more than 8,000 patients which we earlier listened to, in all subsets, whether it is relapse refractory or whether newly diagnosed transplant eligible or newly diagnosed transplant ineligible, high cytogenetic risk, low cytogenetic risk, irrespective of all that, MRD negativity showed a better progression-free survival. Now also the Pollux and Castor trials looked at sustained, the other question is sustained MRD negativity more than 6 months had a better PFS, and also the Maya and Alsaicon trial looked at more than 12 months of MRD negativity, again translated into a better PFS. Again, and we said about CR, and Professor Munshi sir was mentioning this, that all patients with VGPR you could do the MRD, because CR in many ways probably doesn't truly reflect the disease biology probably. And here in this analysis, they have looked at people who had not achieved CR but still were MRD negative, had better PFS while compared to people who had achieved CR but still was MRD positivity. So again, MRD seems to be much more predictive than conventional CR. So there are different trials now. And this looks like the trials incorporating MRD from 2015 to 20, and it is keeping on increasing. And as Professor Munshi was mentioning, there is an international consensus now, and it is actually suggesting that MRD should be included in all newly diagnosed and relapse refractory myelomas, and it should also include functional MRD, and also it should be included in trials with smoldering myeloma. So now MRD versus PFS, why MRD? MRD is an earlier endpoint, smaller trials, lower cost, and leading to a faster drug approval and faster drug availability. So now how to use MRD in drug development and approval? An earlier approval of a drug based on MRD as an endpoint could be considered, and confirmatory data on PFS and OS can be submitted at a later stage, and the methodology can pre-specify out any potential problem early could be, due to early licensure on MRD could be handled later. So an ideal setting for an MRD based endpoint is probably, I think, a relapsed refractory disease, where you could keep the MRD as the primary endpoint, and then that could lead to an accelerated approval of the drug, and then you could have a follow-up PFS and OS data, and then lead to a regular approval. And actually, if you look at FDA or EMA, there are several drugs, including the thrombopoietin receptor agonists that we use in hematology, which have been approved based on surrogate endpoints. So to conclude, I think I would say that OS and PFS are now two latent endpoints, and MRD is the most appealing candidate as a surrogate endpoint and even appears better than conventional CR. We should aim to use MRD as an endpoint for drug approval and development, and to do this we should clarify its role as a surrogate endpoint and answer the currently open questions. The late endpoints should be included in the trials and the confirmatory endpoints, and we should further improve MRD as a surrogate endpoint and look at the sustained MRD negativity and other composite safety evaluations, etc., endpoints and the safety evaluation. So with that, I conclude my argument, and over to you, Sanjeevan.
Thank you, Dr. Neeraj. Next up, we have Dr. Sanjeevan Sharma presenting why MRD negativity should not be the endpoint of therapy.
In cricket, there is a shot known as deflection, so Neeraj has actually deflected the debate already. So that's why what I'm going to do is, I'm going to actually copy paste the organizer's program, which says that the debate is on MRD negativity should the end point of therapy versus that MRD negativity should not be the end point of therapy. So very smartly, my dear friend Neeraj has made it as an end point for clinical trials. To that extent, let me begin with the disclaimer that I agree with you. Yes, MRD negativity is a end point for clinical trials and not for. Nevertheless, over the next 10 minutes, what my endeavor would be, after stalwarts like Dr. Munshi and Dr. Nupur having spoken, and since morning we've been listening only to about, what is good about MRD, what is so great about MRD, and here comes a guy who's saying, hang on, not everything about MRD is good. So I come from this beautiful city of Lucknow. So greetings from Lucknow, well known for its Nawab, Shababs and Kebabs. But today the flavor is not kebabs, it is MRD. And Dr. Hemant had marked yesterday in the last 3-4 years, why are we listening to so much about MRD and MRD? I mean, just a few years ago, we hardly talked about MRD in myeloma, and this is an answer. This is the number of ASH abstracts. If you see, in 2005, myeloma MRD abstracts were just about 2. It went up to around 18 abstracts, and actually last year in 2021, there were 35 abstracts dealing only with myeloma MRD. So that seems to be the flavor. So I am already convinced about that MRD being such a sensitive and specific tool, a surrogate marker of tumor burden, and allowing comparison of different drug combinations, treatment strategies, association between the depth of response. But actually I was not convinced that MRD would be a guide to stop therapy in myeloma, at least in the present term. Now the holy grail of any malignancy treatment is reaching this undetectable tumor burden somewhere here. Okay, the pointer seems not working, where we come to a level where the immune system of the body will keep the tumor burden so low that it will not have a clinical or a subclinical relapse. And to achieve that, we have got tools to measure. So for CML, we have a very simple tool, our BCR-ABL. For acute leukes, we've got very good high quality, at least for the ALLs, B and T cells, high throughput flow cytometry and molecular markers. But for myeloma, there's a wide web of methods. So if you had to get an intramedullary MRD, then you got the molecular things like ASO-PCR, NGS, and or the cell surface based multiparametric flow cytometry, and now got a next generation flow cytometry. If you want an extramedullary MRD detection, then you would use what Dr. Nupur so beautifully highlighted in the previous talk. And hang on, new kids are knocking on the block. Now, in times to come, you will have a MALDI-TOF to predict MRD. You will have LC-MS-MS. You will have a circulating free DNA, and you will have single cell RNA sequencing. So you will have these 12 or 14 different methodologies which will tell you, or a combination of that, whether the person is really MRD negative or not. And this is, you know, so while please concentrate on the right side of the screen where, you know, what is all good about MRD, we've been listening since morning, but every method of MRD, whichever methodology we use, has some issues either related to applicability, accessibility, or accuracy. So, you know, there are issues with each one of them. Now, these are tables directly taken from the IMWG consensus guidelines on MRD, which came out in 2016. And out of the various methods, I've just taken two tables here. This one deals with the flow cytometry based assays for MRD. Just look at the variability of the various studies. Most of them had comparable patients, comparable treatment strategies. One study reports 15% MRD negativity and the other reports 68%. Look at the wide variation. Look at the molecular based methods, 18%, 57%. So whichever methodology we use, if you look at the various studies in the meta-analysis, how much of MRDs they have been reporting. So definitely we can't be going so wrong that either the MRD is 15% or 60%. There has to be some middle ground. And I believe the reason is because of the sensitivity which we use. So if you use a 10⁻⁻⁴, your MRD numbers will shoot up. You make the MRD sensitivity 10⁻⁻⁶, it will come down. Probably if tomorrow a methodology comes with makes the MRD 10⁻⁸, all of them will turn out to be MRD positive. So no, because flow is the most commonly used methodology, so I just went through, and this is, you know, I gained this knowledge while preparing for this debate, and I thanks the image for, you know, allowing me to do this. So just the journey of how flow has come a long way from its humble beginnings in 1993, when just was used as a phenotypic differentiation of normal versus this thing, malignant plasma cells, to investigating MRD. So, you know, way back in 1999, people had already started, especially the Spanish Pithema group had started investigating flow as a tool for MRD, till it started using that it could compare efficacy of different treatment strategies and various methodologies, whether we used molecular methods or flow cytometry. It both were comparable, and then it came to its prediction in people undergoing transplantations. And you know, just I have highlighted in the red circles as the years have progressed that we've got graphs getting widened, which clearly show the benefit of using MRD as a tool for predicting longer PFS. There's absolutely no doubt on that. So much so that in 2002, the Euroflow had to come up with guidelines, because if a tool has to be used so commonly in the clinical practice based on which decisions have to be made, there better be some standardization. So this is the NGF, the measurable by the next generation flow cytometry, and this is an elegant study on a very large cohort of 484 patients, again saying that it is very people with an undetectable MRD, the PFS has not even reached. And this is in intent to treat patients undergoing transplantation. Basically, depending on the level of the cutoffs which we use, whether it is 10⁻⁵ or -4, the MRD negativity definitely predicted. Now, this was an interesting blood paper, which they did a random telephonic survey and a questionnaire survey as to how many physicians, hematologists, oncologists treating patients of multiple myeloma actually used MRD in their clinical practice, so outside of clinical trials. So out of the around 72 questionnaires sent, 32 questionnaires sent, 26 did respond, and these are the results. So look at the variabilities in the cutoffs used, so this is real world practice. The cutoffs used, the sensitivities which they obtained. So even in the US, when it comes to the practice in the clinic, it's got a huge amount of variability. So MRD as a tool still has got a lot of variability. Yesterday we heard about impetus criteria. Our speakers clearly told that we do not use impetus criteria, and I'll tell you the reason for that. Because when we insisted in AFMC, that is in 2014, that we will get all our PET CTs reported only if the PET CT physician reports it based on impetus criteria, they realized it takes around 30 to 40 minutes to report one single PET CT over and above the normal time which takes. But anyway, that is still a real world problem. To get a standardized report based on predefined criteria as whether MRD is negative, so that was on flow, even on imaging methods, there are issues. And lastly, I'll come to the issue of biology. You know, what we are looking at is, there is a cell surface marker, it was there and now it's not there. So if it is not there, I call it negative. But I believe when we give treatment for myeloma, MRD is not a uniform reduction of the entire tumor. We are just correlating that if MRD becomes negative, the tumor burden comes down. Probably that is right, but it may not be the 100% right. Because in any kind of tumor, there are far too many factors than just a particular expression. So this is a nice Chinese paper, you know, monitoring cytogenetic architecture. So they looked at cytogenetics, and what they said was that in their cohort of 193 patients, when they looked at cytogenetic abnormalities, even patients who were MRD positivity, who had MRD positivity with 10 raised to minus 4 sensitivity, people with a new persistent cytogenetic abnormality did worse than people who had lost it. So maybe there are other factors. Now, because of shortage of time, I'll quickly run through this last, otherwise this was an interesting analysis. Same group, PETHEMA group, one paper in 2016, the other in 2021, phenotypic and genomic, in which they went into a genomic analysis. So this time, in addition to MRD, they did very extensive genomic studies on their patients. So they got some data out of that. And in 21, the same group did again. So they, on a very elegant genomic analysis based on a single cell RNA-seq. And when they, another set of researchers, when they compared the two PETHEMA groups, they found that they, out of thousands of genes which they studied, which were down-regulated in MRD negative as compared to MRD positive, there were only 89 common genes. So we are missing out a whole lot of things. And this is what Dr. Neeraj had said, and this is the cat out of the bag. MRD is being talked about because it is leading us to allow faster drug approvals. Because if we wait for PFS and OS as markers to be used for giving trials, probably the next drug which is discovered today will see the light of the day in 2040. But if I use MRD as a surrogate at point, probably it will be there in the market in a very shorter time. So these are the unresolved issues, open issues, validated issues, unless of course the MRD gives us a Midas touch. Probably the results will be out in few years of time. As of today, MRD has got a lot of questions. I believe it has got more questions than answers. And I'll like Dr. Neeraj if he can address these questions in case it is for stopping treatment rather than, you know, being an endpoint of trial. How will you monitor? What would you do a yearly MRD? Would you do a 6-monthly MRD? And as Dr. Munshi pointed out, if a guy is MRD 10 raised to minus 5 negative today, 6 months later, everything is all right, but he becomes MRD 10 raised to minus 5, would you restart therapy? You know, a lot of unanswered questions are there. So with that, I come an end to my talk. In fact, today morning I got a message that next Saturday I have to be in Ladakh, so I welcome all of you to this very beautiful part of our country, the northernmost part, and I'll be very happy to host any of you, one of you who would be willing to come to Ladakh, and I mind you, it's a beautiful place to come. Thank you so much.
So the reason why I tweaked it is because I have never heard about an endpoint use in therapy in outside a clinical trial or in the real world treatment. Nobody uses that word endpoint.
Yeah.
So I tried, first thing I did was searching on this word endpoint. Okay, so every endpoint is described in the context of a clinical trial.
Right. Yeah.
So,
you know, at the end of the debate, we can blame the organizers for confusing all of us. So where's Uday? I think and Uday has very conveniently disappeared at this point of time.
Question was wrong. Right, but I think there are a lot of issues remaining in MRD. I think we would agree with that, but it's still emerging as a.
Give the reasons, give the food for thought for the audience. So you both have done a great job. So thank you so much.
Please note, there are 2 vehicles parked outside the amphitheater. We request the vehicles be moved as there is a cultural program that will follow there shortly. The car numbers are KA04MS4665 and KA04MY9561. As we bring the evening to a close, we have our last panel discussion for the day on implementing MRD protocols in the Indian scenario. Our moderator for this session is Dr. Joseph John. I request him to take the dais to introduce the panelists.
So while the presentation is going on, I would like to invite the panelists Dr. Ankit Chitani, Dr. Abhishek Purohit, Dr. Gurleen Oberoi, Dr. Paritam, no, not this, and Dr. Ritu Jain. So anyway, I think we should just start the talk. We are an overdose of MRD as of now, and as Dr. Pankaj said, the truth has already come out. Now we're churning it further. The elixir of life is going to come out now. Okay, so we've, so maybe I'll stand here so that I can see everybody on the side. So maybe I can't see the slides here, so I will just talk what I have in my mind. No. My slides, unfortunately, what I sent earlier has not yet reached. Okay, so the first slide I had showed was that, the number of cells in the body is about 30 trillion. And the number of bacteria we have is about 38 trillion. So that's where the MRD is all about, to try and deeply go into this 10 to the power of 5 when we have already about 10 to the 5 cells. And if you were to choose a chairman of our body, it would be an E. coli, because the share market is more in the bacterial point of view. So jokes apart, we have the 95% of the cells or more belongs to the hematologist. And in that, we are trying to find out this one cell which we need to find out. So, we had a big debate, and I would like to ask Dr. Gurleen, where would you want to use MRD in your practice?
So as it has been discussed, there are no clear-cut data on changing the therapy, but definitely for knowing the treatment the outcome, the patient outcome, doing MRD at the various time points depending on the protocol which is used. Mostly it is done post.
No, I just want, where would you want to do? Do you want to do MRD at all? That's the first question then.
Yes, definitely. Because
when would you do that?
Most importantly, post-transplant 100-day.
Post-transplant, day 100.
Day 100.
And would you choose flow-based or NGS-based?
In our setup, definitely, so next generation flow or a flow-based MRD is something which.
So what about a baseline? Is required, not required?
The flow has an advantage in the sense that there's a clear-cut difference between normal plasma cells and clonal plasma cells. We are able to pick up the aberrancies and the clonality. So baseline sample is not that much required in the case of the flow. And in comparison to the NGS, where the dominant clone has to be identified, though the patient-specific primer is not required, but the dominant clone has to be identified at the time of the baseline marrow, and then has to be followed.
Sure. So you say that you do flow. Any difference of opinion regarding the baseline requirement, not requirement on a flow? If you want to do a post-transplant, yeah.
So I take inspiration for the previous debate and I'll play the devil's advocate here. So if you look at MRD from an Indian clinician point of view, the highest importance for MRD is for the pharma companies. As everyone has highlighted, that you get a quicker results at an earlier time point and you're able to show the quantum of benefit from MRD is even higher than the quantum benefit shown by the PFS. So you've got to show excellent results. Pharma companies, they'll be the first ones to benefit from it. The second one would be the research institutes where as part of a study they're doing MRD.
Sorry. Let's not repeat the things there. I want to know, in your clinical practice, would you use MRD?
So, if yes, when? That, so from a patient's point of view, I'm saying that you have already attained CR. I'll do an MRD testing and then say you that you're already going to do better than the other patients who have not achieved CR. I'm just saying that you're going to have a 20% higher progression-free survival. And I feel that is not worth it.
So you wouldn't do that? Short answer is that. Any other difference of opinion?
So chance favors those who are ready for that. So I would go for MRD, sir.
You would do it?
Yes,
when would you do that?
Sir, looking at the CML scenario, sir, today we are targeting 10 to the power minus 5. After 2 years, we might be targeting 10 to the power minus 8. If we are not doing today, we are not updating ourselves technically.
That's the rational of it. So you would do that at day what?
Sir, it's not only transplant based, sir. Whenever we are suspecting complete remission or complete response, at the time we are suspecting complete response, at that point also, sir.
Sure. Ritu, you had some difference of opinion there, I think.
Currently, I'm convinced about the MRD, but as a clinician, I'm not in the research institute. I sort of agree with him. Right now, in my clinical practice, I would do in the very ultra-high risk myeloma for prognostication. Like after induction, pre-transplant, post-transplant, in a very high risk.
Sure.
Because there are cost implications.
Okay. So it boils down to what NGS versus flow?
It's a flow-based.
Flow-based. So I think as practical point of view, you would want to use a flow. So I just want to ask Dr. Nikhil about the necessity of a baseline sample in a flow.
In flow, you don't need to have the baseline because it is, as she rightly said, you can identify with the markers the normal versus abnormal, and so that's a big difference between flow and NGS. That in NGS you do need a baseline sample.
Okay, I just want to bring
flow you would not need it, and
post DARA, the challenges of a flow-based MRD.
Not a major issue. It's an important point because CD138 could be occupied and then looking for the primary cells, but with the number of markers that are there, DARA is not as interfering with flow-based method, and there are ways of using alternate antibodies also to get alternate CD138 domains to be identified.
So both NF, new generation flow, NGF and NGS can do away without a baseline sample?
No, NGS cannot.
Cannot.
NGS would need a baseline sample, except that you don't need a fresh sample. You can take a slide and scrape the slide and do it from the slide. That's what usually is done.
Sure. Anybody in this panel? Okay, no problem. This is the old slide, yeah. Yeah, please. Okay, so you think it is non-secretory myelomas you would get? Okay, so marrow is required in both the situations and you would want to do on a flow. No, but even if you want to do a response assessment, marrow would be a reasonable option unless you want to do a really deep molecular response. Sure. So because of short of time and overdose, we will move fast. And this we asked. And the precautions while doing a marrow, anything other than these you would want to do from your side in terms of being cognizant of the fact that MRD sample has to be first draw, small amounts?
I think that is very important, and that's where my pathology colleagues may or may not like it. So what happens in our center everywhere, the first sample always would go to pathology because that's where the real diagnosis would happen till yesterday. Now, at least the MRD sample, I would believe the first sample needs to go to MRD measurement, the second one will go to pathology and whatever else we do it. And that is very deeply ingrained in the system. So one has to make the change that if this is MRD sample, then the first pull should go to the MRD measurement.
So coming to that, sorry.
Yeah, thank you.
So the moot point then is there is a possibility of false negativity of MRD if the sample collection is not appropriate. How do you quality control that part?
I think that's where the flow has an advantage, that you can look for dilution by the content of the other cells and normalize it. So there's a very standardized, even automated algorithm that can be utilized to account for dilution and then look for overcome the dilution effect to see what the real MRD is there or not. In NGS, we cannot easily do that, or it cannot be done, and that's where we are stuck. One caveat to this whole point is that even if there is a dilution, so how much dilution you would see? Let's say 50%. Let's say there is a 90% dilution. So that's only 1 log difference. And so if you're getting 10 to minus 6 and it's 90% diluted, you will get 10 to minus 5. So we do talk about dilution, and this is old debate about NGF versus NGS, where one can do dilution, other one cannot. In practical term, even with a 90% dilution of the marrow, there is a difference of only 1 log. And so if we are measuring 10 to minus 6, now our measurement becomes 10 to minus 5, that's not so bad.
So you would be able to get 10 to the power of 5 or 6 cells for sure?
For 5, quite reasonably, yeah.
Okay.
So one point I would like to make,
please.
In our country, a majority of the corporate setting outsource sample for flow. So considering the lability of plasma cells and the risk of antigenic loss and thereby coming up with a false negative result, and the challenge of acquiring those 5 million cells, ending up with debris. So those are some technical challenges.
Correct.
And how
Now,
to answer them.
That's a point we need to address. So 4 hours versus, beyond that. So most of us are doing by flow, and the chance of losing that viable plasma cell within that 4 hours is very high, and therefore we end up having a false negative, MRD.
I think it's a problem, and especially when the temperatures are high, the cells are not kept at the 24 degrees or thereabouts. I think there would be loss, and you going to get a little bit different, and that's where NGS may end up having a thing. I don't know what's the practical answer in this Indian setting where how the transfer is
Any
done.
suggestions from your side?
Correct.
Okay, it is only a CD138 downregulation which happens because of the time. Okay. So quickly going to a few more.
Also, I would like to add that it is preferable that heparin sample is not used because that also leads to down-regulation of the CD138.
Okay. So what's the solution to that? The slides are not moving. Sorry.
For an EDTA sample in that regard.
Sorry.
EDTA.
EDTA sample.
And for hemodilution, again, the quantity is very important, and I think we can take into account the NPCI which Dr. Ritu Gupta ma'am talked about. So that was a very good idea to correlate the abnormal plasma cell with the denominator of total plasma cell rather than the So the abnormal plasma cell to be correlated or with the denominator of total plasma cell rather than total events, viable events.
So does that mean that if we were to send samples outside, we would use an EDTA and an heparin and send both?
No, we should not collect it. Even if you look at the flow cytometric guidelines of ICMR, they suggest if you are keeping the sample for 24 to 48 hours, 72 hours, maximum time is 72 hours. If you're going to keep the sample, you should collect it in EDTA.
Okay. So that's a take home then. Take it in EDTA first, 2 ml in EDTA. Yeah. So this the timing of samples is the other one. So you talked about a day 100 post transplant, and what was your suggestion?
When we are suspecting complete response.
So that's at the time pre-transplant, that is, and before you go on to a maintenance strategy. Okay. Okay. So this we went through NGF, NGS. Nowadays it is not oligopeptide, it is oligonucleotide. It is so minimum number of plasma cells required at the baseline to detect a clone of myeloma.
So there is a clear-cut criteria of more than 5% of the that is followed, and this more than 5% should be of the recombined molecules, while the criteria for the complete complete number of cells, it is more than 1%. So there are defined criteria to pick up the dominant clone at the baseline.
So what should a clinician take home from that point of view?
So a baseline sample, if you're going for an NGS, is required, and for typing a dominant clone to
Okay,
be followed at the time of the MRD
So
assessment.
5% is what we need to take thinking. This also I will skip. Yeah, so this was the question I had. Can a clone be missed in NGS? Anybody who wants to talk about? Yeah.
Actually, it can be missed, especially if there is somatic mutations, or there is a minor clone which was not diagnosed at the time of the baseline, which later on becomes the dominant part of the relapse, or there is a clonal evolution. Then it can. There are chances that NGS misses it.
So anything to do about that part? What she mentioned.
So I think there are 5 to 7% of the patients where the clone is not identified. They have more technical reason, mainly PCR-based problems. But otherwise, I think once the clone is identified, the primary sequence remains there. A long time ago, we had worked. It's not published, but occasionally there are more than one clone present. Actually, there were more than 2% patients have second clone. Still a myeloma related, and there's a whole science behind it. The clone evolution of the clone can happen, but the primary sequences are still there, and we do not re-identify clone. So once a primary clone idiotype is identified, in the subsequent MRD sample, we do not go back and look for as the new clone evolved, as long as the primary sequence within a mutation or two, and there is a, depending upon the complexity of the PCR, how much discrepancy is allowed. Usually discrepancy of 1 base pair or 2 base pair would be allowed in that case, and that will still identify the primary myeloma clone, which we all utilize. So clone can be missed in theoretical sense. Practically, once the primary clone is identified, that would be used all throughout, and that would be reasonably standard.
Sir, I think one point regarding NGS is that presently NGS is available in India, Chronoseq is available, but cost-wise that is like 20 times higher than your routine flow costs. So
how much is it available for?
It's about 2 point something lakhs is what I was told.
So which means we have
I'm not
to
sure
do
it's a one sample or two samples.
that's what I wanted to know.
I
So
didn't
is
ask-
anybody in the audience doing an NGS based MRD in India? So all of us are doing an NGF. Is
So
the
the
key
first
here.
question should be, is everyone in the audience doing MRD in India?
Correct. So let me ask that question, apart from the panelists, how many of you are doing MRD outside of a clinical trial?
Outside of a research institute?
Yeah. So
no AIMS, PGI?
Okay, so Arun, can you just tell me what decision making would you do based on the MRD?
So like if we have a transplant eligible patient, I would say, so when we do a pre-transplant assessment, that MRD assessment is done as a part of prognosis 1. When you do a day 100 MRD assessment, which is both the medullary compartment and extramedullary compartment, we do decide on consolidation strategies based on that as well. And when we, in a transplant ineligible patient, when we move on to a maintenance strategy, just to understand how accurately or how rigorously we should follow up the patient and prognosticate, we do an MRD assessment before shifting a transplant ineligible patient from induction to maintenance, and we'll be to decide on the maintenance strategy as well.
Sure. So pre-transplant, when you do post-transplant consolidation is based on that, and plus when you go on induction followed by a maintenance, would you want to do that? That's exactly what they are trying to address in that trial which you are doing, right? So in your clinical practice also, sir, would you use the same thing? The strategy which you mentioned, in the sense clinical utilization of the MRD information.
Yeah, in the clinical practice, we have number of myeloma physicians in our group, and each one has their own ideas and own styles of following it. And so, but in general, yes, there's some level of its utilization for consolidation, maintenance, the length of maintenance, and when to probably do more than what we normally do.
So for both de-escalation and escalation, you would use that. Okay. So, but then there is opposing views from Mayo Clinic. They have, up to date. Dr. Vincent has written there. He's not here, saying that outside of clinical trial, MRD is not used. Right?
Yeah, it's easy to contradict him when he's not here, but I would use it. I had a slide that I took out, actually sentence from my slide, which is that we have such a tremendous amount of data on MRD, and as I said, from every which way we look at it, that at this point to deny our patient the benefit that MRD provide is not right.
Sure.
I think there is enough data, and we don't want to change the treatment. Because MRD is positive or negative, we don't want to make a dramatic difference. For example, this patient MRD negative, so I don't not do transplant. We need a little bit more data. So those kind of decisions we have to be careful with. But there are many other things that we have talked about yesterday and today that can be influenced by whether patients are positive or negative, and I think we should consider those.
So, however, that has not yet come into the INWG guidelines of therapy, right?
Yeah, it will come in
sure.
a couple of years.
Sure, Dr.
Currently, I agree with him, MRD right now, not outside a clinical trial. Yes, for prognosis, it will help, but right now we do not have a lot of data to escalate, de-escalate. So right now I think we are still evolving, and we have different...
So we are evolving for the Indian data if you want to, but there is enough US data.
No, but we are not changing therapy. So as a clinician, you and
we are varied
interested.
in this.
Yeah.
There are some people do change, some people do not change
But
right
still
now.
we don't have hardcore data
Absolutely.
to support. Suppose today I'm changing this treatment based on the MRD, patient will say where is the data. So we are going as a clinical judgment. So right now in my practice, I'm learning, but I'm not willing to change
All
therapy.
of us can agree to disagree.
Yes.
So I think to her point, which is correct, that the data doesn't exist, that if based on MRD you did not change the treatment, it's not right, it's not ethical, it's not correct. So I think at this point we are at a point where number of people would think I would change, and those who would think I don't want to change, I think they're both appropriate at the moment. Very soon when the data comes, even then, so for example the French data comes and it says that if you are MRD negative, transplant is not as necessary. It's not going to still set a standard where now if your patient is MRD negative, you cannot do transplant. You can still do transplant and justify it quite often. So I think we are at a time where those who do or do not use it, they are both in the right, based on their own conviction, on patient population, all various features.
Would you? In leukemia, we have established AML, ALL, so we know. But here, I think we are still evolving.
Still evolving.
So, Joseph, can I try and put it into
Yes,
perspective?
yes.
So, where we were with ALL and AML 3 or 5 years back,
We are on the same
we
spot.
are in myeloma at that point. So, we have that learning curve. At the moment, the data is very tantalizing, but once we have a little more data and once we have it into the guidelines, and guidelines would mean that a lot of very smart people have looked at it from a lot of angles.
Sure.
Then it would become standard of care and clinicians would start to use it every day and offer it to their patients.
So would you use NGS, put NGS and NGF in the same platform in terms of interpretation?
Yeah, absolutely.
You would.
Absolutely.
Okay.
I think that's what even the
Sure.
FDA is convinced about. It's not the method, it's the depth that matters.
So maybe I think this is from the other data. I would not do much, and I would just ask maybe last question and we'll wind up. From the PET MRI point of view, would you want to use an imaging technology as an MRD for treatment decision?
So considering the availability cost which has been discussed, the technical challenges both with NGF at the moment as well as NGS, PET seems to be a reasonable option in clinical practice at the moment if we have to make a clinical decision.
So, I mean, first question is, would you want an MRD as an endpoint in the therapy paradigm?
So I would probably wait for more data.
You would not use. Okay, anybody using PET as an MRD? Okay, Arun again. Okay.
Sir, myeloma is a multifocal disease. It has patchy involvement. So unless you assess both the compartments, and marrow is just, we just use a bone marrow biopsy needle to screen the whole body as such. So it's a very, very, I would say, surrogate marker. So you need a cross-sectional imaging like PET, a functional imaging like PET. I'm not talking about the PET MR. I'm talking about the PET gives a broader view of the entire.
You would use it. Would you use
it.
both together? Or
Yes, I would use both, sir.
Dr. Nupur, what is your decision making based on imaging?
So I think imaging, and I think we were just talking about this, if if your patient has been on maintenance, say, for a very long time, and you want to ask the question, can I stop treatment in somebody? If you have a completely negative PET and you're MRD negative, you're going to feel more comfortable. If you see that the PET is still positive in that patient, whatever the MRD status is, I wouldn't be comfortable stopping maintenance. So it does help. I think PET right now is a prognostic tool. It adds to the MRD testing, and it adds more so because of what he just pointed out, that marrow-based disease depends on where you go in. You might miss other focal disease, and PET is a better surrogate of all of that.
Would you weigh MRD by NGS positive, PET negative, and vice versa the same way?
So again, if they are NGS positive on MRD testing, will I stop
PET negative.
treating?
PET negative.
And PET negative, the answer is I'd be less comfortable stopping that patient.
Vice versa?
I'd want to continue. Vice versa, if they are MRD negative and PET negative,
PET positive.
then not at all.
Not
That's
at all.
even worse.
So that is a worse off than the other one. Okay.
This is the example where MRD can be used for decision making.
Yes.
It's more to withdraw, not to add. But this is where I would use MRD or one would use MRD.
Sure. Thank you so much. Thank you all the panelists.
Thank you, Dr. Joseph and the panelists. Our last session to wind up day 2 of the conference is a talk on CAR T-cell therapy for multiple myeloma by Dr. Nupur.
Just would like to request all the members of the audience that after this talk, we've all been talking about the big M of hematology, which is myeloma. We have lined up a cultural music program, the other M, along with dinner at the amphitheater. So please join us for the dinner and the musical program. The amphitheater is behind the main auditorium, so you could just join us. It's 200 meters from here. Thank you. Also forgot to mention that one of the members of the organizing committee is going to be putting in a special performance during it. It's a big surprise, but one of the members of the organizing committee is going to be performing.
And after he introduces, we will connect this back. Is this the one? Okay. Click in the connect. Okay. This is HDMI. It's connected, sir. Hello, good evening. Firstly, let me thank the organizers, Dr. Hari Menon, Dr. Pankaj Malhotra, Dr. Uday Yanagmandra and the Image team for giving us this opportunity. So a warm welcome to Immunil Dinner Symposium. It has been a very exciting last 48 hours. Certainly, I've attended some of the sessions. It's been a huge learning curve, and there were a lot of interesting things that have been discussed today. So before I introduce our guest speaker, let me just take you through, in terms of the context, what we are going to discuss. So let me just tell you about Immunil. Immunil is an Indian startup. It is led by Indians and headquartered in India. It is founded by Padma Bhushan Kiran Majumdar-Shaw, Padma Shri Siddharth Mukherjee, Kush Parmar, and our CEO is Arun Anand. It is based on Atmanirbhar Bharat, Make in India principle. So this is a glimpse of Immunil's facilities. As you can see, we've got excellent state-of-the-art quality control labs, R&D labs, and manufacturing hubs, which can make state-of-the-art products which are fit of world standard. In terms of CAR T, as you are all aware, there are about 6 approved CAR T therapies in the US, EU up till now. 4 are targeting CD19 and 2 are targeting BCMA. In terms of multiple myeloma, we're talking about ID-Captogen and Cilta-Captogen. And certainly in terms of the CD19, we are aware about the 4 approved treatments. But I would also like to point out about ARI-0001, which is approved in Spain for hospital use. As you're all aware, there's a huge unmet need for B-cell malignancies, including ALL, BNHL, and multiple myeloma. Immunil has presented early data for Warnim-Captogen autoleucel. It is a CD19 CAR T-cell therapy, and the early data was presented at ASH 2022. There were 2 posters. One was looking at the pharmacokinetics, which is the response, peak, and persistence of volume captogen, and the clinical data was also presented for interim analysis. So these two posters are available on ASH Abstract website. These are in the public domain, and I'll just share you the brief overview in terms of the results. So the ORR at day 90 was 77.7%, which is in keeping with other approved therapies. Also, the ORR at day 28 was 80%, and I'd like to highlight that in the ALL MRD evaluable population, it was 100%. The PFS, duration of response and overall response, is not reached up till now. In terms of CRS, grade 4 was 10% and grade 1 was 70%, and the safety features are comparable or better than the approved CAR-T therapies. In terms of tocilizumab use, it was 60%. Now coming to the myeloma, as we are all aware, there's a huge unmet need. And these are the two landmark papers which you often compare as for the comparator in terms of hypothesis, 33.1% ORR and 31.7% Kumar et al. And Mammoth study. And we know the data from ID Captogen, which improved from 32 to 80%. And with that, I would like to introduce Dr. Nupur Raja, who has already been with us for last 2 days, and we have certainly learned a lot. And Nupur, obviously head at Center for Multiple Myeloma, would like to hear from clinical trials in terms of CAR T-cell therapy in myeloma. Nupur, over to you. Thank you. Just change the slide deck.
Great. Thank you so much, Anil. And thank you to Immunil. So this is, obviously, it's a great pleasure for me to give this talk specifically now that we actually are not just going to talk about the future, but you're going to have CAR T cells in India. So to me, one thing which has been really incredibly important is democratizing treatments that we have in some of the centers in the US. If we can bring them home, if we can give access to patients all over the globe, it's really meaningful. So I'm just going to go over data, and then I think we'll spend more time chatting about CAR T cell therapy in myeloma. Here are my disclosures. I do sit on the scientific advisory board for Immunil as part of a disclosure for this. And just to set the stage here, chimeric antigen receptor T cell technology has really transformed what we do for heme malignancies. CARs, these are engineered T cells. We take out lymphocytes from patients, and we then insert a transmembrane receptor which is able to go and identify the tumor of interest. And as of right now, what we have is the second generation CARs is what we are looking at. Most of them have an intracellular CD3 zeta chain which activates the T cells, and then you have a co-stimulatory domain which causes proliferation and expansion of these T cells. And most of what we have, at least in the context of myeloma, is the 4-1BB co-stimulatory domain. We first started using CAR T cells now about 5 or 6 years back in myeloma, and I remember we did the first in human study with using an anti-BCMA CAR T cell, now known as idacaptogene viclucel or ida-cel. And honestly, when I first started doing this, I was quite skeptical, because using a modality which wakes up your immune system in end-stage myeloma, and to see that work to me would have been a big surprise. What was really striking, though, was we saw an incredibly high response rates in these very heavily pretreated patients. We talked about MRD earlier on, and what was seen with CAR T cells is patients with packed marrows on day 14 had complete clearing of plasma cells from within their marrow. And if you look at the PET scans, as can be seen in this one example, by 6 months there was complete clearing and PET negativity in patients with extramedullary disease, which all of us know is patients who have received cell going way beyond 2 and 3 years, remaining in a stringent CR and remaining MRD negative. We have other studies that we're doing in Boston. This is an Arcelex CAR T cell, CAR T ddBCMA. It is a novel computationally designed synthetic protein binding domain. It increases the stability and binds BCMA better. I will tell you that we finished phase 1 part of the study. It's just gone into the phase 2 study, and the data looks very similar to what you see with cilta-cel, long, durable, lasting responses, and whether this binding domain is making a difference, we don't know. BCMA loss could be or downregulation could be one of the mechanisms of resistance. What we do have is drug products like gamma secretase inhibitors, which increase BCMA expression. This has been used in Seattle, and there is data using a gamma secretase inhibitor with a BCMA CAR T cell. The one thing we see is BCMA expression going up on the tumor cell. The downside of this is, although you're seeing responses with the CAR T cells, we are seeing a little increase in neurotoxicity, and I think we need to follow up on this a little bit more. Nikhil Munshi in his lab has shown very nicely in a subset of patients, you don't just get a downregulation of BCMA, but you get a total BCMA loss, a biallelic loss of BCMA. That happens in the minority of patients. And if that happens, how do you overcome that? Well, you overcome that by dual targeting strategies, and there are already CAR T cells targeting CD19 and BCMA, or CD38 and BCMA, to overcome that complete loss of BCMA. And finally, we have other targets, and this is an ongoing study which is happening at Dana-Farber. This is the CAR H109, or CAR T cell which is targeting the G protein coupled receptor 5D. And this trial is an investigator-initiated trial, and it had half the patients who had received a prior BCMA CAR, and yet you're seeing very high response rates. So failure after one BCMA, there's still hope and there's life, and you can look at alternate targets, and the response rates here are pretty high, close to about 70% or so. And obviously, because all of us have been trained and we've talked a lot about the microenvironment, there's a lot of opportunities, at least in the myeloma space, to go into combination strategies with CAR T cells so that we can attack some of the negative impact that the microenvironment might have on CAR T cells. There's early phase trials which are already ongoing, even as early as newly diagnosed myeloma, and some of these trials which I've highlighted here are happening in earlier lines of treatment, that is at first relapse or after 2 to 3 lines of treatment. So I do think for the future, you know, we are going to have CARs which could be off the shelf, could be dual targeting CARs, and as of right now, all we are using is a second generation CARs. So there's a lot of room for improvement. This is just a platform, and the future is going to allow us to modify these T cells and use them to try and improve upon the efficacy of these CAR T cells. So currently, I think we have these CAR T cells. We also, at least in the United States, have our first bispecific T cell engager, which is approved, which is sort of the competition for CAR T cells right now. They're both very effective strategies. We've shown that BCMA is a good target, and in the future, what we would like to do, and we're just on the verge of opening a trial where we're doing CAR T cells followed by a stipulated time frame of a bispecific, and ultimately it would be our dream to try and bring these up front so that we get rid of this continuous therapy and maintenance therapy in patients with myeloma, hopefully at least in a subset of patients. So with that, I wanted to stop here, and I think we wanted to do more of a question answer thing. Anil, is that what? Okay.
Thank you, Nupur. I think that was a very informative session. You covered almost most of the CAR T in a very brief, last 15 minutes, and that was fabulous. You also covered ARI 0002H, and that is the one which Immunil, as you rightly said, is bringing to India pending regulatory approval. Whilst we are on myeloma, I have a few text messages from the audience on Varnim, Captagen, Autoleucel, and those who are more interested on the CD19 CAR-T can meet me or Ebu Ninan in the audience. So we are more than happy to give you more information on that. Let's move on to the next session in terms of a fireside chat. Nupur, in the last 2 days that you've been here, what's your take in terms of the myeloma world in India? What do you think is how would you describe it? I mean, we certainly saw a lot of data, isn't it? And some of it is really exciting and almost state of the art on the global level.
So I feel really bad that I missed yesterday. I just came this morning and I don't know how I'm still awake. Nikhil is looking at me. So I landed here at 3 a.m. and I've been going. I've been exceedingly impressed, and I will tell you I was so impressed by the poster session that we had to judge today, because that's what highlighted all the original research. And I was telling Nikhil a little while back, incredible work, and the enthusiasm, the rigor with the way this work has been done has been incredible. And the fact that you all are sitting here in a very focused myeloma meeting is telling in itself. So really great to have this kind of a focus meeting in the first place.
Thank you, Nupur. And I'm sure the entire audience agrees with you. It has been a fabulous 2 days. In terms of, as you can see from the approvals, we had ID Captagen approved in 21, and in 22 early we had Siltecaptagen. What do you think 2023 holds for the myeloma world? What do you think in terms from the clinical realm, in terms of CAR T cell therapy? Are you foreseeing anything which is advanced, which is in terms of approvals, or you think this is a year where most of the data will be consolidated and maybe there's a hiatus, there may be a few gaps before, let's say, GPRC comes on the market? I don't know. What's your take?
So I think what will happen, hopefully, is it'll come up in earlier lines of treatment. We already have the Karma 3 data, and that data will be presented at a meeting soon. And our hope is that the approval needs to not happen after 4 lines of treatment. That's too late. And, you know, we can ask Dr. Munshi here. We all struggle. We have long, long lists of patients, and we can get them on these drug products. And if we can open up the eligibility criteria, and Nikhil, I don't know if you want to comment on this, having them exposed to all of these and having those 4 lines of treatment makes it so hard for us to pay patients on.
Yes, Dr. Munshi, please.
Yeah,
please.
Thank you. That was a very nice talk, for covering all the current and the new. There's nothing old here. And you made a very important point. The approval right now is for the 4th line, and I think we all use all 4 drugs in the beginning, and there's nothing like 4th line anymore. So I think big advance for 2023 would be hopefully that we can use it earlier on. I think that would be important, not just for older drugs, but also for product that you are developing, that you can go straight, not as a 4th line approval, but earlier line of approval.
I'll hold that thought. I'll just come to that. But before we do that, the approved treatments, ID Captagen, there are vast parts of the developed world, for example, UK has no access because there is a logistical challenge with both ID Captagen and Siltecaptagen. Are there any learning points for cell and gene therapy companies like Immunil? What do you think in terms of meeting the demand? Because this, I've realized there's a official paper which said there's a 12-week waiting list. So what do you think, Dr. Munshi and Nupur? What do you think the companies are not getting it right or should get it right?
I think they are not getting right as far as the production capabilities are concerned. And I think it's a challenge. This is not a typical drug you put in a bottle. It requires a lot of setup on the company's side, so we would all understand that. But I think ramping it up, or alternatively more products are available so they can supplement each other and provide the needed supply of the drug, supply of the production.
So scaling up, it's a commercial logistical challenge before, the expectation is there. Nupur, you want to add anything?
No, I agree with Nikhil completely. I think scaling up, even if you scale up, this is not an off-the-shelf product, right? It is going to, and it's not just one piece which gets impacted. You have to have the vector, you have to have there's so many pieces.
But the CD19 seems to have, the team seems to have done it slightly better than the BCMA. I think the problem currently is with the BCMA, isn't it?
So because the demand for BCMA is way higher, and with CD19 you have several different drug products, and if you really look at the lymphoma world, the uptake of CD19, even in the United States, is not that high. And you cure half the patients with just the chemotherapy in lymphoma. With myeloma, you do not
incurable
cure
disease, yeah.
anybody, and everybody is a candidate for CAR T cells. So I do think, you know, people always, the first question they ask is, well, you look at the cell-to-cell data, how can anybody compete? Do you need more products? And you do need more products for exactly the same thing which Nikhil just said, because not one company is going to be able to keep up with the demand. You cannot be anything in terms of response. You have to be competitive, but the more you have in the playing field, one, it's going to bring costs down, and two, it's going to meet the demand, because our demand is always going to outgrow your production. The last thing I would say for Immunil, the learning curve here is, you know, start slow and don't ramp up too fast. Don't overpromise.
Meet the expectations.
Do not overpromise, which ended up what happened with.
And I guess
both.
that applies to any cell and gene therapy working in
Abs-
India, where there's
absolutely.
going to be expected high demand.
Yeah.
Coming to this India-specific question, now this is a real-world data. As you can see, in India, we rarely go beyond third line, fourth line, and the responses are almost in the range of 20% and beyond. In that setting, what do you think is the position of CAR T-cell therapy, especially with the kind of lines of treatment we showed, and comparing to what Dr. Munshi was saying, that we should use it upfront? Would you think that India would be a place where the uptake would be much faster?
Yeah.
Minusing the impact of the cost effectiveness, etc. Let's leave the cost aside. If you talk about access, availability, and affordability.
I think the major difference in India versus US, for example, is that not all the patients will have access to all the drugs. So in US, FDA could say that patients should be exposed to lenalidomide, bortezomib, and CD38 antibody. In India, not everybody would have CD38 antibody. It will be cheaper to go to CAR T than do this. So I think the patient population you target with previous exposure should not be 4 lines, and number 2 should not be on exposure to all the drugs. And I think those two will make it more easily acceptable, one versus another. And I think that would be important contribution, because those patients by definition would be earlier on compared to what the US population is.
Thank you. Nupur, do you want to?
I think completely agree with Nikhil. One other thing for the Indian population, you know, one of the things we saw with cilta-cel, for example, the high rate of delayed neurotoxicity was because of the very high disease burden. You see more of an HLH-like syndrome in those patients. You see that delayed neurotoxicity. So waiting for patients to have very rapidly progressive, high burden disease is not the place that I would start using CAR T cells, because you first have to get used to this, how to use them, and doing it maybe a little bit earlier where the disease is a little more stable would be the first few patients that I would consider.
Thank you, Nupur. Dr. Pankaj and Dr. Hari, do you have any comments on that? And of course, I invite anyone who wants to make a comment.
No, not really. But I just wanted to know, I mean, do you envisage a situation where CAR T-cell therapy would replace an autologous transplant?
Exactly. Thank you, Hari. You should be here.
So, Nupur, can I ask you a question here? So like, is the once the product becomes available to Indian oncologists and hematologists, do you need some special training or exposure, or if you're a trained chemotherapist, you can just give the agent?
Yeah, no, absolutely. I'll come to the tray. Let me just hurry. I absolutely think that this is a time to ask whether or not you can replace transplant. So that trial, there's Cartitude 6. cilta-cel is going to be compared to an
previous
auto
slide.
transplant. So that needs to happen, and we need to think about doing that for sure. To answer Hemant's question, very, very important. When we first started at MGH with CAR T cells, and the same thing Nikhil, when he started at Dana-Farber, it was not just teaching our oncology teams. We had to teach a whole bunch of other teams. So the emergency room had to know about cytokine release syndrome, had to know about neurotoxicity. We had neuro-oncology following our patients. We have infectious disease experts who kind of watch this. And obviously, whenever you do CAR T cells, they have to be a FACT accredited service center. So they were mostly transplant centers. But a lot of education went into this. We've gotten so used to it now, and we are so used to anticipating CRS. We have the tools, but that came with a learning curve. So when you start out here, I think training is incredibly important, and anticipating and expecting toxicities is incredibly important.
Thank you, Nupur. On that note, and Dr. Hemant, Immunil has a 6-module education program which is already rolled out for clinical trial sites, and in commercial qualification, education module is top on the priority. So coming to your institute, that will be also addressed.
Can I ask a question?
Sorry.
Yeah.
Oh yeah, please, sorry.
Okay, we've heard a little bit about Yescarta and Kivria coming with a pay for performance payment model. Do you think is that can be rolled out for myeloma as well in the ida-cel?
So, Kymriah had the only one which was pay for performance model, right? But ida-cel in the United States has a free drug access program. cilta-cel, as of right now, does not have any free drug access program. They're working on it, but for the uninsured patients or patients who are on Medicare and Mass Health in Massachusetts can only get ida-cel and not get cilta-cel. So for myeloma, they've not done that, but the hope is that at least they have free drug access. We do have out-of-spec programs. If the drug product is not completely per label, we're allowed to give them that drug product, and then it comes to us free from the drug company.
And this Kymriah program of that pay for performance, has it worked out and is it successful there?
So Kymriah is not being used as much because there are those two other CD19 CAR products, and they've taken on one from one is Yescarta and the other one is lysocaptogene. They've been used more, and exactly. But Kymriah, for whatever reason, Novartis is revamping their program again.
Dr. Pankaj, you had any questions?
So Nupur, can I ask one more
Sorry.
question? Like you were targeting the same antigen on the myeloma cell, and you are using basically the same T cells. And why are there so much difference in the efficacy and the toxicity amongst the product? So I kind of don't
Can I
understand
add to that
that.
this question, which is essentially Parkinsonism symptoms have been reported with cilta-captogen. Is it the camelid VHH antibody, because BCMA is expressed on basal ganglia, or do you think it's going to be something seen generic? Well, certainly in ID-captogen long-term safety, Parkinsonism hasn't been picked up at the level that we speak about in cilta-captogen. What's your take on that?
Yeah, so we more and more believe that this is an off-tumor, on-target toxicity, because BCMA is expressed in the basal ganglia, it's expressed in the caudate nucleus, and ultimately what it has been reported with ida-cel as well. So it's in their product label. I've actually seen a patient who developed Parkinsonian syndrome post-Abecma. And I think the difference is these are T cells from different patients. Not all T cells are the same, right? Everybody's T cells are different. And there's more and more data in the CAR T cell world where you're looking at the T cell phenotype, genotype, the function, and the quality of T cells does matter in terms of how they expand, how they persist, how they attach. one of the things with cilta-cel, maybe the biepitopic binding binds it even tighter, which is why you're seeing the higher response rate and the higher incidence of the neurotoxicity, and you're not seeing that same incidence with ide-cel.
Thank you, Nupur. Dr. Munshi, do you want to add anything on this? Thank you.
It explains the biology that it's the possibly tighter binding which leads to cilta-cel related. So not all products are going to have it, and not all products need to be put in the same box.
Thank you. Next slide, please. We'll cover in next 5 minutes, Hari, if you don't mind. I know we are running out of time. Very quickly, case study. This is a 57-year-old gentleman, very high risk, translocation 414, stage 3 ISS score, paraprotein is high, had VRD. What would you do for this gentleman? Consolidate with melphalan, or if it's in India and if it's allowed, BCMA CAR T-cell clinical trial? Okay, let's. Yes. Agree? Okay, okay. Now let's go next. Patient had a melphalan autologous transplant, went on to have lenalidomide maintenance, relapses, paraprotein is 2.1 gram. What would you do now? India specific daratumab uptake is pretty low because we don't have, yeah, it is expensive, and CD38 monoclonal, or would you consider BCMA? Sorry, do you want to?
As opposed to waiting for them to be exposed to everything. So if you can get CAR T cells at this point in time, that would be awesome.
Yeah, I mean, it would be, we are awaiting regulatory pending approval. We would expect it for any relapsed refractory myeloma. So, Dr.
So I
Munshi?
think, so there's a study ongoing also where post-transplant VGPR but not CR patients are eligible to get CAR T cell. So point being that post-transplant you want MRD negativity or at least a CR, and if they don't get it, so this patient, if post-transplant while on maintenance, and this particular study is before maintenance, at 3 months, it's VGPR, can get a CAR T cell.
So this is where we are heading in terms of CAR T versus autologous debate. I'm aware we are running out of time, so I'm going to quickly go to the case 2. Now this is a slightly elderly patient, 72-year-old, standard risk, paraprotein 2.7, had VRD, declined autologous. If a brave clinician wants to, I mean, 72 is not, I mean, I'm sure certain centers do offer it 72 as well, had first relapse after DVD remission for 12 months, then POMDX remission for 6 months. BCMA CAR T-cell therapy is available. What would be your option?
Would consider the BCMA CAR T cell.
Dr. Munshi?
I would definitely consider, except in US he may not be eligible yet, and that's the part of our problem. He has 3 drugs but only 3 lines. And we
In
need
India,
4
very
lines.
few people get beyond second line.
So that's why I think in developing it here, the algorithm has to be entirely different, not follow the US example, and something that is inbuilt to the Indian setting. And this patient should definitely get CAR T if I have an access to it.
This is where I want to come to in age, because this is where we are looking at 72. If you look at the ARI 000 data, the age range was 39 to 74. What is the oldest patient you have treated with ID Caprigen? I would ask these questions to both Dr. Munshi and
81.
81, yeah?
84.
84, wow.
So, Nupur, can I ask you a question? Like, in a situation like this, if you had the T-cell engaging monoclonal antibodies also available, and you've done the pivotal study with one of those, would you prefer that over a CAR T, or well, just a hypothetical discussion? We don't have data, we know that.
Yeah, so, we just have our first bispecific T-cell engager, which is available now, teclistamab, and operationalizing that has not been easy. So the difference is you don't have to wait the 4 to 6 weeks. So if somebody is progressing rapidly, then getting them in for teclistamab is easy because that's the approved bispecific T-cell engager. If your patient can wait though, because the problem with the bispecific T-cell engagers right now is it's continuous therapy. We start with weekly dosing. The first week, that they get the treatment, they're actually hospitalized for 7 to 8 days because we do not give them their step-up dosing and their week 1 dosing as an outpatient because of the same toxicities, neuro as well as CRS. So just to say that it's an off-the-shelf drug and that any practicing oncologist can give it to patients is not true. And at least the experience, I'd love to hear what Nikhil's, our experience at MGH with the first few commercial teclistamabs has not been great because our patients have had to stay in the hospital for a really long time.
Do you really foresee that there is any real competition between the bispecifics and CAR-T there?
Yeah, you might like my answer, but I don't think so. And to the point, if you look at all bispecific, any type we have, the response rate is around 60-65%. Almost all CAR T cell response is 90 to 100%. So there's a very clear difference. Number two, the depth. If you look at depth, 50 to 60% MRD negativity, 80% CR, nowhere near for bispecifics. So I think if you need to get a good response, deep response, and just one treatment, I think CAR-T has a leg up. It's more difficult to do it, but that's what it is. What's being done now is to get CAR-T first and then use bispecific as maintenance. And those studies just starting, they will be ramped up over time. So I think that's very important consideration. And what Nupur said, I entirely agree that it's not just like taking out of a bottle and giving. We have our current protocol for commercially is patients will be in the hospital for 7 days. It's partly suggested or not mandated, but suggested by FDA, so it's not as straightforward as it sounds. Once they're over the hump, then more regular oncologists would be able to do it, but not routinely, not in the beginning.
I know we are all looking forward to the dinner and activity that is going to have. Any last comments, Nupur, Dr. Munshi? Any?
One thing I'll just say, people balk at the cost of CAR T cells. The bispecifics, which we give either weekly or every other week, very expensive if you take into account that you're going to stay on it forever.
So
the other thing we have to think about is infections where you're constantly T-cell exhausting patients. And what we are seeing, and we will have a paper coming out on infectious prophylaxis on bispecifics, we're seeing weird infections which we had never seen before, almost like the allogenic days. So I think there's a lot more to learn about bispecifics.
What I hear is that the bispecifics are probably a standby or a backup to CAR-T. I think that's very clear. So with that, thank you very much, Dr. Nupur, Dr. Munshi, and the organizing committee, Dr. Hari, Pankaj, Hemant, and the rest of the team, image team. Thank you very much, and thank you, Nupur. Thank you.
As we bring this day to a close, I call upon Dr. Hari Menon to give the vote of thanks.
Yeah. So we come to the end of the second day's program, and it's time for some mood lightening. And I would invite you all to come to the amphitheater, which is just around the corner. It's about 100 meters from here, next to the main auditorium. You just have to take the curve of the auditorium, and you'll be at the amphitheater. So invite you for dinner over there, which has been organized over there. And I thank all of you to stay back and be there as enthusiastic as ever for this meeting. And I also would look forward to the same enthusiasm tomorrow too. We have lined up a concluding day with a whole load of new talks. And so good evening, and join us for dinner. Yes, thank you.
I'll
I'll conduct, sir. No issue. Thank you so much.
Thank you, sir.